it is associated with lower empathy, concern, and more difficulty recognizing negative emotions, among others. So we also see higher exposure to violence linked to increased generosity. This is a bit tricky in a way that even among all the literature, we could see that half of the studies were documenting that exposure to violence increases altruism, while the other half documents that this reduces altruism. And in our study, as you could see from the results, higher the frequency of exposure to violence was also increased generosity, but reduced the emotional reward that is that comes upon the child after giving. You know, normally when somebody gives more, they're supposed to have a good feeling, and that had been evidenced in science. But for children who are exposed to violence, the more they are altruistic, the more they actually have negative feeling after giving, which would also kind of, not for this study, but kind of explain the relationship that we see between exposure to violence and depression. On distributive justice, the higher exposure was associated with fair sharing in a situation whether there was wealth differences, but not when decisions were based on merit and health needs. As I have explained, you know, in the distributive, we had scenarios where I have two hypothetical children. One is wealthy, the other is poor. We had another one where the one is sick, the other one is healthy, the other one is hardworking, while the other is not hardworking or lazy, to put it so. And we could see that the developmental shift that children normally have from equality-based to equity-based, that there is no fair sharing for those other scenarios, whether it is merit or health related, only for sharing when it is poor and health. We also have another interesting finding here. As you assume, but also evidenced by science, it is normally known that altruism, which is giving more or selfless, is associated to more warm glow feeling, which is a positive feeling that people have after giving. But there is a moderating effect of exposure to violence, as you do see that the higher frequency of exposure to violence, when people give more, they tend to have negative feeling. So it does not affect children's giving ability. They will continue giving, but it is emotionally costly in a way that it actually leads to poor warm glow after sharing. It is also true, this is also a new finding in our study, which is not have been evidenced anywhere, because normally there is a positive relationship between empathy and altruism. So the more I am empathic or able to understand others' feelings, the more I am to be altruistic towards them. So the more I am to give to those people when I have empathy to them. But with frequency of exposure, as you do see in this figure, this direction changes. So the more somebody is empathic, the more they will tend to not be altruistic. So this is another interesting finding, which is a novel finding. So we also attempted to see whether we have mediation effect, whether we could be able to explain the relationship between exposure to violence on one hand and mental health on the other hand through empathy, concern, as I've seen in the previous study. And you would see that the mediation, although the direct mediation stays, but there is partial mediation effect of empathy, concern. The effect size are modest, but still we see that the relationship and the mediation effect is there. which is similar also, the similar trend was observed in altruism, which is that generous ability of the child. After that, after seeing these trends, we aimed to see if there will be parallel mediation effect, since more empathy and altruism are more or less related in the sphere of moral development. We want to see if there will be parallel mediation effect of altruism and empathy. The only change is that once you include altruism, you see that the mediation effect of empathy concern to the depressive symptoms, the effect is no longer strong or significant, which explain the relational effect that is there between altruism and empathy in exposure to violence. So I'm saving minutes for you. So in the discussion section where I think I've already explained exactly what we studied, but we could see that this association has potential psychological and psychiatric impact, because if children are exposed to violence, has poor mental health conditions, and we could explain partially that in the sphere of empathy and prosocial development, and we could document that these are not isolated field, if I may say, that these all happen within the developing child. So we could be able to actually look at interventions that would be able to help us prevent development of mental health conditions. So we've seen that children more frequently exposed to violence show negative relation to empathy, which suggests that the repeated exposure to violence diminishes children's ability to emphasize with other children. It reduces the warm glow effect or the happy effect that people get from giving. So, and we've also listed some of the novel findings which are not there in the science sphere, which we know the relational effect between empathy and prosocial behavior, but that changes as the higher frequency of exposure to violence increases. So I thank you very much for your attention. So I have here Prof. Stefan Jansen, who is the head of mental health and behavior research group, which I'm based, and here in the audience, and the local committee president of this conference, but also who was my supervisor in this interesting study. Thank you very much.
Thank you very much, thank you very much for your presentation. My background is I'm an educator, and when I'm in my school, we have something called trauma-informed practice in what we do, in what we teach, because we know that if we can implement, if we can adopt trauma-informed practices in our classrooms, in the way we teach, then every kid will profit, every kid will benefit from that. So it's a very timely presentation, and I think a presentation that most of the schools in this country and beyond would benefit from knowing that. I'm going to switch to Kinyarwanda because we have an audience that's fully Rwandan. Could you just in 2 minutes tell us what your research was about in Kinyarwanda, if it's possible?
Okay. Murakoze cyane.
There you go.
How did you know that I'm Rwandan?
I don't know, I just assumed.
Okay, thank you very much. So, as he asked me, I'm gonna, in a few minutes, 2 minutes maximum, try to explain to the community here in Kinyarwanda, if you allow me. Buno bushakashatsi twabukoze mu gihugu cya Repubulika Iharanira Demokarasi ya Kongo mu bana bafite imyaka hagati y'6 kugeza ku 10. Icyo twarebaga no kureba ingaruka zo guhura na violence cyangwa se izi ntambara ku buzima bwo mu mutwe bw'abana, cyane cyane tureba hari ubushobozi ubundi abana bagira bwo kubasha kureba umuntu ukabasha kumenya niba arimo ariyumva neza cyangwa ari kwiyumva nabi, afite amarangamutima meza cyangwa mabi. Hari ubushobozi bwo kubasha kwishyira mu mwanya wa mwana mugenzi wawe. Hari ubushobozi bwo gutanga, ndetse wamara no gutanga ukishimira ko watanze. Hakaba rero n'ubuzima bwo mu mutwe, tuza agahinda gasaze. Ntago abana bo bararwara, bagira ibibazo by'ubuzima bwo mu mutwe. Hakaba ndetse no muri rusange uko umwana abaho ubuzima bwe bwiza bwo mu mutwe. Rero twagira ngo turebe niba bino bintu abana banyuramo mu buzima bwa buri munsi bigira ingaruka kuri bwa buzima bwo mu mutwe bwabo, bigira ingaruka kuri bwa bushobozi bwabo mu busanzwe mu buryo abana n'abandi bana, kubasha kumva nyine ukundi mwana arimo ariyumva, kwishyira mu mwanya wiwe. Ibintu rero by'ingenzi twabonyemo nuko nkuko n'ubundi bushakashatsi bwagiye bigaragaza, guhura na bino bibazo bya violence, by'intambara, byo kubona abantu bagize ibibazo mu muhanda, bigira ingaruka mbi ku buzima bwabo bwo mu mutwe, kandi bikanagira n'ingaruka mbi kuri bwa bushobozi bwabo bwo kubona nyine umwana. Ugasanga aho kugira ngo abone yuko umuntu afite ikibazo, ari kumubona nyine nk'aho ari bisanzwe, kubera ko mu mutwe wiwe guhora ukomeza ubona ibibazo bigira ingaruka kumenyera ko abantu bose ari nk'aho ariko babayeho.
Urakoze cyane. Urakoze cyane. N'ikindi ni ukuvuga ngo iyo izo ngaruka ibibazo abana bacamo ahanini ntabwo biba biturutse ku ntambara gusa. Hari ibindi, hari umwana ushobora kuba ari muri accident y'imodokari bigamutera ihungabana. Hari umwana ababyeyi bashobora gutandukana bikamutera ihungabana. Urumva, eske mufite gahunda yo gusakaza iyi research ubushakashatsi bwanyu mu bigo by'amashuri?
Ntabwo navuga ko twarabitekereje, gusa ni igitekerezo cyiza, kubera yuko abana bari no myaka n'undi bari mu mashuri, kandi ni byiza ko yaba abarezi n'ababyeyi babimenya. Numva ari igitekerezo cyiza, ni ikintu umuntu yarebaho. Ntabwo twarabitekereje kubikora gutyo, ariko numva ari ikintu cyiza umuntu yakora. Urakoze.
Sawa, urakoze. Mumushimire. Thank you very much. Up next we have Professor Najib. Lectern, or would you like to lectern here, or are you happy to talk just freestanding?
Yes, sir.
You like it? Okay.
So thank you all for presence here, and it's really my great pleasure to talk about the barriers to healthcare access among patients with epilepsy in Africa and developing countries. So first of all, as you know, you have to see that I think we have a lot of resources in Africa. I think we have more than 1.3 billion inhabitants. We have a lot of resources, natural resources. I think we have skilled persons. So that's why I think it's very unfortunate to find that we have still the biggest barrier in the world in managing epilepsy and other chronic disorders. So you can see also that the GDP in Africa is not one of the highest compared to United States, to China, to even Middle East and other parts of the world. And also the majority of developing countries after priorities are keeping epilepsy far behind. I think that's why we have around 50 million inhabitants with epilepsy in Africa. Majority are in Africa, and you can see that we have a lot of very bad markers about managing epilepsy in our dear continent. So here just some studies. We have also same thing, I think, in Mena region. So I think that's the reason why we focused on calling these conferences Africa and Mena Brain Week, because I think Africa and Mena is north of Africa and Middle East. Also, even if we have very rich countries like Saudi Arabia, Qatar, Arab Emirates, but all the other countries I think are in the same level like Africa. So I think we have the same destiny, we can say. So that's why we are in the same field and with same barriers, the same problems. So the challenges, I listed the 9 challenges on this slide. As you can see, we have the first biggest problem is lack of specialists. I think in Africa, we have one of the lowest number of specialists all over the world, except very few countries like Egypt, when we have around 4,000. We have 6 countries up to now without any single neurologist. So I think that's a huge problem, and you cannot think to develop epilepsy surgery, to develop managing lots of disorders if you don't have any single neurologist to deal with those disorders. So we'll start with this first point. So that's paper that we published recently in 2022. It was not that easy, but I think that thanks to the collaboration with the African colleagues, more than 6 collaborators from different countries, and we had data from all African countries. And you can see that Egypt is the first leading country with around 3,000 at that time, 2022. Now there are around 3,500 neurologists. I think Egypt maybe has more than all the continent compared to the other countries, followed by Algeria, around 300 neurologists, then South Africa and Morocco, around 250, then Tunisia. And you can see that the majority of the other countries, they have less, between 10 and 30. Even the biggest countries like Nigeria, like DRC, like Ethiopia, you can see, and in blue. And unfortunately, as I mentioned, in green, you can see countries without any single neurologist. Of course, that was 2022. But, for example, Djibouti, they had 0 neurologists in 2022. Now they have 2 neurologists, hopefully, that we trained in the centers, for example, in Morocco, in Senegal, in Ivory Coast, in Egypt, South Africa. So I think that's the biggest challenge we face in Africa, the lack of human resources, especially the specialists. We have also done these researches. Just, I think also what is needed is just to have an idea about what is happening in our countries. I think all our experts, scientists, neurologists, we have first of all to start with epilepsy epidemiological studies. I think we calculated epilepsy prevalence in Morocco. It's around 2%, which is highest level. We have some African countries, by example, Burkina Faso. We have Professor Dabilgo here with us. Sometimes it's reaching 5%, like also in Cameroon, 5-6%. And even in some villages, we can have 20% of prevalence. Why? Because we have lots of infections, of etiologies that normally we should prevent, and we should battle against using very simple techniques and very simple tools. And also the other difficulty is also the unequal distribution. So just about the 250 neurologists we have, for example, in Morocco, you can find that the majority of them are located close to the capital, which is Rabat city here, and Casablanca, the economical city. So around half of them are located in this very small part of the country. Of course, it's nearly 20% of the population, but you can see that it's less than 5% of the whole country. After that, you can see that you have 35%, 32, so meaning that nearly 80% are located in north and east. And only you have less than 15 or 20%, for example, in my area in Marrakesh and also in South Morocco. So I think that's another huge problem. The second challenge we have is the low involvement of GPs, general practitioners. I think we have general practitioners, it's a shorter duration to train them than specialists. It's another issue. And also nurses, not only GPs, but also nurses. So here you can see by example, the involvement of general practitioners. Here you have comparison between many countries. For example, about nurses, I think nurses is a very important resource that you have in our continent, and our training is for 3 years. So I think we can train them, and we can educate them in epilepsy and also in telemedicine, and they can cover this gap of specialists. So that's a study done in 2024. So, for example, that's a very practical example of one primary healthcare facility that's in village in Morocco. I think it could be same difficulties that we have in all Africa. And you can see that you have a lot of patients waiting, and sometimes the GP has not the background, for example, to solve the neurological problems. So he had just to refer patients to the big centers. The other problem we have is, for example, automedication. I think that's also another problem, another challenge, another barrier we have to battle. And we have a lot of patients, sometimes they're just using some herbal medicine. I think that's also a big challenge we have. And Professor Suleimani last time discussed about the neurotoxicology. We have a lot of plants with high level of toxicity. And you can see here this paper published about barriers and facilitators to implementation of epilepsy self-management programs. This systematic review mentioning that we have a lot of difficulties to cover this gap. We have also the traditional practices. I think that these are usually represented in Africa. We have a lot of countries. I think epilepsy and the stigma we have. Patients sometimes are considered as contagious. And say in many countries in sub-Saharan Africa, nobody could touch patients with epilepsy. And sometimes we can put them in one isolated part and also cut some baobabs, for example, like in Senegal. So people think that all the maledictions are coming from God and coming through baobabs to the village if you have one patient with epilepsy. So you have to destroy all the trees, which is completely crazy ideas that we have to fight against. And here, for example, you have also in Morocco, we have a lot of traditional practices. So patients go to the mausolees and goes to use a lot of healing techniques. And sometimes this is a big issue of wasting time for patients with epilepsy and worsening the medical situation of patients. So these papers also have been published, and you can have access to that one, Epilepsy in Morocco, with a big paragraph about managing epilepsy and how to fight this problem. Another problem is the little interest of complementary and alternative medicine. I think complementary and alternative medicine is very useful, not only in epilepsy, but also in migraine, in strokes, in Alzheimer, Parkinson, and we have to use it. So that's also another paper published about complementary and alternative medicine in epilepsy in Mena region and also North Africa. And it's also highlighted the need of combining medical drugs in epilepsy and also complementary and alternative medicine. And also it's of very good efficacy. We have the sixth problem, it's the underuse of new technologies. Yesterday we discussed in the workshop about the use of new technologies, telemedicine, which is the solution to cover the gap of specialists. And you can see that, for example, in Morocco, initiated many programs since 2014, and we still are developing them in villages, in rural areas, in difficult access regions in Morocco. And it's sometimes very easy. You just need electricity, need internet connection, and you educate patients. For example, this group is from Safir region, which is 200 kilometers on the Atlantic Ocean. We went there for 2 or 3 times. We trained epilepsy nurses, we trained GPs, and especially member of Association of Epilepsy. And after that, they get trained, they get facilitating work for us. And after that, we can get in touch with them, consult patients. Whenever problem is easy to treat, to manage, we can send ordinance by WhatsApp or by email or any other tool. If the problem is difficult, by example, to do EEG, we can invite patients and we can give appointments, and patients come directly to the EEG department to have his EEG. So I think what you need, we don't need lots of expensive equipment, cameras and screens and so on. That's what we thought in the beginning. It's costing a lot of money. What you need is just your mobile phone with high internet connection, electricity, and you can connect with any part in your country or elsewhere. So we do also tele-education for patients. After developing these techniques with one city, one village, after that, with association with WhatsApp groups, you can get easily in touch with many, many other associations, and you can spread your experience to other parts. And as you know, what we call the bouche à oreille in French, from ear to mouth to ear, patients discuss inside their group, their social media, and after that, they can get in touch with you. And also Chantal, we can get in touch many occasions with patients from Rwanda, and also Dr. Arthur, we collaborated many times. I came in 2022. We had one session of training nurses I will discuss about it. And I think it's very, very useful. You can see here, it's not Pakistan, but it's Morocco in the mountains with the snow. So we have a lot of experience. Of course, it's very nice for tourism, but sometimes when it's snowing, it's very, very difficult of access to come to Marrakesh. So for those patients living in the mountains, when they have electricity, now 98% of people have it in the mountains, you can get access with those patients and solve the problem. So, for example, that's a very good experience. We started 2023 with all the region of Marrakesh, and we have a lot of villages, high mountains, and now the problem is solved by telemedicine. Here you see one of our experiences with the nurse. I think that's a very skilled nurse. We trained him. He was general nurse in one hospital 100 kilometers far in the mountains. And after that, he is solving problem for us and avoiding to transfer patients to our city. And we are just connecting with him. We are seeing the patients. We are here in the hospital of Marrakesh, and you see patients are in the other village. And even we have students with us. We are training students how to use telemedicine techniques. So another way, also we trained even these nurses how to examine patients. We just guide them, do this, do that, ask patients to walk, and everything we can reproduce it due to these trained nurses. And after that, even these nurses have trained other nurses. I think that's very useful when what we call training the trainers. You train one nurse, and after that you have other nurses trained. And I think that's spreading your experience in solving the problems. So that's the experience we have with Mauritania since 2012, 18, with Rwanda 2019. You see one of the experiences. And as I said, every experience, we are sharing it with our students to get them trained in telemedicine and to learn what we are doing and how to be informed, how to use telemedicine in the future for when they are practicing. Of course, we are also sharing our experience with many colleagues in Africa. That's one of our Zoom experiences with the Epilepsy Alliance Africa, with Chantal from Rwanda, with Dr. David from Zimbabwe, Dr. Samuel Shigamba from Malawi, many, many others. We have 35 countries in Africa, Burkina Faso, Senegal, and others. And I think the use of kits in telemedicine is very useful. I think with the new technologies now, we have one small bag with a lot of equipments, and the nurse that you trained in telemedicine in any area in your country or in Africa, you can just educate him how to use oximetry, how to use EKG, EEG, tensiometer, and everything, and they can just put it in the patients far away from you, and you can have all the data on the right time, and you can solve the problems. So, by example, that was in one company from India. Indians are the most skilled people in using new technologies, new kits for telemedicine. And we've been connecting with many, many others in Morocco and also in Africa. So, for example, here you can see how we can control blood pressure, oxygen, EKG, and so on. All the equipments that we can use for telemedicine. Really, it's very, very easy. And we have to demystify telemedicine because, of course, in the beginning, you see that it's complicated. It's like science fiction. But after getting used to that, you can see that it's becoming easy as we are learning. Brain is some dynamic organ, learning every time and improving, and you can get it easier done in the next occasions. So here we can also show you how we use this in our groups. Of course, we are training with many, many collaborators from Morocco, from India, in Africa, and so on. And also we started collaborating with many African countries. By example, this is DRC. So this doctor is a GP, Dr. Prince, really very clever guy. And we met him in this meeting with Epilepsy Alliance Africa. And after that, we trained them. So these are only GPs. And after that, we trained them to manage epilepsy, to manage clinical disorders. In DRC, so there are only 20 neurologists. You can see here in the country, so the majority are in Kinshasa, the capital, but Lumumbashi, we have only one specialist, one neurologist. And all the other GPs have been trained, and now they become skilled in managing, in collaborating by telemedicine, and in solving problems for their patients with epilepsy. We have to think for telemedicine to data centers. I think the majority of us are using Zoom or Teams or WhatsApp or I don't know, but all these tools are originated from United States, from UK, but I think we have to think to our own data centers. For example, in Morocco, that's one data center that has been created in Morocco. So we have to store our data inside the country. I think that's the ethical point of view. You have not to keep your data from Rwanda in United States, because all your informations will go and could be used there. So I think that's a big issue. We have to think about that. We have also the artificial intelligence and epilepsy. I think when we develop telemedicine, we can end with the artificial intelligence. We have a lot of developments that we can use. I think it's combining informations and the tools of artificial intelligence, AI, could even learn and could solve new problems that you have never faced before, even in neuroradiology, in epilepsy, and so on. So we have lack of continuing education, seventh problem. I think that's also very useful. Now we are very happy in this very nice university, and we have a lot of students, but I think we have to spread our educating programs to all of you. By example, as I told you about educating nurses, that's very, very, very useful program that we started many years ago in 2022. We did the first session in Kigali, Rwanda. So it was in 2022 with nurses. It was English session. We did another session in Morocco. It was French session. After that, we had many other sessions. And you can see that we have very, very dynamic teams. For example, in Cameroon, Professor Gams Massi, he's a neurologist, but we have nurses dedicated for telemedicine. We have also this team from Malawi. Mr. Samuel Shigamba, he's not a nurse, he's patient with epilepsy, president of an association, and he trained a group of patients and mother of patients to our association. I think I will be on time, don't worry, my friend. Just so that the session of Rwanda Kigali in 2022, of course, we've been educating. We had Dr. Arthur with us, Chantal, and all the team. And you see here, we did even some practical sessions of how to do EEG. First time, so for me, it's second time today. That's the second session we had in Morocco. And of course, that's another session with the Niger team from the capital of Niger with Professor Fatimata, the head of department, and many, many nurses. And we have also to use people from IT. The second point is we have to share our informations, and I encourage you to see that journal, which is African and Middle East journal. It's for free for epilepsy, the first specialized journal in Africa. I think you can have access, just put A African and Middle East Epilepsy Journal, AMEEJ. We have few educational programs, congresses, webinars. I think we have to promote them. And also we have to sensitize patients. We have a lot of tools, some books, hand left, and some educational systems through website. For example, that's a very interesting small book that we organized in French and Arabic. So what are the practical counseling for epilepsy? You can find it on internet. So it's very easy and very practical. And you can see even, for example, what to do if you are witnessing a seizure, how to practice, how to put your patient on one side. The same leaflet, very practical one. Even International Bureau of Epilepsy asked us to share this book because it's in Arabic and French. A lot of counseling. We should not forget about media. It's very, very important. TV programs and radio spots and so on. So we have to be available to do it. For example, in Morocco, we have French and Arabic and Amazigh, which is native Moroccan. And we can respond to many, and a lot of people can follow these programs. Of course, we are sharing a lot of informations. Social media, it's very useful for free. You can go on Facebook, on WhatsApp, on Twitter, and so on. Lot of groups, but you have to dedicate time for us. We have also Epilepsy Alliance Africa, helping us to solve a lot of problems. You can see Chantal, you can see Tori from Zimbabwe, Prince Kazadi from from DRC, our GP. Tele-advice sessions, as I mentioned before. Don't forget the social activities. I think from time to time, you have to go out with patients to have some relaxed time, because we are not only serious, we are human beings. We have to spend good moments. So that are these nice places in the mountains of Morocco. And also we are giving gifts to patients, to students, and to have some visits to the regions. And also don't forget about terminology. So I think terminology is a big issue. And don't forget that we need good collaboration, good partners. We have a lot of partners and we have to collaborate with all of them. And don't forget also the last point is the lack of involvement of pharmacists and lack of epilepsy surgery. That's one example of pharmacy in Morocco, because they are close to patients and they can educate, they can teach patients. And the last point is epilepsy surgery in Africa. It's not well developed. So that's another paper that we published in 2021. And you can see that only South Africa has a good program with invasive recording, followed by Morocco, Algeria, Tunisia, Egypt, Kenya, and Uganda. And in green, there is no epilepsy surgery. And in blue, Mali, by example, is using epilepsy surgery occasionally. And in blue, countries without any single neurologist, when you cannot develop epilepsy surgery. And epilepsy surgery is not developed. These are some easy techniques. And thank you very much, and see you in the 5th MENA Brain Week. I hope in Oman, Muscat, or maybe in Mali, Bamako. Thank you very much.
Thank you very much, Professor Najib.
been on
Shukran
time.
jazeera. I'll just highlight uyu musaza niwe watangije conference nk'izi ngizi, aturuka mu gihugu cya Maroc. Ibintu byinshi yavuze hano, yavuze yari havuga ingorane zituma abantu batabona ubufasha iyo barwaye. So ikintu kimwe yavuze ibintu 9. Icya mbere yavuze kubura abaganga b'inzobere, urumva, kubura abaganga b'inzobere. Icya kabiri, kwitabira gake kw'abaganga rusange n'abaforomo mu gucunga cyangwa se mu kurinda indwara z'igicuri. Icya gatatu yavuze kwivura umuntu atabanje kugisha inama ya muganga, magendu, kwivuza magendu. Ikindi yavuze ko dufite ubuvuzi bwa gakondo, ariko hari ubuvuzi bwa gakondo bubi. So kurwanya nyine imigenzo mibi ya gakondo. Hanyuma avuga kwitabira gake ubuvuzi bwiyongera mu gucunga indwara y'igicuri. Ikindi yavuze ko gukoresha guke ikoranabuhanga rishya. So mu Rwanda yatweretse amafoto ye yo muri Maroc. Hari igihe baba bafite snow, sinzi ukuntu snow babyita, urubura rwinshi. So bafite n'imisozi myinshi, ariko aravuga ati bakoresha ikoranabuhanga kugira ngo n'abantu bari kure mu biturage bya kure babashe kugerwaho n'ayo mahugurwa bakoresheje ikoranabuhanga. Kandi yavuze ko muri iryo koranabuhanga si ngombwa ko uba ukeneye, si ngombwa ko dukenera ibintu bya televiziyo binini cyane. Telefone bihagije, amafoto bahagije. Hanyuma ku yindi side akaba ari expert, umuntu w'inzobere, hanyuma akaba yafasha abantu gutyo, ariko abantu bakabona ubufasha byihuse bigeze no biri no kugihe. Kubura amahugurwa ahoraho mu bijyanye n'izo ndwara z'igicuri. N'ikindi avuga gahunda nk'iz'uburezi n'amahugurwa. So turishimye ko dufite abanyarwanda bamwe hano benshi. Mutubabarire iminsi ngashize ntabwo twavuga mu Kinyarwanda, ariko turushaka namwe muze kuva hano hari icyo mucyuye, hari icyo mwiyunguyeho muri ayo mahugurwa. Ikindi nyine ni kubura ubufatanye. Urumva, kubura ubufatanye na nibyo abaprofeseri benshi hano bavuze. Abanyeshuri ejo mwari hano, abanyeshuri b'abaganga benshi baraje ba presentinga cyangwa se batwereka ubushakashatsi bakoze. Ariko ubushakashatsi bwakoze aba barimu hano baravuze ati ni kuki mudashira hamwe? Niba muri abanyeshuri 5, ni kuki mudashobora kubatereka twishire hamwe turi abanyeshuri 5 dukore ubushakashatsi hamwe, aho kugira ngo nge nkori yanjye no yakoriye collaboration. So gukoranira hamwe. So nibyo byose yariho atubwira. So ndabasaba musabe tumushimire. Thank you very much.
I just end the tour because it's close to 1 more minute.
Without any further ado, I would like to invite Professor Arif Hereka. Please make him feel welcome. Welcome, Professor.
Good morning. Bismillahirrahmanirrahim. So when I was given this topic to speak on, it was a pleasure. Before I go further, I've been here for the last 3 days, and they've been absolutely amazing, inspiring days. I've had sessions yesterday with the youngsters there, and I've seen them very committed and very composed, very focused. So it's very, very important for me to speak on this subject of pediatric epilepsy insights and community approaches. I have been dealing with pediatric epilepsy for the last only 42 years. Right? So, so epilepsy affects 1% of the population of children. Over the nearly 4 decades of my working with children with epilepsy, what has struck me most is not seizures themselves, but how often it goes unrecognized. That's the important thing. Hello. And it is not only unrecognized, but at times misunderstood entirely. This is what happens, and this is where we need to focus. In children, epilepsy is rarely an isolated diagnosis. It is frequently intervened with brain development and learning, behavior, and family dynamics. So it's just not epilepsy alone. When you have a child with epilepsy, it is not epilepsy alone, it's the brain development, it's the learning, it's the behavior, and the family dynamics. I have seen how early recognition can transform a child's life and how it can quietly derail it as well. So some of the unique features in children. Why does pediatric epilepsy matter? So I was talking of my career. I have seen thousands of children with epilepsy across different countries. I've been to 6, 7, 8 countries in Africa, delivering lectures and doing OPDs. And what I have found out across different countries, cultures and healthcares, that we need a lot of information in the community. The numbers tell us epilepsy affects common causes. One of the most important lessons experience teaches is that pediatric epilepsy dynamic children are not small adults. The children are not small adults. Their epilepsies evolve, some remit, some change form, and some progress. I have followed children longitudinally for decades and seen how early choices, right or wrong, shape long-term cognitive and developmental trajectories. This is so important. It is just not the epilepsy, or it's just not the seizure. It is the complication that it causes around it. So what is important? Timing is more important than technology. Often determines the outcome. What I have seen over the years, that when I began my practice, many childhood epilepsies were labeled idiopathic. But today we have better understanding of the genetic and developmental causes. Yet in many parts of the world, I still see the same preventable etiologies recurring: birth asphyxia, neonatal infections, untreated early seizures. These are not just medical failures, they reflect systemic and societal gaps that we must acknowledge. So what are the diagnostic challenges? Again, over the years, I've learned that the greatest diagnostic tool remains careful listening. So important. Many children I've seen were initially misdiagnosed with behavioral disorders, attention problems, or syncope. So access to EEG and imaging helps, of course. But I must repeat, clinical suspicion is of paramount importance. Delayed diagnosis often reflects lack of awareness, which is very common in most of our underprivileged countries. But then lack of intelligence. So it is the lack of awareness, it's not the lack of intelligence or the effort or the part of the families. Lack of awareness is extremely important. That's what we are here for today. The Mena Brain Week is here because we need to create awareness. So why is this community engagement so critical? Again, in my experience, epilepsy outcomes are often determined before a child ever reaches a specialist. I'm always talking about my own experiences because I must tell you that there is no alternative for experience. You can read from the books, but when you teach and deliver from your experience, there it is unmatched, unrivaled. So I always go to my experiences, and when we are teachers, it is very important for us to pass on what we've gained from our experiences. So the first witnesses of epilepsy or seizures are parents, grandparents, teachers, and community members. Here and everywhere else in countries that are in Asia and Africa, elsewhere as well, cultural beliefs, fear, and stigma frequently shape early responses. So important. That needs to be tackled as well. I've seen families delay treatment. This is very important. Families delay treatment not out of neglect, but out of misinformation and fear. This is why community education is not optional, but it is central to care. So what are the effective community strategies? Some of the most meaningful improvements I have seen did not come from new medications, but from simple interventions, educating teachers, empowering primary care physicians, ensuring uninterrupted access to basic anti-seizure medications. This is needed not only in Rwanda, not in Africa, but in most of the Asian countries as well. So when communities understand epilepsy, adherence improves, stigma diminishes, and children thrive. And these are low cost, high impact strategies. You don't need to spend so much in doing these. Very, very important. So, coming to these, what are the messages take home? Now, if I talk about my message, it is simple. Most childhood epilepsy is treatable. This is very, very important for all the youngsters and everyone else here. Remember, it is a treatable disease, so do not worry about it. But what we need to do is start treatment early. And if you start treatment early, you will prevent a lot of brain damage. So the outcome will be much better by early intervention. Medication alone is not enough. Families, schools, communities must be part of the solution. When we start early treatment, we not only stop seizures, we protect development, dignity, and the future potential. Thank you.
Thank you, Dr. Ray. That was very good timekeeping. Very good. I'm impressed. Thank you very much. I'll just do a quick translation in Kinyarwanda. Professor Arif yari avuga ku bintu bitandukanye bijyanye n'indwara y'igicuri mu bana batoya. So akavuga ko ibyo bintu bishobora, iyo umwana atavuwe hakiri kare, biragenda bikangiza ubwonko bwe. Urumva yayigumanye icyo gicuri cyane bihoraho, icyo ubwonko bwe buragenda nabwo bukangirika, bukarushaho kwangirika. So akavuga ikintu cyangwa mwe yavuga community awareness, community engagement, community iyo avuze community nyine bavuga umuryango w'umwana, ku ishuri h'umwana, niba ajya ku musigiti, niba yiga ku mashuri y'Isilamu ya Korani, niba yiga mu kiliziya. Urumva abo bantu bose baba ari community y'uwo mwana. So bakagombye kumenya symptoms, ibimenyetso umwana yerekana. None niba babonye ibyo bimenyetso bakavuga ati reka dukomunike n'abantu bamwegereye, dukomunike n'abantu bamwitaho, hanyuma avurwe hakiri kare. Ariko ikindi, zimwe mu ngorane dufite muri Afrika hano nuko abaganga b'inzobere, nk'uko Professor Najibere yavuze kare, abaganga b'inzobere ntabwo bahari. Urumva abaganga bihariye bo kuvuga bati nge mvura indwara, abanirologe, nge mvura indwara zijyanye n'ubwonko, ntabwo bahari, ntabwo tubafite ari benshi. Ushobora gusanga hari umunirologe umwe ku bantu nka 2 miliyoni. Urumva, so ibyo bitera ingorane, cyangwa se bishiraho barriers, bishiraho ibintu bituma abana batavurwa. Ikindi kintu yavuze ku mpamvu zisanzwe cyangwa se impamvu rusange zitera epilepsy. Hari uturemangingo ndagasano, like genetic. So hari ibintu biba biri genetic, ku buryo nyine nge niba mbifite muri gene mu maraso yanjye, uko ndemetse nabyara umwana nawe akaba arabifite. So icyo nacyo twabikoraho, niko twaremwe. Cyangwa se kwangirika k'ubwonko k'umwana mbere, mu gihe cyangwa nyuma yo kuvuka. Mu gihe mudama twise cyangwa se mu kubyara, umwana akangirika, ubwonko bwe bukangirika, bukagira impanuka, hakabaho impanuka akangirika, icyo bita perinatal brain injury. Ikindi kintu ni indwara zandura. Indwara zandura nazo zishobora kwangiza ubwonko bw'umwana, bikaviramwo iyo epilepsy. So hakabaho n'izo ndwara nyine zo kudakura neza kubera impamvu runaka, iyo neurodevelopmental disorders. Ariko ikintu cyangombwa nyine yavuze ati ikintu cyangombwa ni awareness, community awareness, abantu kumenya izo ibimenyetso by'icyo gicuri ni gute. Ikindi kintu yavuze ni community awareness, abantu kumenya, mbese guhugura abantu kenshi cyane. Okay. So how is hari ikintu mwashaka kubaza? No. All right. We've had I just want to take this opportunity to thank everyone, each and everyone who is here today. This is day 3, and you've been excellent, an excellent audience. You've been very generous and kind, and we really appreciate that. And so, in a true form of an educator, I'm going to show you something. I want you everyone to raise your hand. Raise your hand, please. Zamura kaboko, zamura kaboko. Hi, everybody. Raise your hand. Bring your hand across here, across, and give yourself a pat. So well done. Good job. Well done, everybody. So, mwakoze cyane. Just give me 2 minutes. I need to sort out something and I'll be back. 2 minutes. Speak amongst yourselves and I'll be back. Vuganira n'umuntu mwegeranye umubwire uti uyu munsi niki nize, uyu munsi niki niyunguye uyu munsi. Muvugane ndaje. 2 minutes. No, it's early. It's early.
umuryango we gutera imbere kuko nawe atangiritse cyane yatekereza neza umuryango we.
So ngo icyangombwa nuko avurwa bimenyekana kare agatangira kuvurwa kare. Yego. Are you Celestine? Thank you very much, dear audience. It's really great to hear the chatter in the audience and people talking to each other. And just spoke to the group at the back there, telling me that there's a few takeaways, and most of the people we have here who are Rwandans are community health workers, and that's how I think we can speed up this community awareness by having groups of people that are trained and continuously improving and getting a lot of professional development, but also remembering that we need to leverage technology so that we can reach as many children, epileptic children or any child with any mental health issue. So without any further ado, our next speaker is postdoctoral and project lead Celestine Mutuyimana. He's going to talk to us about relationship disappointment, stress syndrome, and death, strategies to improve seizure management using herbal medicine, ketogenic therapy, and vitamin supplementation. Please make Mr. Celestine Mutuyimana feel welcome. Karibu.
Okay, here it is. Hello, everybody. That's a pleasure to be here on this very important conference. I am talking something really different, but which has a connection with epilepsy and the brain and any other things, disorders, because I will present my work on trauma-related disorders and the cultural clinical psychology. But I will make types of connection with brain and neurology. So let's go quick. The one things I would like to emphasize is like epilepsy, neurology always is on biological model of treatment. It's like we have MRI, we have ACG, we have the symptoms, this is always biological model of treatment. But this, I would say that might be a pitfall for all other clinicians when we forget always the culture. Because culture is very important. The manifestation of epilepsy, like any other disorders, can be manifested in a different culture, and depending of the circumstances of the factors which is related to the cause of your epilepsy. So this is why I am talking why culture matter, because what I am talking a lot is on my work on trauma related disorder. Why culture matter? Because it shapes our understanding, it shapes the expressions, coping mechanism, diagnostic, assessment, and treatment. All of those should really be connected to the culture. And I think this should be also the case in neuropsychology. But what you see on the chart, it's most studies in psychology, 7% have been conducted in with the Western participant, which represent really 11 portion of the world. So what happens as a result? What we have is like, what we have, the intervention, which I think also in neuropsychology should be reshaped. The intervention we have are not culturally sensitive and lack some important information which can be helpful to the patients. So anytime when we are shaping any types of treatment, please think about cultural sensitivity. Because what we have so far is in Western culture, it's good because we are all human beings, but we have common patterns, but we have also differences, and those differences are coming from our culture. What to do when we are in this research? We use EMIC and ethic. EMIC means we need really to go on the field. I heard that there is here community health workers which works with the people which have epilepsy. So those persons are really the sources that can provide the most information how people are experiencing the disorder, and then this information which is coming from the field can be complemented with the scientific what we have as a research. So this is why I'm saying when we are conducting any research, please remember cultural sensitivity. EMIC, please go down, listen to the people, listen to people who are experiencing, but also go up and listen to what have been established already. So this is important. When we look at traumatic experiences globally, we have seen that at least 70% of the population have been exposed to traumatic exposure. When we see on multiple traumatic exposure, at least 30% of the population have been exposed to traumatic exposure. But when we see East Africa, 80% of the people have been exposed to cumulative and repetitive traumatic exposure. So as a result, you can see if you see this animated, most of traumatic exposure are in global south. The global north, they might have a kind of traumatic exposure, but single, not corrective, not familial. But for us, we have corrective, which is at individual level, at family level, and at community levels. So what we have in global north, it's easier to have a PTSD, but for us, it's easier also to have PTSD and other disorders like relationship disappointment stress syndrome that I will explain, and how is it connected with neurological things that the neurologist here should really know, that this syndrome, if it happens, it's not only for a neurological condition, but a psychological condition. Historical trauma and cultural script of trauma. So I start quickly because with my, I see the watch. Historical trauma. When people are exposed to collective, cumulative, and repetitive trauma, trauma is not only stopping at their individual level, but it's also going to families. We see people here, many young stars drinking, prostitutions, high level of criminality, which is related to historical trauma. And some of the symptoms of historical trauma include also the neurological symptoms. And this is why when we are treating, also shared it to their siblings. And if everybody is suffering, because you know, in your community, your relatives, your fathers, your mother, any of your neighbors, they have been exposed to similar problems. This is why the symptoms are not only individual, but also they are community. We have a community level symptoms. Let's say mistrust. We have a traumatic, a very huge traumatic mistrust. Let's say competition. We have a very high level of competition, but which is coming to historical trauma, like a ripple effect. What is happened to us like individual does not remit here, but also go to other spheres of the community. Another disorder that we have to look is cultural script of trauma. When we talk about cultural script of trauma, we mean other cultural specific symptoms, which are not really recognized in well-known symptoms of PTSD. Let's say body-related symptoms, many people with headaches, with sleeping disorders. Quickly to this disorder, where I finish with this 10 minutes, because it's really connected to what is neurological things. Recently, we have introduced a disorder we called a potential disorder, which is called the relationship disappointment stress syndrome. What is this? So many people, when they are going to go in a relationship, you know, there is a very huge talks around marriage. When you get married, you will be in paradise. Your trauma will be released. You will get everything. You were a child, but then your husband will give you what you need. Your wife will give you everything. So you idealize a relationship like something and pseudo paralysis. I will show you a small video which I will finish because of my time, which shows how people can confuse neurological condition with relationship disappointment syndrome because of these somatic symptoms. Another thing is interpersonal relationship. There is people are most 90% of our participants was women's. They are thinking about their husband wherever they are. They are driving but thinking about their husband. They are working but thinking about the relationship. They are eating but everything. Then this is the preoccupation of a relationship. They are not doing anything. They lose their humanity themselves. They are confused. They don't know where they are. And they don't trust anybody. Why? Because the person who have been betrayed was the person who were trusted the most. So they don't trust anybody. And then they have existential symptoms. Those existential symptoms means, okay, because my relationship failed, nothing in life will work out. So then it's like I am useless. So I should really, it's a symptoms of dying. And then when they have so many problems of talking about their problems because of our culture. If you talk about your marriage, then you lost your marriage, and you know niko zubakwa, you should stay silent until. And they have also the problem to go to the hospital and to talk about their problems. So they go with only somatic symptoms and they say, I have a headache, but it's no longer a headache, it's a disappointment. And they say, many people have done very much MRI of the neck. But those MRI does not provide anything, it's just a disappointment. They are on betapin for so long. The medical doctor who are here, they might prescribe a lot of betapins for backache, and then they told them, oh, you have the problems of the neck because you are using a lot of computer. No way, it's not a computer, it's a disappointment. So association. Because of my time, if the movie is able to be played, I will show you this movie, and then it will end up with, it's a case study we treated. Is it possible to have a voice? I may start again. Sorry. Okay. Sorry. So I still have 2 minutes. This is a case study that we followed up, and it was really confused by neurological conditions. And I discussed the 2 days ago when I came here. I have a case that I am following, which is a trauma survivor, and he never talked about what happens to her when he was after surviving the genocide against the Tutsi. And today, she's having seizures. It's like the seizures, but they are not seizures. When they do MRI, they do not find anything, and ECG, they did not find anything. And then the doctors, she's in France, the doctors said, you are not suffering to any epilepsy, but most probably the effect of past traumatic experiences. So what I am talking about, it's not always, I'm always underlining that when you are treating medical conditions, remember that there is a background of the people and explore those background. Do not always think that epilepsy is only, I say only because it might be a biological, but there might be psycho, social, cultural causes that might be associated with a so-called neurological condition, as I show a case study of relationship disappointment stress syndrome. So I thank you very much for this talk, and I hope this will help for the next treatment.
Thank you so very much. I think one of the chilling things. So I live in Australia, and in Australia, every 7 days there's a woman who dies. She dies because of her ex-partner. She dies or because of her partner, right? Every week. So I wonder, with the cultural trauma, the cultural things we have here, I wonder if in this country, if we were able to keep data on, so we call it feminicide. So, this men, like women, dying at the hands of their lovers, at the hands of their partners. Australia is a developed country. One woman every week, right? So it pains me. It pains me to hear that. And like I talked to previous speakers, this work, what are you doing to publicize this this work of yours, this research? What are you doing to make sure that is a mass communication campaign to educate young people, especially men? So men, we have a problem. We have a problem, and we have to take ownership, right? So is there, I think something you're doing in terms of campaign and sharing your research?
Yes, thank you very much for the question. One thing, I published the result of this, and I have made several videos on this relationship disappointment to make it aware, and I try to go everywhere, like here in a conference, and to make aware about cultural aspect of disorders, the mental disorders, because not always forget this cultural aspect. And third, I established Bahos Meyer Institute. It's an institute which helps in our empowerment people in knowing what is the problem. And every day, we try to produce posters, videos, and we do our online training. We wanted now to target really the young people to know that trauma is not only for the old people, because the old people contaminated you guys. So you should always talk of what is going and what is not going on. I was talking with a young star last time, and she told me, now when I feel the problems, I'm not able even to share with my father, because I know my father is suffering a lot than I do. So it's up to you. Probably among you young, I see there is very young people here. Probably you also face the same problems, but your father is not able. Please look for help.
Fantastic. Just hold on. The other thing, I think, the other thing that we, when we look at autoimmune diseases, so we find that women are predominantly affected by autoimmune diseases. And there's a work by Professor Gabo Mate, who's based in Canada, he talks about the body and mind, or the mind over body connection. So if, the mind has the power to actually affect our physical health, right? So there's a mind and body connection. So it's a lot of work on intergenerational trauma. And again, my reference where I live and where I work with Aboriginal people of Australia.
Yeah.
And so there's a lot of intergenerational trauma, right? So because of colonization in that country, you have the way the settler colonialism has treated them. You still have, we're dealing 4 generations, 5 generations down the track, we're still dealing with traumatic events from those kids. I would like to quickly just ask your resume in Kinyarwanda so that some of our audience can listen to that as well. I'll give you 2 minutes. Ubabwire mu Kinyarwanda ubushakashatsi ahanini icyo bushingiyeho n'icyo wabusanzemo.
Yego, murakoze. Abantu batumva ruriya ziriya ndimi z'amahanga, ubushakashatsi bwanjye bureba cyane cyane ibikomere abantu bahuye nabyo, abanyarwanda by'umwihariko, ariko nkajya kuri East Africa ndetse nkakora no kuri Afghanistan na Ukraine. Icyo tubona gikomeye nuko amateka abantu banyuramo ateye kubabara ntabwo agarukira kuri bo bonyine, ahubwo agera no kubo babyaye, akagera no ku muryango wose. Icyo ni kimwe cya mbere navuga mu minota 2 bampaye, ko niba uzi ko, murabizi ko twese twavutse ahantu habaye jenoside ikagera ku bantu benshi, ku buryo abantu benshi mu gihugu bashobora kuba bafite trauma, bafite ihungabana. Igihe rero umerewe gutyo, ntugaceceke, jya uvuga, kuko bimwe mu bituma abantu bagira ibibazo nuko batavuga. Hanyuma ikindi nasobanuye cyane ni indwara n'isi ntimba y'urushako. Ni indwara n'isi ntimba y'urushako. Nagize ikibazo cy'abantu barasakuza si bikanyamburuye. Yeah, it's not. Yego, nari ndimo mvuga ko basakuzaga bikanyamburuye, to be honest. Iyo uri kuvuga kumva abandi bantu bavuga, ntabwo biba bimeze nkaho uri kuvucurangira abahetsi, niko mu Kinyarwanda babyita. Nuko navugaga iriya ndwara n'isi ntimba y'urushako. Abantu murabizi neza yuko mu muco wacu bavuga bati nujya gushaka ibintu byose bizaryoha, uzaba mwiza, ibikomere wanyuzemo, agahinda kose muri bridal shower baragutegura ukumva ugiye mu ijuru we, maze umugabo nawe bakamutegura gutyo, sinzi aho yitegurira. Hanyuma byarangiza rero umugore akagenda agategereza ko umugabo azamuterura, n'umugabo akagenda agategereza ko bamukuramo inkweto rukabura gica. Bikaza kurangira rero hari abantu bafite ibimenyetso bibabara, navugaga umutwe udakira, ijosi, umugongo, kuribwa mu nda, guhora utekereza relationship yawe ahantu hose uri, uryamye, usinziriye, nta mahoro ujya ugira, nukuhora, kutagira umuntu wizera, kugabanuka ko gushaka imibonano cyangwa guhura n'uwo mudahuje sex, kumva intego zose z'ubuzima zararangiye, kuko ibyo niba relationship yarakunaniye, ubwo nta kindi kintu kizongera kubaho. So abantu benshi bajya kwa muganga bagakora ama MRI, ariko bigasanga nubusa, ntacyo bari kubona, bakabaha ama beta pin, ariko atagira ikintu na kimwe, kubera relationship disappointment syndrome. So nkavuga rero ko abaganga baba bari hano, abari kwigira ubuganga, abarwayi cyane cyane abadamu 90%, mfite n'abagabo 2 twavuye, sofa bane twavuye nabo bafite relationship disappointment. Ni ukuvuga ko atari ngore gusa, ariko igihe wumva uri mu mubano utameze neza, ukaba wumva hari ibimenyetso ufite, aho kugira ngo ujye gushaka imiti uzayinywa ariko ntuzakira, ni byiza ko washaka ubufasha buri therapeutique, biravurwa bigakira, turabivura bigakira. abantu mwabibonye naberetse the case study. Iyi ni case study nerekanaga twakurikiranye at the beginning yari hospitalize ku bitaro bya Nyanza. Namuvuye online. Yari hospitalize ku bitaro bya Nyanza hanyuma ndamuvura online kugeza mwamubonye ko yagendaga. Ariko bura ntago yabashaga no kugenda. So ngayo nguko uwabasha kwivuza yabikora gutyo. Ndumva ari byo nagerageje kuvuga nirukanka kubera iminota yacu. Ya ndikubona abantu babiri. Yes.
Ni post traumatic stress disorders. Twese twafushije muri genocide. Ariko ingaruka yabyo y'ibintu twabonye. Ariko Celeste mu mukomere amashi. Mu ba professeur ba kaminuza w'u Rwanda. Nguko Dr. Vincent Sezibera yabivuzeje. Uyu nguyu ya developye PSTD tool ya AI. AI iri approve muri Eastern Africa. Nukuvuga ntabwo izafasha gusa abanyarwanda ariko izadufasha natwe abagore ari gihe tubyara tukagira ama post traumatic ari gihe n'ibindi bitubaho because life is no pink ariko ibintu tuhura nabyo ama disappointment biriya byose ni ibintu avura ariko ngewe ndavuga mu nyungu y'abanyarwanda iki kintu cyakwiye kuba mu ibuzima health ibuzima mukivugire ejuru bakiadaptinze iyo PSTD tool ni ya mbere mu banyeshuri ba East Africa bakoreye kandi ngenda shaka ko muri inama ya CDC tuzakora umwaka utaha tubisabe ni mwebwe muhura na guverinoma tuvuge mu bintu nguriya twarakoranye muri epilepsy nago nibukaniye Emmanuel aricaye I have a memory. Please stand up a bit. We are here for economic, yeah. And I'm not here to misjudge you work and we work together, but this PSTD tool should be implemented on eBuzima. Artificial intelligence cloud to help people, not to commit suicide and carry on life. Thank you so much.
Yego arakoze cyane ni tour ya historical trauma kuri presentation nayiteguye ariko nabonye ari byinshi ntashobora kuyivuga iri adapte mu Rwanda no muri East Africa iri kuba adapte no mu bindi bihugu muri Costa Rica mu Budage muri Ukraine no mu Bufaransa nabonye hari umunyeshuri wacu w'umunyarwanda w'umufaransa arimo arayikoresha muri masters yiwe so niba ikenera irahari ni free source bashobora kuyikoresha bakayishyiramo kubera ko yasesinga trauma at individual family and collective level ntabwo ari noneho PTSD dusanzwe tuzi ni historical trauma ntabwo ibibazo abanyarwanda bafite ari gusa nightmares ariko banagira n'ibyitwa cultural distress nta muntu hano ujya ubabazwa nuko atagituye ku musozi yari atuyeho nta muntu hano ujya ubabazwa nuko nguriya n'abandi nta muntu hano ujya ubabazwa iyo yibutse ukuntu iwabo bamuciraga imigani cyangwa bari nk'ahantu iyo cultural distress ntabwo ibaho i Burayi iri rero muri iyo historical trauma nta muntu hano ujya utekereza akavuga ati ariko ibimbaho byose ni ukubera ibyo nanyuzemo ni ukubera genocide cyangwa intambara ukumva ibintu byose niyo baba bakoneshereje ukavuga uti buriya ni ukubera ko byagenze gutya that is historical trauma revengeful thoughts attributed damage so mushobora kubibonamo rero at any time. Yes please.
Murakoze mwaramutse nani ndashaka kumushimira kuri presentation nziza duhaye kandi mushimira nkuko Chantal yabivuze kuba yaricaye agakora igikoresho reka mbyite gutyo igikoresho abaganga dushobora gukoresha kugira ngo tumenye niba umuntu afite trauma cyangwa stress yaba cultural cyangwa itari na cultural hari ikintu wavuze nge nshaka ko gusubiraho abantu benshi peut-être batabatumvise hano nubise ko arabavuga ikinyarwanda gusa wavuze ko wa murwayi wamuvuriye online kuvura umuntu online no kuvura umuntu mutari kumwe muri bureau ya consultation, mutari kumwe mu cyumba kimwe. Murumva ko hano turi gushaka no kwereka abantu ko Afrika bitari u Rwanda gusa, ni benshi bagenzi banjye babivuze, dufite abaganga bakeya muri Afrika. Icya kabiri, Afrika ukuntu iteye, usanga umuntu atuye ku musozi azahabyarira ryari, cyangwa niba afite umwana ufite igicuri, cyangwa we ubwe afite trauma, uzamusaba kumanuka uwo musozi agusanga i Kigali. Nanjye ndi mu baganga bavura online kandi birafasha pe, nkuko nawe yabibabwiye hano ko yavuye uriya murwayi wavuriwe i Nyanza akamuvura batari kumwe, akamuvurira kuri telefone kandi akamufasha. Ndagushimiye pe, kuko tugomba kujyana n'igihe. Hano ninde udafite smartphone? Twese turazifite, ariko aho dutandukaniye ni uburyo dukoresha smartphones zacu, burya ntabwo tuzikoresha kimwe. Murakoze.
Yego, urakoze cyane. Anyibukije ko ejo nigisha kuri University ya Zurich, hanyuma ejo ntabwo ari kubibaratira, bari bampaye award ya yitwa Sparkling Research. Ndi gukora application ifasha, twakoze ngewe na team yanjye twadevelopye self help intervention, tuyishyiramo, tudevelopa kumatchinga abatherapeuts n'abarwayi online, tubishyiramo, tunadevelopa online peer support group, aho ushobora guhurira n'abandi bantu muhuje ikibazo cyangwa ushaka kwiga cyangwa ushaka kumenya. Umungira group ya Baho Smile Institute turi gukoraho trial, ariko izarangira ibaye iyo app. Iyo app rero tuzajya tuyikoresha abanyarwanda nidutangira, niba yabaye published, natekereza ko mu mpera z'uyu mwaka izaba yabaye published. Ariko mwibuke nkuko yabivuze, kwivuza online. Online birashoboka kimwe na in person. Ikintu nabonye ikindi cyiza abaganga bashobora kuba bari hano, nuko hari abantu dusigaye tuvura anonymous. Nukuvuga murabizi ko mental health ifite 70% ya stigma. Iyo nagiye Karayesi nkaba ndafande, murumva bazambona bate? Ariko iyo biri online uramubwira, do you want to be anonymous? Yes, nta kibazo. Icy'ingenzi ntabwo ari uko umenya izina ry'uvura, icy'ingenzi ni uko umuvura akagenza gute agakira. Benshi twatangiranye n'abari anonymous, birangira nyine banyibwiye barambwira ngo burya ni ngewe rwose. Rero it's another advantage. Niba ufite isoni zo kujya Karayesi, zo kujya kubera wenda stigma, hari ubundi buryo ushobora gukira.
Murakoze cyane. Ikintu navugagaho kare, ni indwara usanga hanini wavuze 90% n'abadamu. Izo ndwara zigaturuka kuri hanini ibyo twavuze nyine, either intergenerational trauma, nko muri iki gihugu cyacu turabizi hari intergenerational trauma ihambaye cyane. So nyine navuze nyine uburyo nkorana n'abantu aborigine bo muri Australia, nabo bafite intergenerational trauma. So iyo ikaza kutwafectinga rero, twabishaka tutabishaka, twabishaka ikatwafecting. Ikibazo mfite cyanyuma turi burangirize mbere yuko tujya kurya, eske iyo service iri kuri mituweli? Icyo cya mbere. Urumva ikindi cya kabiri, nje muri consultation, nje kureba muganga GP, general practitioner, afite umwanya wo kumbaza utiriyasi ihungabana rya ibyo bibazo bimbazaho, cyangwa areba umubiri wanjye, umutwe urandya, umugongo urandya, ndaryama sindi gusinzira? Eske abaganga bacu bahabwa umwanya wo gucukumbura ngo babaze ibibazo naba mfite bijyanye n'ibyo bintu?
Yego, urakoze cyane, ni ikibazo cyiza. Na buriya aboriginal bari abakavukire bo muri Amerika na Australia, nabakozeho ntangira gukora historical trauma, ubushakashatsi bwa mbere na publiye nibo. Ni modeli ya mbere ya umuntu wabivuze ni Maria Yelo, Maria byo menya nta kintu bibamarira, ariko abantu babayeho mu myaka 300 ishize, ubuvivi bwabo buracyafite ibibazo bya basekuruza. Wako natwe mubimenye ko hari ibibazo dufite tuzakomeza tukabitera. Niki nsaba ababyeyi bari hano? Please mu ngo zanyu mugerageze muba ababyeyi beza. Mwikorera iyo burden ariko tureke twishyira ku bandi. Tuzaba tubaye intwari icyo gihe. Ariko nituyinanirwa ubwo tuba tuyishyize, ubundi so ukwanga akoraga urubanza rwamunani. Nuko bigenda. Ubwo nitubinanirwa tuzabishyira ku bandi. Icyo nicyo navuga, iyo nyine niyo navugaga mu cyongereza ngo ni ripple effect. Iyo ufashe akabuye ukakanaga mu mazi, aho kituye niho ubona kaguye, ariko inyuma yaho ugenda ubona utundi tuzeru. Iyo rero niyo historical trauma. Nkaba rero navuga icyo babazaga cy'abaganga, abarimu bigisha abaganga hakwiye kuba harimo ba psychotherapists, aba psychologists bigisha the medical doctors how to meet, to treat, to understand, to listen to people who ndagarutse kandi muri bwa Rwongereza. Hagombye kuba harimo abaganga bigisha uko utega amatwi, umenya, ubaza. Umuntu nk'uyu wavukiye mu Rwanda ahantu hari ibikomere, iyo akugeze imbere koko abarimo avuga burwayi bw'umubiri gusa, cyangwa ukwiriye kumubaza n'ibindi bibazo. Ese umufitiye umwanya? Services za mituweli kugeza ubu nakoze registration muri Minisante, ndizera ko bazaduha approval yo online clinic vuba, ariko kugeza ubu ntabwo irajya kuri mituweli.
Yeah, biraba bikenewe. Thank you so much. Murakoze cyane. Kandi mukomeze courage kabisa, mukomeze. Ifoto.
Ngo njye kuyigurisha ahantu ko navuye hano.
Ifoto zirahariho.
Thank you very much.
Sa murakoze. Yeah. Oti? Ufite ikibazo? Kibazo cyihute cyane, cyihuse gato gake.
Murakoze. Amazina yanjye nitwa Frank Ndayimana, niga nutrition muri University-RWANDA. So naringize ikibazo nk'abantu twagiye turi kwiga, tujya kuri field rimwe na rimwe tugasanga hari ibibazo bihaba. So ugasanga dufite umubare munini wo treating abantu cyangwa kwita ku barwayi. So nari numvishe iyo program cyangwa iyo system mwari mwakoze numva ari nziza. Ikibazo rero kijya kigira most y'abanyarwanda cyangwa abaturage benshi, ubushobozi ni ikibazo, kandi ubwo bwaba ari n'uburyo bwiza kugira ngo treating abantu benshi online kandi byihuse. So nkabaza as doctor, ni nk'ikihe kintu uteganya iyo uri gukora nk'iyo system according n'ubushobozi bw'abaturage kugira ngo ubwo buvuzi bubagereho byoroshye? Kuko usanga nibyo natwe dukora bya nutrition, hari igihe ukora ikintu nk'uko mwabitubwiye abantu bafite disorders, ugasanga nta kintu ukora, cyangwa ugasanga uburyo bwo kumufasha na time n'abantu ni benshi. So accessibility y'abaturage kuri iyo program yo muyitekerezaho iki, cyangwa hari ikintu muyikoraho ku buryo umuturage yayigeraho ukanamutreatinga cyangwa ukamukurikirana nyuma yaho?
Yego. Ni ikibazo cyiza ubajije kijyanye no guspreadinga. Ubundi ahantu habaye collective trauma haba collective healing. Iyo bitagenze gutyo nta kibano kuvuga y'abantu bahuye n'amakuba menshi, ntago ushobora kubakiza ari umwe uza kwivuza, ntago wazabakiza nubwo waba uri umwe expert wa hene byakora. Ikintu cyonyine gishoboka ni ukureba ukuntu nk'ubu tuhuriye hano biroroshye ko umuntu yabavura bigakunda. Muri iyo modeli dukora kohereza posta buri munsi. Posta nakandiko kanditseho ibintu bishobora gufasha, karagenda njya mbona baduhererekanyije aho muzatubona twanditseho ba Smile Institute. Tuba turagenda tukagera no ku muntu utazi gusoma. Ubwo ni uburyo bwa mbere kugira ngo na waho utazabona amafaranga ariko yabona ikintu gishobora kumufasha. Uburyo bwa kabiri nuko hagombye kubaho integration ya system na health insurance zikabyumva, kuko narabimenye Manuel wenda azatubaza. Manuel ni umukorege wanjye, kubera ko mituweli ngo therapy yishyura 2, ntabwo washobora kumara amasaha 2 uganira n'umuntu ngo baguhe 2. ntabwo bishoboka. Byose ni ibintu byo gukoreraho ubuvugizi kuri leta kugira ngo imenye terapi inyuranye gute, ariko nabyo ntibibe misused, ntibikoreshwe nabi kuko abantu bashobora kubikoresha nabi. Numva hari ubwo buryo dukoresha bwo gutanga videos ngo zigere kure, wenda abantu benshi bashobora udafite video akagira posta agapapuro gato yasoma, udafite agapapuro gato yasoma akaba ashobora gukora. Twashyizemo uburyo bwa self healing, ushobora kwifasha, ibyo wenda byakorwa n'umuntu wize, ariko nibura nabwo ni ubundi buryo, kuba atari gusa ko uzahura n'umuganga. We integrated another way, twashyizemo ubundi buryo bw'uko ushobora kugenda ugakurikira amabwiriza kugeza igihe wikijije, wakenera umuganga ugahamagara.
Murakoze cyane. Ibibazo Dr. ari hano tugiye kujya kurya, nabasaba ko mwamwegera niba mufite ikibazo mukamubaza, sibyo?
Mumbaze nta kibazo.
Yego, so muramwegera, tugiye kunywa icyayi hasi. Abantu bagende gake gake. So abantu ngo tugende gake gake, ariko
Yes,
so,
I have time.
Okay.
I have
So
time.
abantu bagiye gake gake, hanyuma tukomeze twumve.
Murakoze. Amazina yanjye ni Nsengiyumva Thierry, niga medecine muri University of Rwanda. Abanza gushimira Dr. kuri icyo gisubizo yazanye. Application yanyu muri kudevelopa cyangwa se n'ubwo buryo bwa PTSD AI tool, twebwe twifuza ko wenda nk'umuryango w'abanyeshuri biga ubuganga hari igihe tujya dukora advocacy campaigns tuvuga ku bintu bya mental health, kugira ngo tumvishe abaturage nyine ko bakeneye kugira ubuzima bwiza ndetse bwo mu mutwe mbere na mbere. Ariko twifuza no ko mwaduha, hari igihe muri kugerageza nka application cyangwa tool muri kuyidevelopinga, hari abantu baba basabwa ko nyine ba contributingaho bagashyiraho amakuru. Bibaye byiza twabona contact zanyu, natwe tukagiramo uruhare tukuzura muri system, byose bikagenda neza.
Urakoze cyane rwose, ndaziguha contact zawe.
Sawa, murakoze.
Ndagushimiye.
Murakoze.
Murakoze, nitwa Christine, nkora muri UMST-UNIVERSITY-RWANDA. Naje kubashimira kuri iyo tour mumaze kudevelopa, uko kuntu mushobora gufasha abantu online, ni byiza. Ariko natekereje kuri Shadia mwamuvuye online ari mu bitaro by'i Nyanza, kandi turabizi ko mu ma hôpitaux uretse ubu no mu ma centre de santé hari abantu bashobora gufasha abantu, hariho ama service ya santé mentale. Ni byiza ko nyene haza harabaho amelioration. Eske nta kuntu byoshoboka ahubwo abantu bakora muri ayo ma service mukaza murabatraininga kuri ubwo buryo bushasha, ku buryo bashobora gufasha abantu benshi, kuko uburyo bwa online si bose bashobora kubwa accessingaho. Murakoze.
Yego, urimo uravuga ikibazo cyiza cyane. Ibintu umuntu yabivuze byose ntabwo byibuka. Iriya ntuza tuyita hybrid. Hybrid ni ukuvuga online na in person. Mu gice kimwe kiriya iyo twise self help intervention, ubwo buryo umuntu ashobora kwifasha yitwa ubuntu multi systemic intervention. Iyo duteganya ibyo bintu bisaba amafaranga, ariko duteganya kuyihugura muri universite, abanyeshuri bo ubwabo bari kwiga bakayiga, kugira ngo mu by'ukuri ntabwo dufite abanyeshuri yaba ari abiga medicine yaba ari abiga psychology, ntabwo dufite intervention ubuvuzi psychotherapy intervention igenda igasubiza bya bibazo by'iwacu. Rero twarayidevelopye, ariko ntituragira ubushobozi bwo kuyigisha. Ubu niyo next wave, kuyigisha, kuyigeza muri health institutions zikayigisha. Turimo turabishakira amafaranga, nituyabona tuzabikora, ariko kugeza birahari, iri well developed n'abantu b'abahanga, kandi iri really adapted ku byo dukeneye iwacu, ku muco wacu. Rero ni ikintu cyiza warubajije ko ntabwo bintu byose byakemukira online, ahubwo online iba yabaye alternative, iba yabaye ubundi buryo umuntu yakoresha.
Thank you. Ngewe nitwa Benwa Ndagijimana, ndi medical doctor muri resident training ya psychiatry. Ngira ngo iriya ndwara relationship disappointment stress syndrome ni indwara nshya yo mwavumbuye ariko which is recent ukuntu bariya barwayi ba za neck pain headache abenshi turabagira. So I think if we can make well the diagnosis twagira na case nyinshi. Niyo mpamvu nabazaga ngo ese ko abantu nimba nabyumvise neza romantic love itabaye meti nk'uko umuntu yabyifuzaga ibigiramo uruhare runini. Nkibaza ngo ese ko abasore n'inkumi umuntu ashakana n'undi akakubwira ngo twadetinganye imwaka 2 hari icyakorwa before someone gets sick during dating period, kuko bwa buryo buri culture mwavuze hari n'ibindi biri religious aho bakubwira bati ikintu cyatuma utandukana n'umuntu wakunze nuko wamuca inyuma gusa. Iyo mpamvu ikaba ariyo yonyine ba mentioning. So I wanted to ask your advice, can it be a way of breakdown of a relationship ubashije kubona ko za romantic expectations zawe zitazaba fully met?
Good question, Doctor. Navuga ibintu bitatu kuri icyo kisubizo. Icya mbere nuko please aba medical doctor mube aware kuri iyo diagnostic iri correct, abantu bararwaye kandi ntago barwaye biri biologic, it's really psychological. Second, turi gushyiraho prenuptial counseling consultation. Uva ko aba ubu ngubu kugeza ubu mu Rwanda ntayihari, turimo turainstalla muri system nayo. Ni ibintu bizadufata imyaka, ariko at least we are turi gukora kugira ngo nibura abazabikunda uzajya mbere yo kushaka aho yangobe ari bridal shower gusa anyure ni mu nzira iri professional. Noneho imutegura amenye ibyo agiyemo, amenye ko atagiye gusa kwakira, agiye no gutanga, amenye ko agomba kugenda yarakize, kuko umuntu atanga icyo afite. Ugenda n'ubundi uri ibikomere bisa, ukaba ushaka umuntu ukomora nawe mugahura ari igikomere, ubwo urumva azakomora ati ntabwo bishoboka. So nibura kubafata tukabanyuza muri iyo nzira yo kubakiza, ariko tukanabategura no kubana biri professional. Iyo ni imwe muri activity. Ibyo bintu bikabera ntibibere kuri bikabera iwacu nk'uko bategura kwigira umubano cyara byabagaho, ariko biriya biri religious nk'uko uri kubivuga. Hakeneye biri professional kandi bikiza n'umutima, byegera umutima w'umuntu akumva. Ariko noneho abantu bageze noneho mu mubano bo bakaba bamerewe batyo, nabo bakeneye nyine iyi awareness turi gukora kugira ngo bataguma aho hantu bababaye badakora. Abana baba babashiha, baba babakubita shamva, barabaha koko nibo babizi. Kubera ko ikintu cyo byose biba byarabereye itabi. Ndumva ari cyo nabisubizaho kugeza ubu ngubu.
Sawa asante. Reka uramwegera Dr. Yego, uramwegera Dr. Reka turangize. Mwe musigaye mwe hano ndabasaba ko mwajya hasi mugafata icyo kunywa n'icyo kurya, hanyuma tukagaruka byihuse. Dr. Thank you very much. How do we upscale? How is that? How can we subscribe? How can the government subscribe? Another way to subscribe. Makes sense. Yeah. Thank you very much. You're welcome. And iyo miziki muyikuremo. Murakoze. So abantu baragenda baza buke buke, abandi baracyafata icyo kurya n'icyo kunywa. Ndashaka tugiye kuvuga kandi ku bintu bijyanye n'indwara y'igicuri mu bana. Ndashaka nimvite I would like to invite Professor Tahil to come up to the stage and share with us some of his presentation and research. Thank you. So that's forward. So we'll have the time there. Presentation is going to go on. I'm looking at those boys at the back. It's I'm looking for that. Okay. Also, I would like to invite the med students. Abanyeshuri hari session y'abanyeshuri iri kubera mu cyumba bita urugwiro. Iyo ni epilepsy treatment needs focus and dedication. In Professor Francis Feze. So muri iki cyumba niba ushaka kujya muri ibyo bintu bya epilepsy treatment needs focus and dedication, ni muri iki cyumba kitwegereye hano sohotse iburyo bwawe. Sawa? Ariko ni session iri ku banyeshuri gusa, mainly students. So without any further ado, please, Professor Tahil.
Good afternoon. Is it morning? So my talk, I hope it will be interesting, and I hope I will finish in time. As you know, juvenile myoclonic epilepsy is one of the most interesting epilepsy syndrome encountered by human. So my learning objectives will be to focus initially on definition, as recently there are some structural changes which have been described in this condition. Also, an important understanding of epilepsy in general, especially idiopathic genetic epilepsy, is the structural changes in the network which have been recently addressed. Also, a recent debate, is it generalized or is it focal, which is interesting. Then I will touch on drug treatment, and of course gender is very important to address in this epilepsy syndrome. And lastly, I'll touch on genetics. So this is a genetic form of idiopathic epilepsy. It encounters about 5 to 10% of epilepsy in general. It occurs around puberty or the adolescent, and the hallmark of this syndrome is morning jerk. As you can see from this slide, there are 4 genetic idiopathic epilepsies, which includes childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and generalized tonic-clonic convulsions on awakening. These 4 syndromes, they have shared some clinical and genetic background. Also, their EEG shows spike and slow wave. And it is interesting to know that, for example, juvenile myoclonic epilepsy might borrow absences from childhood epilepsy, and juvenile absence epilepsy rarely might have myoclonic jerks. So it's interesting to study these syndromes more in future. The EEG is classical interictally between the attack. It shows generalized spike, multi-spike, and slow wave in a rate of 2.5 to 6 Hertz. And during the ictus or the seizure itself, the polyspike become more prominent, and you can see some at the end of the trace, some artifact movement. And this is very important. If you have a patient who develop myoclonic jerks, which can be psychogenic, it is not accompanied by these classical EEG changes, and in spite of this, you will see only movement artifact. We have the chance to study this absence epilepsy with the late Professor Bariatopoulos, in which we did a video study of this syndrome, and this was published in the Annals of Neurology a long time ago. Some of you might not have been born. And the absences are very subtle, but sometimes can be overt and clear, especially if the patient is young. The EEG, we found that is distinct. It shows pulse spike and also fragmentation of discharges. Neuroimaging is not important in this condition because this is a clinical diagnosis which can be completed by doing an EEG. So MRI, you don't need to do an MRI, but in some cases in which the presentation is atypical. For example, if you have a patient with juvenile myoclonic epilepsy and he shows some mental subnormality, most likely he is heading towards a progressive form of myoclonic epilepsy, which is distinct from this syndrome. Also, some authorities advocate doing an MRI in patient who is resistant to medication, though it is not advisable by many experts because it is known that 30% of these patients might be drug resistant. So you don't just MRI patients who are not controlled. Now we come to a very exciting, interesting field which evolved recently. By doing multimodal MRI, it was found that there are some gray matter reduction in the frontal lobe, especially in the dorsolateral frontal lobe, and also the thalamus of these patients saw some volume reduction. So also it was found that there are some microstructural changes and thalamic bundle alteration. So these findings raises the possibility that the studies supported the notion that GMA might not be generalized, but it's a network disturbance. The circuit is disturbed in the thalamocortical area. And this is a very interesting finding, which was found in most of the idiopathic generalized epilepsy, that there is a disturbance in the thalamocortical circuit. What happened? I just stuck the young man. So you look at juvenile myoclonic epilepsy as a network cortical disturbances in the circuit of the thalamocortical area. It is against the old idea that in generalized epilepsy, it is mainly the cortex is the generator. But now we go to the level of this disturbed circuit. Genetics is more complex and it is polygenetics. And it is interesting to know that around 50 to 60% of relative of this patient might have an underlying seizure. So this field of genetics is so complex, and so far by studying gene mutation, around 8 genes have been discovered. And these genes may be of help in future research. I don't want to go to detail in these genes. We did a study in Saudi Arabia where consanguinity is very common and also the family size is big, an average of 5 children. And we found that in that 15 families, there is an autosomal recessive inheritance by doing with the help of Professor Baniotopoulos, who is a leader in this field of epilepsy. Also, there are some publication indicating that some of these patients might have also an autosomal dominant inheritance. But in general, this is a polygenetic, so don't take that it is an autosomal recessive or Mendelian recessive. It doesn't show the straight Mendelian pattern of inheritance. What's the importance of doing genetic study? Because, for example, if you find a gene in which GAPRE or glutamic acid pituitary A receptor, you can do precision medicine. Try to treat the disturbance in that location of the gene. And this is probably will be the future for precision medicine to find where is the defect in the genetic locus. Still, we need more to know about this complex genetics. So, anti-seizure medication, valproate is the best treatment to control generalized this GMA because it controls the myoclonic jerks, the absences, and the associated generalized tonic-clonic convulsions, but it is not the best treatment. And then I'll talk later about it. Levetiracetam have been recently introduced as an alternative, but still levetiracetam has not been proved to suppress the absences if they are present. Paracetam is an analog of levetiracetam. It's a good drug, but still not well marketed. Lamotrigine in another medicine, but you have to remember that lamotrigine might exacerbate the myoclonic jerks in this patient. Clonazepam and colbazam can be used, and from our experience, we use clonazepam as an adjunct in patients in whom the myoclonic jerks are very difficult to control. Primarily, the recent drug, some publication quoted sunamabate, which is a recent drug, which mainly marketed in focal seizure, focal epilepsy rather than generalized epilepsy. The prognosis, this is one of the best controlled epilepsy syndrome. Around 90% of this patient can be controlled. The problem is that when you stop treatment, a large number, which might go up to 90%, it might relapse. Though there are some studies showing that in minority of patients, they might go off treatment. 30% of patients of GME are drug resistant, and this is in general in all epileptic syndrome. 30% are drug resistant. So, before incriminating drug resistant, you have to exclude any psychogenic non-epileptic seizure. Of course, there is a big differential diagnosis of GME, like progressive myoclonus, eyelid myoclonus, and so on. But with a classical picture of this patient, it is easy to diagnose the condition. Remember that inappropriate medication, for example, if we give this patient sodium channel blockers or GABAergic drug, so you might exacerbate the condition. So some of these patients are erroneously diagnosed as focal epilepsy because in some of them, the myoclonic jerks might predominate in one side. Also, in a large number of patients, the EEG might show some focalities. So you should not be deviated from diagnosing GME even in the absence of a focal in the classical EEG. There are certain risk factors for having a resistant GME, and one of them is the absence seizure, because some children with childhood absence epilepsy might go to develop GME, and this might be resistant to medication. Patients with GME, they might have a high number of psychiatric problems, and therefore it can have a burden on control. Febrile seizure in association with GME also might make them resistant. If you have a patient, because I forget to mention, GME is a syndrome in which the patient develop the hallmark is morning care. 80 to 90% they might have an associated generalized tonic convulsions, and a third of them might have absences. So if a patient is unlucky to have the three types of seizure, there is a chance that he might not be easily controlled. Also, females, especially with ketamine and seizure, might be difficult to control. So in drug-resistant treatment, you seek an alternative, but neurostimulation have been done in few resistant cases. The bad news, if you don't control this patient, they might develop a high incidence of morbidity, and like any other epilepsy syndrome, if you don't control them, there is a chance of sudden unexplained death. Also, they might have a high association with psychiatric problem. Depression, anxiety state are very common in this patient. And you have to remember that if you give levetiracetam as an alternative, this drug might exacerbate the underlying psychological problem, and therefore you have to be very careful. They might have cognitive problem, and this might be related to the changes, subtle changes which have been described by multimodal MRIs, in which the frontal lobe might have some issues, and the quality of life might be disturbed. Now we come to the valproate. Valproate is the best drug to control GME. Already we know that it should no longer be given to a childbearing female because of the neurodevelopmental problem and teratogenic effect. But now some worries have been raised that this drug might affect males. The count of his sperm might decrease, but this is reversible. The most dreaded problem is that children, offspring of this patient might have some issues with cognitive function. Of course, there is no strong evidence yet, but you have to remember that as the European Medicine Agency warned against using this in men, but it's not true. Still it is used, it's a good drug. Even in female who are resistant to medication, you might try a small dose of sodium valproate, not exceeding 400 milligram in conjunction with another medication. As I said, resistance is very common in this syndrome. So still you give it to male, but some of therapies, you might discuss this possibility, rare possibility with the male that you might have some problem with offspring. Of course, if you tell him, he might not take the medicine. Breastfeeding is safe, and the IQ, which was tested in H3, it is not affected. Some worrying recent problem, which have been published recently by Meadows, who's a big figure in epileptology, between the year 210 and 220, it was found that the use of sodium valproate in low-income country is high. It's getting high with time. And this is very dangerous issue to remember. This is used in child-bearing females. Why? Because sodium valproate is effective in many types of epileptic syndrome, and also it is cheap and available. And to my mind, it is used as a broad spectrum anti-seizure medication, especially in the absence of classification of the epileptic syndrome. And therefore, you have to be very careful in using this drug. So I finished, and thank you for listening.
Thank you very much, Professor Tahir. Now, I want to be able to, hold on, wait today. I want to be able to shorten, give a little bit of resume to people who are not speakers of English. How can you tell me, how can I tell people who speak only Kinyarwanda what you just told us?
So tell them that there is a form of epilepsy occurring in young people around puberty, and this epilepsy have morning jerks as the main symptom.
Okay.
They might also have major grand mal seizure and absences. It is a treatable disease. If it's a treatable disease, if you diagnose the patient and there is a genetic tendency, but it doesn't mean that if there is a woman or a man suffering from this condition, he can produce normal children.
Okay. So Mzee Tahira yaratubwiye ko iyi presentation ibintu amaze kutubwira avuze ko hari indwara ya epilepsy cyangwa se y'igicuri iboneka mu bana batoya kubera ko kuri bya bintu byitwa indangasano umubyeyi akaba afite icyo kintu bita genetic n'umugabo n'umubyeyi w'umugore n'umubyeyi w'umugabo bose babifite, ariko abo bantu noro babyara umwana bakabyara umwana ufite iyo ndwara y'igicuri igaragazwa cyane, mbese izifite ingufu cyane. Ikindi kintu yavuze ku bintu hari igihe bayivura iyo ndwara ariko ikaresista, bakamuha imiti ariko imiti nikore nifasha uwo mwana. Ariko none n'ikindi avuze ko hari igihe ngiye nk'umubyeyi w'umugabo n'umubyeyi w'umugore tubyaye umwana n'ubu twaba dufite izo ndangasano, hari igihe tutaziha uwo mwana wacu. Yes. Thank you very much. Thank you very much, Professor. The next speaker is Dr. Arthur Rukundo, a clinician of 25 years. He's been involved in mental health sector for the last 20 years as well. He's a senior psychiatrist at Ndera Hospital and also a university lecturer. Please come and share with us, Dr. Rukundo. Please make him feel welcome.
Honorable Vincent Biruta, Rwanda Minister of Foreign Affairs, the co-host of this event. Honorable Dr. Abdul Momen, Bangladeshi Minister of Foreign Affairs. Honorable Vincent Biruta, Rwanda Minister of Foreign Affairs. Honorable Patricia, Scotland QC, Secretary General of the Commonwealth. Dr. Tedros, Director General of the WHO. Honorable dignitaries, esteemed advocates, distinguished guests, good evening. Thank you all for joining us for this crucial event. The timing couldn't be more appropriate. We are gathered under the reality that as we speak, according to the WHO, 1/8 of the people we know, 1/8 of the people that we love is affected by mental health problems. If you allow me, esteemed guest, I would like to address the elephant in the room, as none of us is strange to the health crisis that the world is currently straining to overcome. There are events that take a toll on the mental well-being of entire populations, and unfortunately, Rwandans are all too well placed to know this. Our history is not only marred by the trauma of loss and undeniably of dehumanization, our history is also defined by the monumental effort of overcoming, following unimaginable collective psychological, physical, and emotional suffering. Dear guests, the world has lost 6 million people to COVID-19. Millions of families have been ravaged by premature death, and billions of people have suffered the COVID-19's financial and social strains. And the bitterness of the COVID-19 wake-up call may long remain, ladies and gentlemen. But the prevalence and rapid increase of poor mental health among our children, our neighbors, our friends, our fellow Commonwealth citizens must be done with. We must act, and this no later than the day following yesterday. It goes without saying, ladies and gentlemen, that mental health transcends the health domain. Poor mental health breaks down our communities by disrupting the wellness of families, poisoning our socioeconomic development. Presently, poor mental health costs the world economy an estimated $2.5 trillion every year. This hemorrhage of resources, this costly human tragedy makes one thing clear. Mental health is the bedrock upon which the welfare of our communities lies. We cannot allow this foundation to crack without us joining forces to solder it. Honorable guests, allow me to make the case for substantial resource attribution to the protection and support of mental health from the lens of a country that has seen firsthand its importance in survival. Over the last decade, Rwanda has strived to implement homegrown solutions by our citizens, for our citizens in mental health and beyond. Over the last Imbuto Foundation, in collaboration with the Rwandan Ministry of Health and strong partners, recently launched the Bahoneza mental health program in Rwanda. Bahoneza tends to the mental health of Rwandans, very first day on earth, by ensuring the holistic wellness of the mother. Committed to actualizing a brighter future, Bahoneza defends the health of Rwandans throughout the life, and indeed, the birthing life. Ladies and gentlemen, the time is now. We need and must invest more financial resources in mental health research, prevention, skills, training, and treatment. We need and must eradicate mental illness stigma and develop a global culture of tolerance and self-accountability. We need and must deploy effective collaboration between mental health experts from public and private sectors, from state and non-governmental agencies across the Commonwealth to build resilient structures of mental health support. I thank you for being here and to define the way forward and improving mental health in Commonwealth member states. There is no health without mental health. There is no development without mental health. There is no brightness in our shared future without mental health. And ladies and gentlemen, there is no Commonwealth without common mental health. Thank you. The co-host of this event.
Yeah, good morning. It's a great honor to be with you today, to not only to participate in this great Congress, but also to be with you and share with you on this topic of quality of health, quality of life in neurology and psychiatry. So I don't know what I can add after this speech. This is the best speech I've ever heard about brain health, because here we are talking about brain health. We are sharing about brain health. And let me start by that quote that we see that it's not well visible. There is no health without mental health. There is no health without brain health. So here, as we see, we are talking about advancing brain health and mental well-being. Our First Lady has mentioned about stigma, and let me tell you that there is stigma. There is stigma about mental health. There is stigma about brain health. So it's good. This is a brain week. But if you see, we have, from the first day, it is stroke, it is epilepsy, and it is not even all chapters of neurology. Yes, but have you heard about chronic stress, for example? Have you heard about depression? Have you heard about schizophrenia here? So that are very clear. For example, here in Rwanda, 1 person in 5 is affected by a mental health problem, a mental health condition. And who's coming to consult? Very few. So 20% of the population is too much, isn't it? It's too much. But for the 20%, how many are consulting and how many are treated? Also, it's less than 10%. So you see that we have a great job to do. So before I continue, let me salute all professors who are here. You are in Kigali, you are in Rwanda, please welcome back. May this Congress not be your last time to be in Kigali in Rwanda to share with you or to meet you. Because when we are with you, we learn a lot. I did my residency in psychiatry in Senegal, in Dakar, and it was a great moment for me. And let me share with you that I refused to do my residency in Rwanda. So you can ask me why. Because when I finished medical school in 2000, I take time to decide about the specialization I can do. So the question comes and say, if people who have trained you to become a medical doctor, are they the one who will train you to become a specialist? This is not. You understand? That is why I say, okay, let me go abroad to do my specialization. And we still have few professors in Africa. We still have few professors. So if I say here how many professors are in this room, you will see there will be 3 or 4. So I'm a senior psychiatrist. I'm a psychiatrist now in practice since, my journey in psychiatry started in 2005. And now it's 20 years. So stigma again is there. You know, when you are a medical doctor and you decide to become a psychiatrist, you know how your colleagues see you? Say, Doc Arthur, how? You go in psychiatry? You want to become a psychiatrist? Say, it seems like it is the last choice you can do. It seems like it's the last choice. How you become a psychiatrist while you can be a good gynecologist or a good surgeon? I remember I did my thesis of medicine in surgery. I was very good in surgery, but the destiny is the destiny. Your destiny is your destiny. Your choices are your choices. Don't let anyone choose for you. Because if someone else chooses for you, you will become what he wants you to become, not what you want to become. That's a problem. And if you face problem, and if you face challenges, you will, you will stay down. So, psychiatrists, I think I'm the only psychiatrist in this room. Is there anyone else? A psychiatrist, not resident in psychiatry. I say, a psychiatrist. How many here in this room? You see the stigma? You see the stigma? This is because psychiatry or brain health is not well explained to young doctors who are finished. It is not well shared. Up today, the training of a young medical doctor who wants to become a doctor, a GP, he come in Ndera Hospital, which is the only hospital we have in Rwanda. The only one. For 2 weeks. So how can you compare? I do my residency for 4 years and my residency for 2 weeks. Do you see the... Yes. I have been in Senegal, and in Senegal, a young doctor, an undergraduate,
he is in the department for 1 month, not 2 weeks. And fortunately there they have professors. I remember even the chief of the unit where I was a professor. But the reality is not the same in other African countries. You know that we have even African countries where they have just one psychiatrist. One. So can we say that there is no health without mental health? Can we say that mental health transcends the health domain? I don't think so. So there is a lot of work to do. As you see me here, I have served for like 25 years. I'm a Rwandan psychiatrist, but for now, I'm an African psychiatrist because I want to expand my expertise in other places where they don't have psychiatrists and encourage young doctors to become psychiatrists. So if you see in Africa, because we are saying about Africa, how many neurologists we have in Africa? And how many psychiatrists we have in Africa? This is brain health. So I salute the presence of my colleague for many years here. Let me tell him to go up. I'm talking about Dr. Awaziremo, please. A great doctor who helped children. Why I call for him? Because we have to work together in our practices. You know, we have to communicate it together. We have to share our practice. When you have a limit, call your colleague. Yes. So we have to complete ourselves in our practice. So let me go with the presentation. Improving quality of life. I'm sorry for the mistake there. Quality of life for neurologic patient. Yeah, living with a neurological disorder is, can significantly impact an individual life. Disorders such as Parkinson's disease, epilepsy, Alzheimer's disease, or stroke can alter physical capabilities, disrupt cognitive functioning, and affect emotional well-being. The well-being is there again. Mental well-being. Neurological disorder result from abnormalities in the brain, the spinal cord, or nerves that can cause a wide range of symptoms, including movement problems, pain, confusion, even memory loss. So apart from the physical discomfort, individuals living with neurological disorder often experience emotional distress, including feelings of frustration, fear, anxiety, and sometimes helplessness. So I have 4 minutes. I will accept for me to be a little bit fast. So healthy lifestyle. What is a healthy lifestyle? So there is mental well-being. So maintaining a healthy lifestyle forms the bedrock of managing any health condition. Consuming a balanced diet, rich in fruit. So the diet is back here. How is our diet? You know, because I didn't tell you, I tell you about my experience, but let me tell you that I don't look my age. It's a secret, but some people here knows, how old am I? But I don't look my age. Why? Because what I've learned in medicine, I applied in my life. So here we are talking about half of the population, but we have also to think about health or well-being of practitioners in health. You know how many doctors are suffering from diabetes, high blood pressure? So allow me to talk about also lifestyle, because lifestyle is very, very important. Okay? So balanced diet, rich in fruit, vegetable, lean proteins, and whole grain can help maintain overall health. Regular physical activity. How many here do sport every day? Every day. According to WHO, we must do sport every day. 30 to 45 minutes per day. Ninde ukora sport hano buri munsi? Who do sport every day 40 minutes per day? Doctors. So I do. And very important. Yes. So if we want to give health, we must be healthy. Isn't it? Yeah. Tailored to the patient abilities can enhance muscle strength and coordination, improving mobility. Physical exercise also plays a crucial role in boosting mood and combating symptoms of depression, a common occurrence in individuals with a neurological disorder. Following the prescribed treatment plan or taking medication as directed and keeping regular medical checkups can significantly improve the management of neurological disorder. So you know many patients we follow in our settings, they don't have a good discipline of observing our treatment. That is why many of them, they come back in a bad situation. So it's crucial to report any new symptoms or any exacerbation of existing ones to your neurophysician promptly. This open communication allows for timely adjustment to treatment plan and helps prevent complication of disease. So physical therapy and rehabilitation is very, very important. So physical therapy is a critical component in the treatment plan for many neurological disorders. It helps to improve mobility, strength, and balance. So stress management is very important here. So stress, many people are stressed, you know. Many. And unfortunately, many, they don't know how to manage stress. We all face stress, but the management, how we manage stress is different. That is why people must know how to manage stress. And remember that all chronic conditions, they have behind a chronic stress situation. So very important to talk with your patient and see how to manage, how to tell them how to do a good psychoeducation and tell them how they can manage their stress. So managing stress level is essential in patients living with a neurological disorder. Mindfulness also technique, meditation and yoga, can help reduce stress and promote relaxation. Hobbies that provide joy and fulfillment. Ask yourself, what is my hobby? Yes, very important. Because when you are in a relaxing moment, you must be in a hobby place, in a place you like. Yeah. So, such as music, or art, or gardening can also serve as effective therapeutic moments. So, thank you very much. I see the time is over. Let me show this. This picture is very important for stress management, for yourself, for ourselves, and for our patient. So as you see there, the doctor must be there. The health practitioner must be there to add his input. Music is very important. I think tomorrow we'll have time for music, all of us. So to go in spa is very good too. Yes. Time management. Time management is very important, isn't it? I see my friend there. So, and to go in nature also is very important. And to do sport, of course, is very important. Thank you very much for a good, kind attention.
Thank you very much, Dr. Rukundo.
Oh, yes.
One of the things I've learned this morning, or that there's a common thread. There's a common thread, and the common thread is that there's a lot of how do we upscale, right? We don't have enough neurologists. We don't have enough psychiatrists. How do we upscale, right? If we're training people for 7-10 years, right? How do people right now get the help that they need, right? So, And the
So
common
it's
thread,
a challenge.
that's right.
It's
And
not
the common
possible.
thread here this morning and yesterday and a few last days we've been here is that we need to work together. We need to share a lot of sharing, and we can leverage technology, I think,
Yes.
in that way. But before I give the mic to the floor, I would like you to Dr. Rukundo to just give us a summary or a resume, a summary of what you just said about in Kinyarwanda. Just 2 minutes. Byihuse cyane.
Murakoze cyane. Natangiye nivuga ndi umuganga umaze imyaka 25 nkorera mu Rwanda. Muri iyo myaka 25 nkaba narafashije narabaye mu bijyanye n'ubuzima bwo mu mutwe mu myaka 20 imazemo. Murumva aho nkorera mu bitaro bya Ndera, ni bitaro bizwi cyane hano mu Rwanda, kuko unarebye n'ibyo bitaro byonyine dufite mu Rwanda bifasha abantu bafite ibibazo byo mu mutwe. Muri iyo myaka 20 nabonye byinshi. Ni n'ibitaro bifasha abantu bafite ibibazo byo mu mutwe, nabyo twita maladie psychiatrique, ariko bikanafasha n'abantu bafite ibibazo by'imyakura cyangwa maladie neurologique. Hano turi kuvuga ku bijyanye n'ubuzima bwo mu bwonko. Abantu benshi bakunze kuvuga ubuzima bwo mu mutwe, ariko hari ubwonko hakaba n'ubuzima bwo mu bwonko. Ubwonko bushobora gukomereka ukagira paralizi. Bashobora kugutera ibuye ku mutwe cyangwa bashobora kugukubita icupa ku basore basohoka, bashobora kugukubita icupa ku mutwe ukagira ikibazo cy'imyakura. Hari ibibazo byo mu mutwe, sibyo? Ariko hakaba n'ibibazo by'ubwonko. Umuntu wese ujya kwivuriza ku bitaro bya Ndera ntago biba bivuze ngo afite ikibazo cyo mu mutwe. Mu byumve neza. Hano turi gutanga ikiganiro tuvuga ukuntu umuntu wagize ikibazo cyo mu mutwe cyangwa cyo mu bwonko agomba gufashwa. Nabivuzeho, nta nugufata umuntu, murabizi hano twabibonye, umuntu ni mugari. Wowe muganga nawe uri mugari. Umuntu naza kukwivurizaho ntukarebe ibimenyetso gusa, reba n'ibindi bibazo ashobora kuba afite, kuko birashoboka. Mwabonye umuntu wigishije hano mbere yanjye yavuze ku bibazo by'ubuzima, kuri trauma umuntu ashobora kugira maze akaza akubwira ngo arwaye umutwe. Utamuvuye, utamenye ko afite ikibazo cy'ubuzima yahuye nacyo, ntago wamufasha neza. Wowe atanga ikinini, ariko ikinini ntago cyajya kuvura trauma. Mwabonye ikiganiro nyakubahwa First Lady yatanze. Njyewe kira kiganiro ndagikunda cyane kuko harimo amasomo. Aratubwira ko iyo nta buzima bwo mu mutwe umuntu afite, nta buzima bafite. Tuzajye twiyitaho, tuzajye tumenya ukuntu tugomba kwita ku buzima bwacu bwo mu mutwe. Tubone umwanya wo kuruhuka, umenye ibyo ukunda, usohokera aho ukunda. Niba uri umuntu ufite urugo, sohokana n'umugabo wawe. Niba uri umuntu uraho ufite akazi, ntukore kuva kwa mbere kugeza ku cyumweru. Hanze hari abantu bakora kuva kwa mbere kugeza ku cyumweru bataruhuka. Reka mbabwire ko bari abantu n'abakiriya banje. Umuntu wese uzi ko ataruhuka, umunsi umwe aza muri biro yanjye. Ko kutaruhuka, kutaryama, turi mu isi iri kwihuta cyane. Udasinziriye ejo bundi uzaza. Ni byiza kumenya kwiyitaho. N'abarwayi batugana turabigisha. Harabo dukoresha siporo, harabo dukoresha physio, harabo dushiraho ka music, kuko ushobora kuburaho mu gihe turi kukuvura tugashiraho indirimbo. Mu gihe turi kukuvura, mu gihe bari kugukorera physio bakakubaza ukuntu bayeho. Kuvura umuntu nukumuvura muri rusange. Erega n'abanyarwanda barabivuze, umuntu ni mugari. Nushaka kumuvura umuntu neza, uzamuvure mu bugari bwe. Murakoze cyane.
Professor Shehu.
Thank you very much for the insightful talk, and really the challenge not only to us as professionals but to the nations of Africa as a whole, with particular reference to the needs of psychiatry support in Rwanda. And I really hope the government takes heed on this. The unfortunate situation is you cannot be reproduced or recycled within a very short space of time. So to think of getting psychiatrists in Rwanda like another 10 or so, God knows how long that will take. But what can be considered is the possibility of training some of the healthcare workers or community psychiatric nurses who can learn some skills, whether it's in stress management, identifying depressed patients, identifying other aspects of mental health, that they can give some basic advices to these people where they are in their homes, and then escalate those who may require to be escalated because the condition is so bad. That's my first recommendation. My second point is about the issue of the stress management and things like that. I think one aspect we're missing is the prevention of stress. That also needs to be emphasized, because we as individuals, we have the right to prevent stress to hit us, because we accumulate things, problems one after another coming to hit us. We don't know how to say no to people who demand our time. We always keep giving in until one day we can't do anymore, and we feel the world is on top of us. That is our making. So we need to prevent that from happening, then we are not overwhelmed. Secondly, we need to make sure we pat ourselves on the back to be happy with what we've achieved. There are many people who move the goalpost. The moment you achieve something, then it's not good enough. You have to achieve more. You have to achieve more because you refuse to be happy. Why can't you be happy with what you achieve? So that also makes you become more stressed because you're not actually looking after yourself. So there are many of these things that we can look at. There is a statement that says, you can't control your thinking, but you can control what you dwell in. So let's control what we dwell in to be something that is positive. And when you're faced with any information, before you give it a negative connotation, find the positivity within it first, and see it even as a challenge of something that can boost yourself to be a better person, even if there is all negative around it. Because you don't know the wisdom of challenges, you don't see the result or the outcome of that until it passes. Then you will realize you have learned a lesson for something bigger to come. Thank you.
Thank you, Professor. Professor Sheikh. Before just to translate a little bit, and I really insist, we're insisting that we translate in Kinyarwanda because we have community health workers who need to take this message back. So it's really important that we translate this in Kinyarwanda so that they have a takeaway messages for them. So please bear with us as we do this because it's very crucial for them to understand what we're talking about. Professor Shehu yari avuga ati ikintu cyangombwa ntabwo kuba umuganga, kuba umuspsychiatrist bitwara imyaka hafi 10. Abantu bakeneye ubwo bufasha bwacu bari hano none, ntabwo badutegereza imyaka 10 kugira ngo umuntu ajye muri kaminuza arangize. Nibwo bavuga rero abantu mwe mukora muri centre de santé mufasha, mukaza mu mahugurwa gutya, mugahugurwa, mushobora guhugurwa mukamenya uburyo mwakangurira abaturage uburyo birinda kugira izo ngorane zituma ubwonko bwabo burwara. So icyo nicyo kintu cya mbere yavuze. Ikindi aravuga ati ahanini gukorera hamwe, gukorera muri what do you say, gukorana n'abandi baganga. Yego.
Hari ikindi yavuze cy'ingenzi cyane, kuko abaganga ari bakeya, abo twaba doctors, ni byiza ko dukora n'abaforomo n'abapsikologe bose tukabigisha, tugakorana ku buryo aho tutari bashobora kudufasha. Yavuze ko ari byiza ko dukorana, tukagira amakipe, reka nbyite gutyo, tugakora nk'amatimu.
Professor Sheikh.
Thank you very much for this very heart-touching actually approach, and also thank you very much. We have been talking about stigma about epilepsy and this, but there's also sometimes unfair stigma about psychiatry, and many of the people who do not realize that 90% of the human being is psych, and only 10% is chassis and the tires and the other hardware. The hardware is the neurology, and the software is psychiatry. And if they don't work together, the outcome is not good. And equally, it is not all, health is not only doctors. Health is first is patient, family, community, and then it comes to medics, primary healthcare center. regional hospital, tertiary care, and then educational and investigation and research and extravaganza and big ties and nice coats. The most important message I understand here is that those are the villages and those are the grassroots must be empowered with recognition, positive support, appropriate knowledge, good training, and good life. You cannot, one person or two people, transform a country which has been traumatized by an insult which is beyond human tolerance, like Rwanda. I applaud Rwanda. I applaud people working in Rwanda. But the community here must have like continuous awareness of the importance of getting involved with psychiatric management. It does not need to be by the psychiatrist. It needs to be by the community workers, the trainers, even the community leaders. They receive training, they go back, they help people. Recognition by giving them formal training, so they will get certificates. If one gets, bachelor in community psychiatry, or even this is called for the universities to open avenues, not necessarily for medical doctors, because many medical doctors you need clinical psychologists, you need community educators. Now he is translating, which is really good, because what is the point of we speak in English and in French, and many people here, whatever English they know, they will not be able to conceive what is going to be tried to communicate. So I would suggest you should build a platform, not necessarily, in complicated, but everybody has a mobile phone. If you generate just small software, basic information, post-traumatic stress syndrome, how to manage anxiety, like what we are doing for the organic diseases, which I said 10%. But imagine if you empower a mother, what to do with her ADHD child, what for a father to do for his brother who became schizophrenic, what to do is somebody who's stressed and cannot do the examinations. What about a young bride girl who cannot go to school because she has school phobia? These things cannot be done by one person. And I don't think in my lifetime I would see where there will be enough doctors for Africa or enough neurologists, leave alone enough psychiatrists. So I would think you should start a platform. Call it Rwanda, whatever. You have the technologies, you have clever people who can do it for you. And message to the doctors. I think in the training of all doctors in Africa, there should be a decent amount of time for training in psychiatry. Because I did neurology in the West, so it was compulsory for me to go and do psychiatry. I cannot be a neurologist if I don't understand.
Yeah.
But is it part of curricula in our countries? It is not. So we have to push towards getting this not imposed, but I think also should be in the agenda of higher education. Thank you very much.
Thank you very much, Professor O'Shea. Yariho aravuga ati umubiri w'umuntu ngo umuntu
ni mu mutwe.
Umuntu ni mu mutwe. Yeah, umuntu ni mu mutwe. Yaravuga ati umutwe, ubwonko ni 90% by'ibitugize. Izindi nyama, indi mubiri ni 10% gusa. Ngo hakaba hari rero ni ngombwa ko abantu tumenya twita kuri iyo 90% itugize. Urumva? Ikinavuze nyine nibyo tuvuga, ni gute dukeneye abakozi b'ubuzima benshi, ni gute tubageraho byihuse. Ikindi kintu yavuze ko twakoresha technology, dufite telefone, ni gute leta mwebwe muhura n'abayobozi mukaba bavugizi babo barwayi banyu, babyita advocacy. Urumva, tukaba advocates b'abarwayi tuba dufite, tukabavugira, noneho leta igashiramo imbaraga mu gukora iki, mu gutanga imfashanyo, mu gufasha abantu ko habaho platform. Urumva, ivuga ati umwana wanjye ndabona ameze gutya, umubyeyi wanjye yagize stroke, umuturanyi wanjye yarwaye gutya, ni buhe bufasha namukorera, namufasha kugira ngo abashe kubaho ubuzima bumuhesheje ishema. Any last word? Concluding? Okay. So, mumfashe dushimire Dr. Rukundo. Dr. Rukundo ari hano. If you have a question, please feel free to catch up with him. We're going to have a panel, and a panel that is from Partners in Health. This is what we're talking about. And Partners in Health has been one of the major sponsors for this event, and we can't thank them enough for their support, their ongoing support in this as you see, as you can see, and as you can hear the debate here, it's a very important topic and a very timely topic. And for me as a Rwandan, nearly 30 years, I think we should have had this, 1995 or 1994, this thing, right? But here we are. So it's a very timely conversation that we're having in Kigali. But we also have health workers from across the country who will take that message back, whatever their learnings today and over the course of the conference. They will take those messages back and then we'll reach masses that way. I'd like to invite Mr. Eric and his fellow panelists. Eric will be the moderator, but also wanting to thank Eric and the organization that he works for, Partners in Health. And I will please join me in thanking Partners in Health in being one of the major sponsors for this event. So, Ndakureka, we introduce you.
Mwiriwe, we are in the afternoon already, and these discussions that we have been having here are very insightful and really very informative. And I'm really happy that this session comes after the first ones you have about epilepsy. Then the one you have after Arthur, Dr. Arthur, for this. Actually, he's one of my seniors in Rwanda. I'm a medical doctor as well. My name is Eric Baganizi. I work for Partners in Rwanda. For the last 11 years, I lead clinical programs in Partners in Health, where mental health program is under as well. So the session we are going to hear about is almost a continuation of what I've been talking about. That beyond the clinical wars, the mental health diseases do not get cured into the hospital only. So as Partners in Health, we have been learning this as in a hard way. The mental health recovery does not happen in isolation. Usually it doesn't only happen through medications only as well, but it has to be clinical care, psychosocial rehabilitation, family support, and community support. It's almost what Dr. Arthur was saying. Our approach is really rooted into social medicine, where we look at the person, not at the disease. A holistic approach to the person. Who is the person coming to us? Where does the person coming from? What does he need? Is he really the disease from just being the disease, or from other conditions that are associated to that? At Partners Health, from the last 15 years, we have received almost more than 18,000 people in our mental health programs, and we have tried to approach this holistically, think about the social ecosystem that the person lives in. That's why we have started programs such as problem management plus at the community level, and also psychosocial rehabilitation at the community level. People come to us through different channels. Some of them come direct to the hospitals, some of them come from the communities, and we have been supporting them to get from the hospital up to the community level. That's why what you're going to hear today, what have we done, what have we learned, and actually, how is the person who lives these conditions these days? How does the person really go through these challenges, navigate the system to get back to the community and be a father, be a mother, be a sister, be a daughter? Thank you, and I'm going to invite my fellow panelists. Ndagira ngo mpite mbivuga nihuse mu Kinyarwanda kugira ngo n'abandi bashe kubyumva. Partners in Rwanda mu Rwanda abantu tuzi ku izina rya inshuti mu buzima. Niho cyane tumenyerewe. Dukorera mu bitaro bitatu, mu turere dutatu, bitaro bitatu, akarere ka Kayonza mu bitaro bya Rwinkwavu, niho twatangiriye, akarere ka Kirehe n'ibitaro bya Kirehe, n'akarere ka Burera mu bitaro bya Butaro. Programme yacu y'ubuzima bwo mu mutwe ntabwo ari programme tubona mu bitaro gusa, tuyibona no hanze y'ibitaro. Ese umurwayi watugezeho asubira gute muri community bisanzwe aho yaratuye? Kayerekere tubivuga stigma akata abantu bahabwa bigenda gute? Twebwe rero muri PIH twabifashe nk'inshingano zacu, tubona umurwayi atugezeho kwa muganga, ariko tukavuga tuti uyu murwayi namara gufata imiti hano, namara kumera neza, nasubira aho atuye biragenda bite? Ese arabaho ate? Ese arabana n'abandi gute? Ese biramufasha gute kugira ngo yongere abe umupapa, yongere abe umubyeyi, yongere abe umwana, yongere asubire ku ishuri, yongere yifashe? Nakakato abantu baha abantu bamubwira ngo afite ibibazo byo mu mutwe, wenda avuga ati ntashoboye gukora, ntashoboye kugira gute? Twebwe tumufasha kubinyuramo bimworoheye, kandi natwe tugafatanya na leta kugira ngo bidukundire. Ni muri urwo rwego ngiye guhamagara abantu bari bumfashe muri kino kiganiro. Werarise Nsanzabaganwa ni umuganga wacu ukora ku bitaro bya Rwinkwavu, adufasha kureba hari umuntu wavuze mbere yanjye yerekana igicuri agashyiraho utuntu tw'udushushanyo dusa n'uduhagaze ukuntu. Uyu muganga mpamagaye afasha abarwayi kugira ngo tumenye koko bihagaze. Ndongere mpamagare umwe mu bantu twavuye kandi n'ubu tugikurikirana, Mwiseneza Jean Claude, ni umurwayi twafashije aturuka mu karere ka Burera, ni karibu hano. Nongeye mpamagare Beata Nyirandagijimana, ni umukozi wa PH mu Rwanda ashinzwe porogaramu y'ubuzima bwo mu mutwe mu karere ka Burera. Ndanongera mpamagare Diane, ni titulaire w'ikigo nderabuzima cya Ndongozi. Mpamagare n'umukozi wo muri RBC Emmanuel Hakomeza ushinzwe ubuzima bwo mu mutwe bwo mu ngimbi n'abangavu muri gace ka RBC gashinzwe ubuzima bwo mu mutwe ariko muri community no kuntu basubira muri community. Murakoze cyane. Karibu. Iraje nta kibazo. So I'm going to be asking some few questions and we're going to discuss. This will be an interactive session, and I hope that at the end of the session you will be able to to see how the journey of a patient, mental health patient, is in Rwanda, and how we as a country and PIH are supporting the patient to go back to the community. I want to start with Weraris. You can speak in another language. I will be translating a bit. Ngiye kukibaza mu Kinyarwanda, wenda urasubiza mu rurimi wumva nongeye na translating. When you see a patient who comes to your clinic requiring EEG, what happens? How is the patient? How the patient leave your office with the result? How do you support that patient to get to know the diagnosis? Thank you. First, introduce yourself before. Thank you.
Thank you very much. My name is Weraris Nsanzabaganwa. Basically, I am a mental health nurse and EEG technician. Me being performing EEG is a way of task sharing. I'm not a neurophysiologist, but I'm able to perform EEG for the last 10 years. Back into the question, as IMB works in the rural community, and as have seen, epilepsy is among the higher number of the patients who come to consult in mental health clinics. So, being in the rural community, the patients also have burden of reduced financial means. So getting to the hospital, doctors or healthcare providers most of the time request EEG to support the diagnosis. But the patient, most of the time in the past, were not able to go far in the city in Kigali to perform an EEG. So since we are performing EEG in the rural hospitals, the patients are relieved, are very happy. They say, finally, the test is done. Probably, I'm going to get treated. It's the message of relief. Even though it's not EEG who's going to treat the patient, but on one side, the patient is relieved that at least he's able to have a test that he was not able to go far to perform. Thank you.
Thanks, Weraris. One of the things I want to add on before I translate in Kinyarwanda is the task shifting you have been talking about. He's not really an EEG technician, but someone who learned to perform EEG, and he's performing it and interpreting it properly in a rural setting, not in the city of Kigali, in a rural setting where you support the patient nearby their communities. Weraris aratubwiye ngo iwe iyo abarwayi bamugezeho akorera Rwinkwavu ndetse akajya anajyana Burera na Kirehe kuko tutafite izo mashini za EEG zifasha kureba uko ubwonko bukora. Amurwayi amusangaho ntago twongera kumuhereza i Kigali ahubwo amureberaho akamuha n'igisubizo aho ngaho, bigatuma umurwayi avuga ati nge nsohotsemo hano ndi Rwinkwavu cyangwa se ndi Burera cyangwa se ndi Kirehe kandi mfite igisubizo, ndizera ko ngiye kubona imiti ya nyayo ijyanye n'uburwayi mfite kuko uburwayi bwamenyekanye. Niyo mpamvu bidufasha cyane kugira ngo tumenye uko umurwayi ameze. Arakoze cyane Weraris. Jean Claude, uratangira wibwira abantu noneho unatubwira urugendo rwawe byagenze gute mu burwayi bwawe.
Urakoze, nitwa Mwiseneza Jean Claude, mvuka i Burera mu murenge wa Cyeru. Ubwo nari kuva ahantu nagiye kumva numva hari ikintu kije nk'igicu mu mutwe, nikubita sinari ndi n'igare, cyakora ngira amahirwe mbona umuntu w'umukobwa anjyana ku bitaro bya Kirambo, ngezeyo bampa imiti arantegera ndagaruka ngera mu rugo. Ubwo icyo gihe mara igihe cy'umwaka ntasubiye kwa muganga, mvuga ko hari igihe ari amarozi baba barandoze. Ku bw'amahirwe mpura n'abajyanama bangira inama nerekera ibitaro bya Ndongozi. Nkigerayo umuganga amusobanura ukuntu afashwe, arambwira ariko nyuma gakeya nigena nitura hasi buri nko mu minsi ibiri buri munsi, hari n'umunsi nituraga hasi kabiri cya gatatu. Noneho angira iyo nama nerekera ibitaro, nsobanurira muganga uko ndwaye, arambwira ati ni igicuri. Ku bw'amahirwe ampa imiti nkomeza kwirya, igihe kigeze arambwira ati jya kwa Ibutaro ku bitaro bikuru bankorera ubuvuzi ku mashini. Barambwira ati icyo urwaye ni igicuri, tumaze kubyemezwa n'imashini. Noneho ubwo nkomeza kurya imiti, ngera ku bitaro bampa amarandevu nkayubahiriza mpere icyo gihe. Kugeza na n'ubu ngubu hari n'ubuvuzi bujyanye n'ibiganiro baduhaye, ubwo bazaga mu byumweru 9 bakatwereka uburyo tuganira nabo, bakatwereka n'uburenganzira twifiteho, ndetse n'igihe tugiye gusubirwa bakabitubwira mu icyo kiganiro, batubwira uburyo twakwitwaramo igihe tugiye kumva tugiye gufatwa, ko tugomba kwicara ahantu tukabanza gutuza gake gake. Batubwira ko no kwegera amatsinda tukaganira nayo bizadufasha. Bere icyo gihe twashinze itsinda, iryo tsinda ryatwemeza intego yo guhinga no korora. Ibyo byose tubigeraho. Nanjye ubwanje ndavuga nti nihaye intego nzageraho mu uyu mwaka. Intego niyemeje niyo kugura intama, iyo ntama ikazamfasha mu buryo bwo kuza abana banjye mbarira bakajya ku ishuri. Ku bw'amahirwe na n'ubu icyo nshimira ni uko leta yadufashe kutwegereza abaganga, igihe cyose imiti tukayibonera igihe. Murakoze.
Arakoze cyane Jean Claude. Arakoze. To summarize, his journey started when he was on a bike, then he fell down on the bike, went back home. He did not go back think that it was a serious issue, but he thought this was poisoning. Then he spent a whole year without going back to going to any clinic to see what's going on. Then at the end, he continued to have episode of fainting. Then at last he went to health post. The health post transferred him to the health center. Then the health center transferred him to Butaro Hospital, where he received an EEG examination that confirmed he had epilepsy. From that time, he started getting the right medication. Then afterward, as we are he introduced somehow the next topic I'm going to talk about. PIH supported him to integrate a self-help group so that they can start psychosocial rehabilitation. In their group, they have thought of farming as a project, and they have what they have to achieve. For himself, the aim he has is to take his children at school. Actually, he has 5 children, and also be able to buy some livestock for him to be able to sustain his life. Thank you. Urakoze cyane Jean Claude. From that discussion that Jean Claude gave us, we have the health facility level, but the people have to go back to the community. What happens to that level? Beata. Iyo abarwayi batugezeho bigenda gute, bava ku bitaro gute, tukagera gute muri aho batuye kugira ngo basubire mu buzima busanzwe. How does that happen?
Thank you. I'm Beata Nyirandagijimana. I'm a psychologist by profession. As Dr. Eric mentioned before, we are treating the patient using pharmacotherapy or psychotherapy, and also we have patients with epilepsy. After treating our patient, yes, most of the time our patients are doing well, but we end up finding out as we are working in a rural area that most of the patients are poor. And like the people we receive in PM Plus, which is problem management approach we use as a psychotherapy approach, we find out that mostly the patient we receive, they have depression. And we find out that sometimes depression is caused by poverty. They complete 5 sessions, but after completing 5 sessions, you find out that the cause is not really tackled because they go back to the poverty, which means the relapse may come. The same also with patients with epilepsy. They may be taking medication, but sometimes they end up stopping taking medication because of lack of food. So that's where we had to think about when they go back to the community, how can they continue living? Even their family have to live. That's where we're providing like a social support, like food package, but this is something which can help them like 1 week or 2 weeks while the family have to continue living. That's where comes a psychotherapy approach, where this is a structured curriculum which has 9 sessions, where we put the patient in a group of 15. We teach them different sessions, like as he mentioned about gender-based violence, because some of our patients are facing violence in the community and they don't know their rights. We teach them how to set a personal goal, because before they achieve the goal, they should set the goal before. We teach them, we strengthen their capacity to set their personal goal. If, as he mentioned, like they are doing farming, others are doing agriculture, others are doing tailoring. So the goal is set based on patient interests and also capacity or ability, because they are not all at the same level of improvement. That's why we should look on patient capacity or ability of functioning, so they can choose what they are interested in doing based on their capacity. We also teach them about relapse prevention, because sometimes our patients, you find out that sometimes they don't know the signs and symptoms, but through those models, we teach them how to recognize the signs so that they can immediately go to the hospital before the illness attack them. We also teach them on getting along with other people, like communication skills in their business, because when they start the business, for example, like tailoring, they should know how to communicate to people in order to attract the clients. So all those skills are being taught. So he's among the patients who completed those sessions. And we also assessed the improvement of the outcome of the session using a tool called the WHODAS, that's World Health Organization Disability Schedule, which mostly is looking about the disability due to mental illness. We also used another tool called the RAS, which is Recovery Assessment Scale, which mostly focus on recovery. So actually, we assess them before they start the intervention. We also assess them during the intervention and at the end also of the intervention. So those we started with, the score showed that they are really improving, which means the intervention is being scaled up to other health centers where patients are being helped in the community. And what I can also add on that is not PIH, which is only delivering the intervention. We work with the health center. We have psychologists and psychiatric nurse or social worker who are delivering the intervention, which means even non-specialized people, they can support the mental health patient. Thank you.
Thank you, Beata. Mu magambo make Beata atuganirije ku buryo abarwayi bava kwa muganga bakagera aho batuye bagakomeza gufashwa bijyanye n'abantu bose ari abavuzi bo kwa muganga, abaganga bari bakora kwa muganga, ndetse nabo basanze muri community. Abarwayi bakajya mu matsinda y'abantu 15 bagakora bakiga inshuro 9 ibyo babigisha, bakanabafasha kwishyira muri ayo matsinda, bakishyiraho intego zabo z'ibyo bazageraho bitewe nuko bahagaze, nuko babona bo icyo babasha kugeraho. Hakaba intego y'itsinda, hakaba intego z'umuntu ku giti cye bitewe n'icyo yumva ashobora kuzageraho, kuko abantu bafite uburwayi butandukanye. Ikindi kiriho muri ayo matsinda bafashanya kwigiranaho uburyo babasha guhangana n'indwara barwaye, kandi bakaniga uburyo babasha kumenya niba bagiye kongera gusubira mu burwayi bukabije bakajya kwa muganga hakiri kare. Ayo matsinda bahora babareba uko bahagaze, ndetse bakanamenya niba umuntu yaba yabashije kugera ko nakwita ku gukira. Muri ibyo, all of this is done at the community level, but the patients are at the facility level. In Rwanda, the health facility are run by healthcare professionals, but we are trying to have a model that integrates both the health facilities and the community. That's why today we have one lead of a health center, Diane, who leads one of the health centers where we start this program. Diane, umuyobozi w'ikigo nderabuzima, ubundi tuzi ko abayobozi b'ibigo nderabuzima bari bita cyane ku bijyanye n'ubuvuzi. Ese mwebwe ku kigo nderabuzima cya Ndongozi byagenza gute kugira ngo mubashe guhuza ibyo kuvura cyane cyane abantu bafite uburwayi bwo mu mutwe, ndetse mubashe no kubakurikirana aho batuye, mubashe no kubafasha nk'abantu bakorera kwa muganga? Wenda batangira bibwira abantu bari hano.
Murakoze cyane. Amazina nitwa Iradukunda Diane, ndi umuyobozi w'ikigo nderabuzima cya Ndongozi, ni muri Burera, amajyaruguru y'u Rwanda, mu bitaro bya Butaro. Murakoze ku kibazo cyiza mumbajije. Nibyo koko abayobozi b'ibigo nderabuzima tugira inshingano nyinshi, ariko duhereye aho twatangiriye kugeza uyu munsi ku biganiro byose byagiye bitambuka, ubuzima bw'umuntu navuga ko bushingiye ku buzima bwo mu mutwe. Rero iyo tuvuze umuntu ufite ikibazo wenda cyo mu mutwe, wa muntu ari muri community. Muri community ni handi dutuye, hari abaturanyi, hari abanyamuryango bacu, hari abayobozi b'inzego z'ibanze, hari n'abajyanama b'ubuzima. Rero uwo muntu iyo agize ikibazo, izo nzego uko zikurikirana navuga ko zifite uruhare rukomeye cyane, ndetse tunashimira mu gufasha uwo muntu. Ni ukuvuga nibyo koko ubuvuzi navuga butangirira hahandi kuri community, kuko niba bamubonye baramufasha bakamuzana ku kigo nderabuzima. Rero iyo bamuzanye twebwe turamufasha, tumufasha mu buryo butandukanye bitewe n'ikibazo umuntu afite. Dufite ubuvuzi navuga buri mu byiciro bitatu. Hari ubuvuzi bushingiye ku biganiro, hari ubuvuzi bushingiye ku miti, ariko hari n'ubuvuzi bwo gusubiza umuntu wagize ikibazo cyo mu mutwe mu buzima busanzwe. Ubwo buvuzi rero butangwa n'abantu ku byiciro bitandukanye. Hari abaganga cyangwa se aba professional nurses baba bahari ku kigo nderabuzima, baba bari aba professionals mu bintu bijyanye n'indwara zo mu mutwe, ariko tuba dufite noneho n'umunasi. Twagize amahirwe PIH iraza itanga formation, abantu nyine ubuzima bwo mu mutwe twese turabukangukira. Umuntu wese yasanga ku kigo nderabuzima umurwayi cyangwa se uwo mukiriya uje utugana arafashwa. Mu by'ukuri rero kubihuza n'inshingano zacu za buri munsi ntago ari ibintu navuga bikomeye, icya mbere ni ukubiha agaciro tukumva ko ni ibintu byacu, tukumva ko ni ubuzima bwacu bwa buri munsi, kandi tukirinda ko wa muntu yagira ikibazo cyo guhabwa akato. Akato ka mbere umuntu yakagira ari twebwe tubiteye. Rero niba umuntu habayeho ibiganiro muri kominote yigishwa ko ubuzima bwo mu mutwe ni ubuzima nk'ubundi, nk'uko umuntu yarwara mu nda, nk'uko umuntu yarwara urundi rugingo, ariko noneho ku mutwe ho bikaza byihariye. Ari niyo mpamvu dukeneye ko kominote ibimenya cyane kurushaho. Rero ntabwo dutanga wenda ubwo bufasha ku rwego navuga rw'ikigo nderabuzima gusa, oya, no muri kominote turamanuka tugatangamo ibiganiro, abantu bagasobanukirwa ubuzima bwo mu mutwe, bagasobanukirwa ese umuntu wagize ikibazo kijyanye n'ihungabana cyangwa se n'uburwayi bwo mu mutwe afashwa gute, byibanze bigenda gute. Urumva ko duhera hasi, duhera kuri kominote, bijya kutugeraho twebwe ubona abantu navuga bari muri mood. Ibi ntago byahozeho mbere ya 2012 decentralisation y'ubuzima bwo mu mutwe itarabaho, ntago ari uko nkuko byagendaga. Umuntu yagiraga ikibazo cy'uburwayi bwo mu mutwe, nyine abantu bose bakitaza bakamukwena, kubona nyine aratereranwe. Uyu munsi navuga ko iwacu Burera atari ko bimeze, cyane cyane wenda muri zone y'ikigo nderabuzima cya Ndongozi, kuko twebwe by'umwihariko twahawe amahirwe y'uko ukuntu bavuze dutanga ubuvuzi bwa psychosocial rehabilitation, gusubiza wa muntu noneho mu buzima busanzwe, byahereye iwacu. Turabanya amahirwe cyane, byahereye iwacu, turanabikunda. Ndi umutangabuhamya wabyo. Bitangira nanjye naribazaga ese bizagenda gute ibi bintu, noneho PIH bagiye kurema ikidashoboka. Nanjye ntabwo numvaga ko bishoboka, ariko mu by'ukuri byarashobotse, biranadushobokerera cyane, aho abantu bose twari dufite bitabiriye bya biganiro bose 100% byabagira umumaro kandi barakize. Icyo navuga nuko ari intego bihaye bazirimo neza, kandi ubona ko n'abantu nyine bafite intumbero ndetse yo kwiteza imbere no gusubira mu buzima busanzwe. Ikigeretseho kandi n'intego zabo bihaye bwite ku giti cyabo, nukuri bazirimo neza. Rero nkashimira cyane umuterankunga wacu PIH, nkashimira cyane guverinoma y'u Rwanda, nkashimira Minisitiri w'Ubuzima, nkashimira nyakubahwa Perezida wa Repubulika, kuko ibi byose tubigeraho kubwe, tubigeraho kubera ko yahaye agaciro ubuzima. Rero nabashimira cyane, ariko nongera kugaruka ko kubihuza rwose n'inshingano zacu, ntago ari imbogamizi, kandi turahari turiteguye. Murakoze.
Thanks, Diane. In summary, Diane started by saying that combining psychosocial rehabilitation and their routine work as health professionals at the health center, it's not complicated. It's just you have to give this the due value of that intervention as well. If it's not really given due time, due consideration, it doesn't happen. But for them, because they gave that aspect really a consideration, now it's functioning. At the start, it was not easy because it was started by PIH jointly with the government of Rwanda. It was really hard for them to say this will be functioning or this will lead any result. But now it's going very well. And for them, another thing that they're doing is go to the community to talk about mental health as any other condition, to show the community that mental health is not just it's different from other diseases, but it's really it is as any other one. And really, the health of the body starts by a healthy mental health. And these interventions were not existing for 2012. In 2012, that's when PIH went to Butaro and started decentralizing mental health from the high level of the care, the district hospitals, toward the community and health centers, which are the primary health care unit in the country. And they say that they help the people to state the goals, as Beato was also mentioning, and they keep following up on them. And now they see that the goals are being achieved and they're achievable. And really, the people who are in those self-help group, they are really covering and they are really keeping up with their life. Thank you, Diane. On top of this, we, as PIH, as a health centers, we have RBC, Rwanda Biomedical Center, that oversees healthcare in the country. And with this intervention, that goes up to the community. how does Rwanda Biomedical Center see this, and also how does it fit in the vision of Rwanda Biomedical Center so that this can be scaled up? Over to you, Emmanuel. Start by introducing yourself. Thank you.
Thank you. My name is Emmanuel Hakomeza. I work at Rwanda Biomedical Center under mental health division. Before I go to your question, I want to clarify or to complement what Dr. Rukondo has said about the overview of mental health in Rwanda. There's not only one psychiatric hospital in Rwanda. We have three mental health specialized services, including neuropsychiatric teaching hospital. We have a mental health, Kigali Mental Health Referral Center. We have also other specialized center which treat people who have who experience issue of drug abuse problems in Huye. Huye is a rehabilitation center. But also the government, due to a significant number of people who have mental health problems after genocide, the Rwanda has emphasized and put a great effort to integrate mental health into primary health care, which means that each hospital has unity of mental health unity with staff from psychiatrists, some, but mainly mental health nurses and clinical psychology. As time goes and as we keep strengthening mental health system in Rwanda, some hospitals start to get psychiatric, doctor, psychiatrists. Recently, you have Rwamagana, we have a King Faisal, we have Seashibe, Seashika, and we hope as people get graduated, we will keep putting, strengthening this decentralization with varying psychiatrists. We also, because this seminar has put emphasis on epilepsy, the Rwanda also government of Rwanda has worked on medical equipment, especially EEG machine, where right now we have more than half of hospital equipped with EEG machine, just to improve diagnosis of epilepsy. So the decentralization goes to community health workers. I just wanted to correct or to emphasize on the key messages where Professor raised the issue of mental health should not be treated by only psychiatrists, especially in a country where we have the issue of specialized medical doctors. So for your question where you asked about the community intervention, the government of Rwanda through the Ministry of Health under mental health division has started to strengthen the community, because when you treat someone who has mental health issue, the research showed that the medication has a role to play, but also the society also has another big role to play. Across this seminar, we have emphasized, or we have talked about stigma, we have talked about discrimination. So with assessment, with follow-up we have done across the years, because mental health has went to the peak after genocide. So with the follow-up, the government put the much effort in strengthening health system by putting in place mental health services from hospital to health center. But we saw a gap between the health center and the community, where the people went and received appropriate treatment, either hospitalization or outpatient services. But when they go back in the community, they have there was a number of relapse due to stigma, relapse due to mental health literacy in the community. So that's why the government has started to work with partners, work with community integrating mental health in the community health, in the community health workers, to go down to the village to educate the community, the families, the young people about mental health. But also with the support of PIH, other stakeholders, we have more than many stakeholders, mental health stakeholders, whom we work together on a daily basis. We are strengthening the community, the mental health communities, to eradicate or to reduce the stigma, and also to help people who experience mental health problems to be able to rehabilitate it and to be able to reintegrate in the community. So we started, as you asked, recently we had like a field visit to hospitals under PIH, especially Rwinkwavu, to learn from success to be able to implement in the other hospitals, so that people who have mental health problems are really being supported in a comprehensive way, not only medication, but also receive family support and be able also to benefit psychosocial programs from government. Thank you.
Thank you. Arakoze Emmanuel, ndagira ngo nkore mu ncamake byatubwiye kugira ngo twese tubyumve kimwe n'abatumva ururimi rw'icyongereza. Yatangiye adusobanurira ko ubuvuzi bw'indwara zo mu mutwe butabera gusa Indera, ariko leta y'u Rwanda yabaje kubugeza n'ahandi, ndetse n'abaganga babivura bamaze kugenda biyongera, nk'ubu i Rwamagana, i Butare ku bitaro bya kaminuza bya Butare n'ibitaro bya Faisal baramufite. Nicyo yatangiye aheraho. Ikindi yavuze nuko leta y'u Rwanda kandi irimo gukora ubushoboka byose kugira ngo yongere ireme ry'ubuvuzi bw'indwara zo mu mutwe, ishyira ziriya mashini nk'iyo Weraris akoresha ku bitaro byinshi, ku buryo icya kabiri cy'umubare w'ibitaro biri mu Rwanda bimaze kuzigira kandi zose zikora. Ahuza ibyo twaganiragaho n'icyo nebazo nayimajije cy'ukuntu leta ibibona. Leta y'u Rwanda ibona ko ubuvuzi bw'indwara zo mu mutwe butagarukira ku miti gusa, ahubwo bisaba ko n'umuntu agera mu muryango aho abantu batuye ndetse no muri community. Akaba ariyo mpamvu zino gahunda umushinga Partners in Health watangije, RBC igenda izigiraho kugira ngo ibashe kuzigeza n'ahandi, kugira ngo wa murwayi wavuwe atazahabwa imiti gusa, namara guhabwa imiti nageramo aho atuye muri community, akato nigatangira ko nta bukangurambaga buhari cyangwa se nta bufasha bundi buhari bumusubiza mu buzima busanzwe, wa muntu atongera akarwara. Leta ribona ko izi ngizi ari ibingibi ari bikorwa bikenewe kugira ngo abarwayi bavurwe neza mu buryo bwuzuye kandi nabo babashe gusubira mu buzima busanzwe. Thank you so much. Thank you. this is what we look at PIH when we talk about what is social medicine, what is a holistic approach to a disease, to a person, not to a disease. When we see someone coming at the hospital, at the health facility, we encourage everyone to not see the disease. Usually, when we sit as doctors, especially when it comes to higher specialization, we tend to focus on just one aspect. The person who came to me has a mental health problem, has a fracture, then I see that as the end point. But we, at PIH, we take to our hearts what is a social medicine approach to the disease, a patient-centered approach for a person, for a family, for a community, so that when there is a condition in the community, we treat it as a general, holistically. That's why we have psychosocial rehabilitation in mental health that took an approach from the hospital level, health facility level, up to the community to improve the livelihood of the people that we have seen at the hospital level. Thank you so much. At the end, we can take some questions. MC.
So thank you so much for the Partner in Health, which fund now the social enterprise of the patient. And what I like and admire about Partner in Health is to see that they are bringing even evidence of people with vitiligo, other disabilities, include and invisible disabilities as epilepsy. So regarding my question in a social therapy, we have some tools, smart tools applied to give to every patient. They can wear it, and that smart tool can measure, example, the seizure they have, and even the continuity of the repeat prescription without going to the hospital. That is called the Epilepsy Aid Management app. And that app has helped many patients not to fall under fatal incident like the burning of the body, like you said that he fell from the back. He should lose his life, or even get maybe a cranial traumatized, and even now it's not even show up. Maybe it will show up later. So for me, what I'm saying, we are a good country which listening to people, even they are not entitled of anything. Maybe even I'm not in the MOH, but for me, what I'm saying, for us to avoid other big incidents to appear, is to adopt an app. And that application form can be at each patient place, where the patient can even record after his daily activities what is happening to them. So the doctor who is in the district hospital, let's say in a psychotherapy, will have a pending to say that this patient, before he's coming, I know what is going. I have to add the drug. So the artificial intelligence will alert which kind of combined anti-seizures they can get, include a therapy, and even send them to the counseling program. But another thing I want to highlight, even at school, we need to thank Rwanda to put the benazole. Thank you, Dr. Darius. Because that is also something preventing the disease of the children. And here in Rwanda, I witnessed that children are taking it's like something which help the children not to get. So if they have an infection in the intestine, and that it can be cured, and that prevent also seizures. But what I'm asking, despite it, in each single school, do we have a medical record of each single student with a chronic condition? Let's say it's not only about epilepsy. Those who have, example, diabetic, etc., any other non-communicable disease on it. So in case the children access a school, this is a new idea I'm giving to you and Dr. Nancy, professor, include the team behind. So if every child come to school, by coming, is it shadowed by an adult, for example? The one with epilepsy cannot come alone to avoid incidents. Another one is about to ask a child, Did you take your medication in the morning? So the school environment health policies tick on it. They call it match records on social cares, policies safeguard. And then if it reach at midday, they can see, oh, which dose did you take? They have it at school also, and they give it to the children, or the children can come with it. If it's not there, they need to call the parent to bring it, because the classroom is finished after 4 p.m., let's say 3 p.m. Another thing I want to ask you. I spoke with the lady there, and she listened to the presentation of Dr. Celestine about the PSTD. But she asked me, how can I meet him to talk with him? So the online cloud on PSTD tools Dr. Celestine provided is about to treat the PSTD disorders. And majority of us who got epilepsy, it is a traumatized. Because when we fell, we lost conscience, but we don't know if we wake up. If you see myself today, others are on grave. But the thing I'm asking, can we please adopt this app? Because it's a standardization tool, approved also in East Africa. And among the juniors psychotherapists in Rwanda, is him who produced that AI. We need at least something to measure or mood by the human resource. Even you are directors or in the bank or anywhere else. You may have also some traumatized stress or some personality disorders, but you need to be checked. They need to see your record. Are you fit? Because sometimes your stress can spray through the environment of the work, and it kill everyone. So it means that it brings stroke to your colleague, etc. By yourself, you don't know that you are killing people, but we need to be very careful and take such thing. It is an invisible disabilities, but it's very dangerous even compared to HIV. Thank you so much.
Thank you. Those are very good intervention. Maybe nongere mbivuge ku bantu twese tubyumvira hamwe. Avuze cyane ku bintu bijyanye n'ikoranabuhanga, uburyo twabasha kurikoresha naryo kugira ngo abarwayi bajye babasha kumenya uko bahagaze kandi bibe byanavugana no kwa muganga bimenyere rimwe. Ni ibintu muri partners. Let me maybe answer this on behalf of the panel. In the PIH, that's why we are called partners actually. All of we achieve is through partnership. So we can partner with you or any other person to see the feasibility of this. Most of the time, as we have been talking in the morning actually, about the phones, the smartphones, these are the things that requires technology, how we adopt technology, and also how we go about it in terms of the national laws that we have. Ariko ni ibintu twumva byashoboka gukoresha ikoranabuhanga kwasha gukurikirana abarwayi ndetse ashyizamo n'ikintu cyo kuvuga ngo abanyeshuri bageze ku ishuri bakwikiranwa gute. Nabyo ni ibintu tuzakoranaho na RBC tukareba how can we start this, ni gute twabitangira cyangwa se twagira na gato n'ahantu hato dutangirira bikazafasha RBC kuvuga ngo byashoboka cyangwa ntibyashoboka mu Rwanda. Murakoze cyane.
Thank you very much. Murakoze.
Arakoze Dr. Eric. Chantal arakoze. Raising ibibazo bibiri. First of all, the question about application, medical application, mental health application, there is a process to take to be adopted. I'm sure you know, even Dr. Celestine knows. So they have to be pass through that process to be adopted, but the government, especially Minister of Health, welcomes innovation and technology in mental health. We have some we are using, so that's one. The second, for student medical file, I'm sure you know we have started the school-based mental health program since 2021 to 2020 December. It's been 5 years. We are working with teachers, school leaders, especially for mental health program. But we are also discussing about your concern. How can we have a medical file, a student medical file? It has to be discussed with Minister of Education, with Mena and Minister of Health. So it's one of recommendation, and surely we will take into consideration. Thank you.
Thank you very much. We pressed for time. I would like to really ask the audience to join me in thanking the panel. Mwakoze cyane kwigomwa mukaba muri hano. Turashaka muhaguruke bafate ifoto ya groupe, hanyuma na Professor Najib aze abavugire. Just wait, they're taking a photo, a group photo, and then present.
Relax.
Fight stress.
So thank you very much. It's our privilege to thank you, to thank Partners in Health. I think without your support, please wait. Without your support, Partners in Health, I think we should not meet this week here for this fourth Brain Week. We even was thinking about maybe moving Brain Week from Rwanda to somewhere else, Morocco. But thank you very much to Partners in Health and all the people working very hard on the ground, the nurses, social workers, connecting patients and helping patients. And this is a small gift brought by our institution to these members who are working hard on the earth.
I want to call our ED to come and receive the award together. Nadine, thank you. And Darius as well.
Yeah, Darius also. Yeah, we also thank Mr. Darius from Ministry of Health for all the support, all the agreement to work together. Yeah, this is for Mr. Darius. Thank you very much. Thank you very much. Our great pleasure.
Just thank you. Like Dr. Eric said, we are partners in health. We partner up with our patients, our communities, and our main partners, the government of Rwanda, represented by the Ministry of Health and RBC. And we want to thank the organizers because, and of course, advocates like Chantal, who remind us every day that behind every disease, behind every publication, behind all the data that we look at, there are people, and that's who we should care about. Thank you.
Thank you so much. Good afternoon. Mine will also be to thank Partners in Health and, of course, the organizer of this conference and Brain Week. I was looking this morning on numbers, and I found that the district where she come from, Burera, supported by PIH, they received for January 2026, 2,280 patients. And I made a simple calculation, asking myself if they had to come to Kigali just to get the medication or seeing a specialist, if they had to pay 10,000 just for transport, it will make near to 20 millions that will be used by families and etc. So this mode of bringing care near to the population is very, very important. And I thank all our partners, and I also thank the scientific committee, the organization committee for this conference that is helping to reflect on this and keep improving. Thank you.
Thank you very much. Thank you all. Thank you for all your collaboration. I think without the help of all of you, we cannot be here. And I think we will improve our Brain Week in the future. And we invite all of you to keep in touch with us, with the people from Rwanda, with our committee, with all the members for the coming Brain Weeks, inshallah, in Oman or in Mali for the next one. And I hope we'll come back again, inshallah. Thank you very much. And without any delay, so I will call Professor Friedman from Germany, Paul Friedman. He is the first leading person in multiple sclerosis and also in NMO and MOGAD. So he is connected by Zoom. Professor Friedman, are you with us? And he could not make it because there are a lot of snow in Germany. All the flights have been cancelled the 3 days before. So no flights could come from Germany. That's why he is presenting online.
Hello, everybody. Yeah, Professor Kisani rightfully said that both Felix, a colleague who will speak right after me, and myself couldn't make it due to the bad weather conditions in Germany yesterday and the day before yesterday. But nonetheless, it's a great pleasure to be with you, at least virtually and on Zoom. And I do hope that we will have the opportunity to meet in person during one of the upcoming MENA meetings next year, hopefully. So I was asked to speak about NMOSD and MOGAD, and I need to be given the opportunity to share my screen. So please, the control room could give me the screen share option, if you don't mind. Let me see. Okay. Can you see my slides?
Yes, we can do this. Thank you.
Okay, and please record my talk. I will share the slides after this talk, just in case there is any technical issue. And I'll get started right away. Okay, so you probably know the diseases neuromyelitis optica and MOGAD, myelin oligodendrocyte glycoprotein antibody-associated disease, complicated name. By the way, these diseases are probably a lot more prevalent in Africa than in Europe, but we do have the issue of lack of access to antibody testing in many centers, and Felix will touch upon antibodies and biomarkers during his talk in more detail. I will start with a clinical presentation, differential diagnosis, and of course also immunopathogenesis. So let's start with NMOSD. It's a severe autoimmune rare condition of the central nervous system that shows some clinical overlap with typical multiple sclerosis. But on average, the disease is a lot more severe. The attacks are associated with more severe neurological deficits. And the characteristic presentation is with optic neuritis, with transverse myelitis. And as you can see here, in most cases, longitudinally extensive transverse myelitis, so very long lesions expanding over 3 or more segments of the spinal cord, and often overlooked, but very characteristic on the left lower part of the slide, the so-called area postrema lesions with intractable hiccups, nausea, and vomiting. And you probably also know that in most cases, this comes with antibodies to the water channel aquaporin 4 that can be detected in a cell-based assay. However, NMOSD often goes beyond the central nervous system, and it's important to work closely together with internal medicine colleagues, general practitioners, and so, because many patients with NMOSD have so-called extra CNS complications. This is shown down here, left lower panel of the slide. So many patients have autoimmune disorders like lupus erythematosus, myasthenia gravis, Sjögren's syndrome, myositis, and many others. And a few words on immunopathogenesis. This is meant to be a primarily clinical talk, but a few words I think are important. So what is still not fully understood is that why does the pathogenic autoantibody against the astrocyte water channel aquaporin 4 come from the periphery. And you can see this here on the very left side of the slide. This is the bloodstream. So we have plasma cells, B cells that produce and release these aquaporin 4 IgG antibodies that then, with the help of T cells, with the help of inflammatory cytokines like interleukin-6 and others, can gain access to the central nervous system. And then, and you can see this here on the right side, they gain access to their target antigen, the astrocyte end feed, and here they activate complement, and with the help of complement-dependent cytotoxicity, antibody-mediated cellular cytotoxicity, and other mechanisms, then in the end, there is a loss of water channel function or even a dying astrocyte, so a demise of the astrocytes. Yeah. Again, it's still not fully clear why the antibodies come from the periphery. Now, in recent years, there has been research into the role of T cells, because in the immune system, B cells and plasma cells can never function properly without T cells and vice versa. So there is a B and T cell interaction that is required for a regular immune response to an infection, for example, but also plays a role in autoimmunity like NMOSD. So interestingly, this was work from a group in the United States. There seems to be some overlap of aquaporin 4 specific T cells that recognize certain epitopes of this aquaporin 4 peptide or a protein on the astrocyte end feed, but also shows some reactivity to Clostridium perfringens ABC transporter permease, which is a gut bug, a bacterium that is very abundant in the gut. So this could point towards a gut microbial role in NMOSD pathogenesis. And interestingly, another study from the same group then showed that the gut microbiome is changed, is altered in NMOSD versus healthy controls and versus multiple sclerosis. You can see this here on the left side. Even in a corrected fashion, there are some different signatures of the gut microbiome in NMOSD. And here on the right side, you can see a specific analysis for Clostridium perfringens, and you can see that this is increased in NMO versus MS and healthy controls, and even in patients that are treated with rituximab, so that do have immunotherapy. But to sum this part up, the role of T cells in the immunopathogenesis of NMOSD is still much under-researched. Now back to the clinical scenario, the disease course, and there's a very clear distinction from multiple sclerosis. You see a typical NMOSD disease course on the left and an MS disease course on the right. And in NMOSD, there usually is no progressive disease, with few exceptions like in MS, but the attacks, and this is shown here, are usually more severe and show a poor recovery. Yeah, even if you give high-dose corticosteroids, if you have the chance to give IVIG or perhaps plasma exchange. And this means that preventive immunotherapy is a lot more urgent after the first attack in NMOSD than in multiple sclerosis. So there is no time to wait, time to observe the further disease course before you make a treatment decision. In NMOSD, at least in those patients who have the antibody against aquaporin 4, you must act immediately and must give preventive immunotherapy right after the first attack, because in older case series and studies before we had some modern immunotherapies, up to 35% of patients died from the disease because they had severe myelitis with brainstem affection. They had respiratory failure and other issues, so there was a high mortality rate. And this is reflected in a registry study we did in Germany a few years ago. We have created a network, NEMOS is the name, Neuromyelitis Optica Study Group, because we felt it's a rare disease. We need to share forces, we need to combine data and address research questions from a kind of group standpoint or from a network standpoint in order to increase sample sizes. So we then found that the vast majority of attacks, and this pertains both to myelitis and optic neuritis, this pertains to the first attack of the disease as well as to subsequent attacks, show a poor recovery. So only up to 20-25% of attacks show good recovery. The vast majority of attacks leaves the patient behind with severe neurological deficits. Now, how can we diagnose the disease? This is probably a tricky issue for some of you, but maybe something for the discussion after Felix' talk then. So you've heard that the vast majority of patients with this clinical phenotype of NMOSD has antibodies against the astrocyte water channel, aquaporin 4. Some patients are seronegative and they do have antibodies against another CNS antigen. This is MOG. I'll come to that towards the end of my presentation. And of course, there are also double seronegative patients whose serological status is unknown because they cannot be tested or because they may have a yet undiscovered autoantibody. So there are numerous tests available depending on the region of the world, the country you work in, the healthcare system, the reimbursement situation, etc., etc. But ideally, from a methodological standpoint, a cell-based assay, ideally a live cell-based assay, is the gold standard. So you transfect HEK cells, human embryonic kidney cells that are often used for autoantibody testing. You transfect these cells with vectors to express the aquaporin 4 protein and then can put a patient sera on this, and with some counter staining with various modalities, you can then get images like this one here on the very left and can detect these antibodies. And the highest sensitivity and specificity to detect aquaporin 4 antibodies is in the live cell-based assay. You can also use a fixed cell-based assay. An ELISA and other test modalities should be avoided, but I know that it's difficult, that in many countries there are either no tests available, or if there are tests available, they are ELISA tests which have these known issues. But so my personal opinion is that it's better to test in an ELISA than not to test at all. But you have to be aware of the problems with sensitivity and specificity of an ELISA test. This is a bit difficult. Maybe the key point here is because the classic differential diagnosis of NMOSD is multiple sclerosis, and until the seminal discovery of the aquaporin 4 antibody 20 years ago by a group in the US at the Mayo Clinic, Rwanda Lennon, NMOSD was thought to be a rare and more severe variant of multiple sclerosis. Now we know that it's a totally distinct neuroimmunological entity, and beyond the antibody, it's the CSF analysis that can help. So usually in MS, as you know, the vast majority of patients, 80 to 90, maybe 95%, has oligoclonal bands in the CSF. This is very rarely the case in NMOSD, below 20%. So the presence or absence of oligoclonal bands can be a good additional tool to help with a correct diagnosis. And this is, again, totally overloaded with text. And this is not to go through all the details. This is just to show you that there were diagnostic criteria for NMOSD published more than 10 years ago by Dean Wingertschuk and an international panel in 2015 with a scenario here on the left for patients with aquaporin 4 IgG or the aquaporin 4 antibody, and here on the right for patients without aquaporin 4 antibodies or patients in whom tests are not doable because they are not available. There will be new criteria published later this year. I'm happy to share it once it's a bit more advanced, so you will find it in the literature. An international panel, again led by Dean Wingertschuk, has been working on a revision of the diagnostic criteria since 2023. And the work is nearing its end, and the publication is being prepared and will hopefully be out in the second half of 2026. Now, to set NMOSD apart from an imaging standpoint, you should pay attention to a few characteristics. So if you have the opportunity to do an MRI or perhaps also a repeat MRI in your patient, you should take the opportunity. So for example, here on the left side, you see a characteristic affection of the optic nerve that affects or that prevails in the posterior part of the optic nerves, including the chiasm. And here in the middle, you see some characteristic brain images, for example, lesions that appear to be tumefactive, may mimic lymphoma or other edema-associated conditions. You can see lesions here close to the ventricles, and here on the very right, again, these characteristic infratentorial area postrema around the fourth ventricle lesions with intractable hiccups, nausea, and vomiting that are very, very characteristic of NMOSD. And in the spinal cord, you usually have these, as I showed you, these long cord lesions. You may find shorter lesions, but the lesions are usually very necrotic, as you can see here, so very destructive. And what is shown here in the middle of the slide are so-called bright spotty lesions, so very bright T2 hyperintense lesions in the spinal cord that also reflect the underlying tissue damage and are very typical of NMOSD. And when you now compare NMOSD, it's in the middle here with aquaporin 4 antibodies to MOGAD, which I'll present in a minute, and to MS on the very right, you can see longitudinally extensive cord lesions in both MOGAD and in aquaporin 4 NMOSD. However, in MOGAD, you often have this so-called H sign, which is shown down here, left lower panel on this slide. In the middle, in the axial image, you see this very destructive lesion in aquaporin 4 disease. And on the very right, you see a typical MS spinal cord lesion, which is more peripherally located, is smaller, and is wedge-shaped and does not show this extent of destructiveness as aquaporin 4 disease, for example. And there's a nice paper by a colleague from the Mayo Clinic that nicely visualizes here on the right the different distribution of the spinal cord lesions in the three conditions. And now back to the what happens in the brain. So when you look at older literature, it was thought that NMOSD patients have no brain lesions in contrast to multiple sclerosis. Now we know that this is not true. So the vast majority of NMOSD patients does show some brain lesions, but most of these are so-called small punctate hyperintense patches below 3 millimeters in diameter that are considered unspecific. So what does unspecific mean? Unspecific means that they are probably pathophysiologically not related to the underlying pathobiology of NMOSD, but rather stem from concomitant vascular disease, hypertension, migraine, history of smoking, and other conditions that can cause small unspecific brain lesions. Yeah, and this is very important to bear in mind. What makes the MR interpretation a bit problematic is the fact that not few patients with aquaporin 4 NMOSD and even with MOGAD meet the so-called Barkov criteria for multiple sclerosis. So this means that if you see a brain MRI that seems to resemble multiple sclerosis, you should not over-hastily rule out NMOSD or MOGAD. You should expand your differential diagnosis, if possible, of course, into any direction, and also take MOGAD and NMOSD into consideration. And within our network in Germany, the NIMOS network, we have seen many patients who initially had a misdiagnosis of multiple sclerosis and were then later correctly diagnosed with NMOSD or with MOGAD. Yeah. And what can perhaps help in the future, of course, again, this depends on the availability of imaging, of MRI scanners, is the so-called central vein sign. This is an adjunct criterion in the new McDonald criteria for MS that were published end of last year. And you can see here on the right these typical MS lesions with a central vein in them. And on the left side, again, you see these typical unspecific NMO-SD lesions without a central vein. And the sensitivity is not so good, but the specificity of discriminating from MS, of discriminating another condition from MS is very, very high. So in certain circumstances, this might be of help. And this has also been shown or has been replicated in larger groups, for example, by the Magnums Consortium. And you can see here on the right side that the vast majority of MS lesions shows the central vein sign, and in aquaporin 4, NMO, and in MOGAD, this is less frequent. But I presume that the vast majority of colleagues, by the way, even including in Germany, and Europe does not have access to MRI scanners that can regularly visualize the central vein sign. So this might not be very practical for daily routine. And again, from the same paper by colleagues at the Mayo Clinic, a very nice graphic showing the discriminative features of brain lesions in the three conditions: multiple sclerosis, aquaporin 4, NMOSD, and MOGAD. And the same pertains to the optic nerve, and I'll briefly repeat the key features here. So in aquaporin 4 disease, right lower panel, you see this posterior location of lesions, including the chiasm. And in MOGAD, you have a longitudinally extensive lesion of one or both optic nerves that can even lead to an optic nerve head swelling into the eyeball. I have another example in a minute. Now, we are increasingly using OCT, optical coherence tomography, that comes from the field of ophthalmology. I do not know if this is available for some colleagues in the audience, but it's definitely a very easy to use, relatively cheap and non-invasive tool to monitor changes of retinal tissue that is central nervous system tissue, as you know, so thinning of the retina, damage to retinal axons and retinal ganglion cells. And in NMOSD, you can see, and this is reflected here by a massive thinning of the retina, the retinal nerve fiber layer, that the optic neuritis attacks are on average a lot more destructive and harmful than optic neuritis attacks in patients with multiple sclerosis. And you also know that the recovery is very poor. I already mentioned that so maybe OCT will be used more frequently in the future, perhaps in scenarios where MRI is not available or too expensive or otherwise not doable. So our NEMOS group in Germany published two papers 3 years ago. They are freely downloadable, open access in the Journal of Neurology, that summarize the diagnostic approach to NMOSD, and a second paper that summarizes therapeutic options for NMOSD. So this could be helpful for navigating together with your patient through the diagnostic pathway, hopefully to a correct diagnosis. And now let's move on to immunotherapy. So first of all, attack. It is very, very important that attack management is done without any delay. And usually, as in multiple sclerosis, you would start with a high-dose intravenous corticosteroids. And the earlier, the better. This was an international study that looked at 27 NMO and 9 MOGAD patients. And the bottom line is here. There is a critical temporal threshold of around 4 days. So if you treat within 4 days after onset of clinical symptoms, you have a very good chance of good functional recovery. If you treat after 4 days or even after 7 days, you have a very high risk of failure to regain a good vision of 20/20 or 20/30, which means you should act immediately and not lose time when treating these conditions. And the same pertains to plasma exchange or immunoadsorption. This was another study by the NEMOS group. You can see here that when you do plasma exchange within 2 days of symptom onset, you have a good proportion of patients who show good recovery or CR, complete recovery, whereas when you wait later, 3 to 6 or more than 7 days, there's a very, very small minority of patients showing complete or partial recovery and a high proportion of patients showing no recovery at all. Now, preventive immunotherapy, you can see here, this is a paper more than 10 years old by NEMOS, that then there were virtually no approved therapies for NMOSD. We used rituximab as a generic B-cell depleting agent, and we used azathioprine or other broad and unspecific immunosuppressants like mycophenolate, mitoxantrone, methotrexate. They are still widely in use, by the way, because they are cheap. They are generically available, so they can be used, of course. They have shown good efficacy in retrospective studies and observational clinical trials. We already knew then, and this hasn't changed since, that the vast majority of MS immunotherapies, with the exception of B-cell depletion, must be avoided because they are harmful and inefficacious in NMOSD. But there have been a few clinical trials. I know I'm nearing the end of my time. I need 5 more minutes, if that's okay.
Okay.
Thank you. So I'll speed up. So there have been several clinical trials in the past 10 years that led to the approval of drugs like complement inhibition, eculizumab, ravulizumab. Besides rituximab, we have a second B-cell depleting agent, inebilizumab, and here on the very right, satralizumab, a monoclonal antibody against IL-6. Again, a very important cytokine for blood-brain barrier disruption and other bad immunological effects. There were these trials. I can do this somewhat faster. And all these drugs have reached approval in the EU, the US, Japan, and some other countries, and have shown good effect on reduction of attack rates between 70 and 80% roughly for inebilizumab and satralizumab, and a higher rate for eculizumab. And this pertains only to alpha-protein 4 antibody positive NMOSD patients. There is no evidence of efficacy of these drugs in seronegative NMOSD patients or in MOGAD. And ravulizumab, another complement inhibitor, was approved 3 years ago in Europe with the advantage of a longer half-life, so it has to be given only once in 8 weeks. And this was summarized in the second paper. I had already mentioned that by the NEMOS group on preventive immunotherapy. Now that we have these drugs at hand, there's an algorithm in the paper. You can look this up, how to switch between the various immunotherapies if you have a patient failing on one immunotherapy and you want to switch him or her to another. For double seronegative NMOSD, so without aquaporin 4, without MOG antibodies, we don't have much more than rituximab or these old immunosuppressants. Now, in acute, I'll skip this for the sake of time. Just let me do a few words on MOGAD. Can I have 3 more minutes? Is that okay?
Yes.
Okay, thank you. So, MOGAD. Again, MOGAD was thought to be part of the NMO spectrum. Now we know that it's another distinct neuroimmunological entity. You can see here that on the right, the NMOSD attacks the astrocytes. On the left, it's MOGAD. The antibodies, again, coming from the periphery, attack the oligodendrocytes. And this is the key discriminating feature in terms of immunopathogenesis. A few years ago, 3 years in January 2023, there were diagnostic criteria published for the first time. I can't go into detail. Again, it's an open access paper. You can download it here. But in principle, you need a core clinical presentation shown here, and antibody results in serum, again, ideally with a cell-based assay, and then depending on the antibody results, you need additional supporting clinical or MRI features to make the diagnosis. And there are some differences between NMOSD and MOGAD NMS. So in kids, the predominant clinical presentation is an ADEM-like phenotype. So in kids younger than 20. Yeah. And the older the patient, the higher the proportion of the opticospinal phenotype, and the vast majority of patients presents with uni or bilateral recurrent optic neuritis. And this then led to a reclassification of many patients. I guess you know the diagnostic category of a CRION, chronic relapsing inflammatory optic neuropathy. And then with the advent of the NMO-IgG in 2004, some of these CRION patients were re-diagnosed with aquaporin 4 NMOSD, and probably many more patients have been re-diagnosed with MOGAD since 2019 or 2018, when MOG assays became widely available. You have seen this slide already on spinal cord. I can skip it. What is very characteristic of MOGAD is the affection of the lower parts of the spinal cord, the so-called conus, as shown here, the lumbar spinal cord, often associated with bladder, bowel, and erectile dysfunction in men that does not show good recovery, unfortunately. What is also very characteristic of MOGAD in contrast to NMO and MS is cerebral enhancement, as shown here, very characteristic gadolinium enhancement near the meninges, something very rare in aquaporin 4 NMOSD and multiple sclerosis. And what is also very characteristic of MOGAD is so-called lesion resolution. So when you perform an MRI in MS and you do another MRI 6, 8 weeks or 3 months later, you will hardly see any disappearance of lesions. The same pertains to aquaporin 4 NMO, but in MOGAD you frequently have lesion resolution in a short period of time. And this is another example, a study from Italy and the United States showing that almost 80% of 452 lesions disappeared after a couple of weeks to months on follow-up MRI. Optic neuritis, I'm almost done. Forgive me 2 more minutes, please. You can see here this massive swelling of the optic nerve head, and this is also visible on OCT, and here on the right side you can see this swelling even on MRI, the optic nerve head protrusion into the eyeball. Visual acuity during the attack in MOGAD usually is very, very poor, but shows good recovery with corticosteroids. And here's another example of the OCT shown here, this massive swelling in MOGAD. Here is the OCT measurement, and this does not show, does not appear in multiple sclerosis. So the swelling of the optic nerve head of the RNFL is a good discriminator between MS and MOGAD. Now, immunotherapy, there's virtually nothing. There still is a debate as to whether MOGAD should be treated with preventive immunotherapy after the first attack, because roughly half of patients remain monophasic, so they have just one attack and no subsequent attacks. So we wouldn't want to expose these patients to a lifelong or very long risk of immunotherapy with all side effects. So many colleagues think we should only treat preventive or should give preventive immunotherapy after a second attack, but this is still a matter of debate. What we do know is that rituximab works less well in MOGAD than in aquaporin 4 disease. Some patients, a French study down here, that were fully B-cell depleted but nonetheless experienced attacks. And a study from the US showed that IVIG probably is the best attack preventive drug, although, of course, it's not easily available. It's very costly, so it might not be an option for many colleagues in many countries. We have done a study with tocilizumab, anti-IL-6, which shows good effect. And there are 2 trials that have just completed enrollment, one with satralizumab, so this anti-IL-6 monoclonal antibody that has been approved for NMOSD. The trial has just stopped enrollment for MOGAD, and another trial with an anti-neonatal FC receptor antibody by UCB. The COSMOC study has also completed enrollment, and we are awaiting the results over the course of the year. We have formed a network in Europe, the so-called MEDEN network, MOGAD Eugene de Vic European Network. You see a photo of a meeting we had in Berlin 2 years ago, and we are open for collaborations and interaction with colleagues and partners in Africa and beyond. So if you want to start collaborating, share ideas, projects, please email Janika. She's based in France, our secretary, or you can email me or Felix, who will speak after me. And again, we are very happy to establish collaborations. Thank you very much for your attention.
So thank you very much, Professor Friedman, for this very nice talk. And I hope that you will stay with us for this half an hour to listen to Professor Felix. Or maybe you are leaving, maybe we can send you some few questions.
I'll be here. I'm staying on, and we can discuss maybe both talks after Felix.
Thank you very much. So thank you, Professor Friedman, for this very nice and precise and clear talk. So I will call without any delay Professor Felix Wortlab. He is also from Charité Berlin, one of the eminent centers of MS and MOGAD management in Europe, not only in Germany, to talk about diagnostic and monitoring biomarkers in NMOSD and MOGAD. And I think we thank him also because he will also cover the emerging approaches that was dedicated to Professor Patrick Waters, who could not also be with us. The floor is yours, Professor Felix.
Thank you so much, dear Professor Najib Ghessani. So can you hear me in the audience?
Yes, we hear you.
Perfect. So yeah, first of all, thank you so much for the kind invitation. It's really a great pleasure to participate at the conference. And my name is Dr. Felix Worab. I'm working with Friedemann Paul at Charité Berlin as a neurologist. And we are mainly working with patients in neuroimmunology, so covering multiple sclerosis, but also NMOSD and MOGAD. And my first slide is actually showing you greetings from Berlin. The weather conditions here at the moment with heavy ice and snow. And unfortunately, I was sitting in one of those planes the day before. It was unable to start. So it's really a pity that we can't join you in person. But it was a great opportunity to follow the conference online and very insightful to learn about the current topics relevant in Africa, on brain health and neurology, and to get to learn from this a lot. So first of all, I want to talk a little bit about the three diseases, MS, NMOSD, and MOGAD, and then keep this quite short because you just heard this extensive presentation of Professor Friedemann Paul. Just wanted to summarize a little bit. So multiple sclerosis is, as you know, an autoimmune mediated disease of the central nervous system, and it's one of the most common neuroimmunological diseases. It's mainly a disease of the axons or of the myelin sheets, which involves inflammation, infiltration of immune cells that come from the periphery and lead to demyelination and associated disability. And as you can see on the bottom panel, this comes with a high burden of chronic disability over many years. And so it's very relevant for loss of quality of life in patients. And so they start subtle symptoms and usually having this relapsing course over the time, going to more and more burden of disability, from wheelchair-bound to bed-bound and very heavily sick conditions. So it's associated with some genetic factors, but also lifestyle and environmental factors are thought to be important. This is, for example, smoking, vitamin D deficiency, but also potentially environmental factors like pollution, etc. So this is a bit more speculative, but may play a role. And also, most importantly, the link to post-infections, so to germs, to infectious diseases, most prominently the Epstein-Barr virus infection, EBV, but potentially also other germs. So what is known about prevalence of multiple sclerosis? So it's one of, as I said, one of the most common neurological diseases. In this work, you can see that the data that is available, it's most common in US, Canada, and Europe. But as you see and I try to activate a pointer, if that's possible. Yeah. So if you look here at Africa, all these white spots is where we have no data available. So this is still unknown from epidemiological data. What's the prevalence in Africa? So neuromyelitis optica spectrum disorders and MOGAD. So you just heard about these two. Here's another overview. Target the same pathophysiology in terms of the target. So again, the myelin sheet of axonal part of the neuron is involved, but it has a different pathophysiology. So this is why it can resemble, from a clinical perspective, multiple sclerosis, but the disease mechanism is different, as you see here. So aquaporin 4 autoantibody-mediated NMOSD is thought to be a disease of the astrocyte, which is seen here, whereas MOGAD is considered a disease of the oligodendrocyte, which is seen here, as also Friedemann has just mentioned. So if you look at this chart comparing these three diseases, it's also interesting to look at ethnicity. And if you look here close at this table, you see that NMOSD is actually thought to or observed to be more prevalent in patients of African ancestry or African American patients. So another work is showing a world map on population-based studies in NMOSD. And if you have a closer look here, it actually shows that NMOSD is 2 to 3 times higher prevalence in patients of African ancestry. So this might indicate that there's actually a lot of underdiagnosed patients in, across Africa with NMOSD. And this is a nice picture which I took from one of Najib Kisani's publication from 2022, which shows the numbers of neurologists throughout African countries. And so this combination with the presumed underdiagnosis of NMOSD coming from epidemiological data and potentially also the limited access to neurological diagnosis really poses this question if we can help find more NMOSD patients in African countries to reduce chronic disease burden for these people. So how can we actually diagnose NMOSD and MOGAD? And you just heard, so in both diseases, autoantibodies play a huge role. This is for NMOSD. So here you can see in this picture here, the plasma cell, a little bit bigger here, produces aquaporin 4 specific IgG autoantibodies that actually are very closely associated with the disease and disease course. So these antibodies can be found in the serum. And so just a simple blood test would be in principle helpful to get more information on this diagnosis. But of course, as you also just heard, besides the clinical features, the MRI-based imaging features that are most characteristic for those diseases play a large role in diagnosing this disease. However, also which I learned during the last days, given the limited availability of MRI diagnostics in some African countries, this might be a large challenge to improve diagnostic availability. So the same is true for MOGAD. So also here, it's an autoantibody that can be identified in serum, so single blood test of these patients. And this has a little bit of a different pathophysiology, as you can see again here, where the oligodendrocytes are the main downstream target of the disease. And also here applies the same, that besides also clinical features, the MRI actually plays a crucial role for the disease. So given the best availability of diagnostic test I think that blood-based tests have a very high promise to reach better diagnostic coverage of those both diseases in also resource-restricted areas. And how is it actually done, the blood-based diagnostics? And here I want to cover for Professor Patrick Waters, who can't unfortunately join us today, but he provided kindly his slides that I will present you. So in the center here, you see the autoantibody. This can be the aquaporin 4 autoantibody or the MOC autoantibody for either diseases. And there are different test modalities out there that can actually quantify or identify this autoantibody. There is ELISA, which relies on an immobilized antigen. There is immunoblot or Western blot, which relies on a gel electrophoresis and a denatured protein that is then targeted by a secondary antibody. There's immunoprecipitation, where the antibody is specifically targeted using another antibody. And then there's importantly, there are cell-based assays where in hex cells, usually the antigen is produced and the autoantibody binds the antigen, and then it can be visualized in autofluorescent microscopy. So which is actually the best test to use for diagnostics, given this wide range of different tests? And so the principle is the same. So again, you see here is the autoantibody that is the target of the test, but the differences in the test methods is the antigen. So what is actually presented here. So the test substrate is different in each assay. So it can be aquaporin 4 or it can be MOG. So it looks a little bit different. And so if you then look how this antigen presents in the test, it shows beyond different modalities, it shows a different formation in a molecular perspective. So it's in some tests it's more native, and in other tests it's more denatured. And so you can see what this actually means for the background of the test and the meaningfulness. So what kind of this denatured protein actually does not really resemble the biology. So the best test is actually therefore a test that employs a native antigen, and that's mostly provided in cell-based assays, where cells produce those antigens and present them to the test. And so it usually works like this, that down here you have the antigen presenting cells, and then you can compare between a potentially patient sample, a blood sample, and a healthy person's blood sample. And if you apply this to the test, then in the patient sample there will be some antibody present that bind to the antigen. In the healthy sample there will no antibody be present and non-binding. And so then in the next step there comes the secondary antibody, and in the patient it binds to the autoantibody and sticks in the test, but in the healthy the secondary antibody disappears. And so this is what in the end, so this green text indicated, gives a signal and identifies this test as positive, whereas this test stays negative. So what's the difference between live and fixed cell-based assays? So the best test method is live cell-based assay. So in both assays, the antigen is transfected in hex cells and proteins are expressed on the surface. And then this is the live cell-based, so it is given directly for diagnostics and testing. In the fixed cell-based assay, actually there's an additional step where those cells are immobilized using formaldehyde dehydration or alcohols, and this actually destroys the cells and also alters the conformation, but is also feasible for a test. So these are in principle the two best test methods available for a simple blood test. So, but I also wanted to show you the comparison between those tests again. What's actually the best test for autoantibody detection? So indicated here, you have those test assays where the antigen is less native, and then going up to the most native protein antigen presentations, and those are the cell-based assays. So they are presumably the best tests available, and I can show you again here an example which shows the superiority of cell-based assays against ELISA, so those conventional tests. And here you see a result of at ELISA test on the one hand, and here on the other hand. And we don't know how to interpret it. This is just coming back from the lab, but this is now blinded. So if we unblind it and look what was actually tested, you can see here was tested patients with MOGAD, and here was tested patients with healthy blood. And so if you just look at these, it's difficult to really make a conclusion. But if you use for the same persons a live CBA, so a live cell-based assay, you see that the picture becomes much more clearer, that in the positives, you see a positive signal mostly, and in negative, a negative. So this is why the test of the live cell-based assay is really superior to the ELISA tests. So in the next chapter, I want to talk about monitoring biomarkers, but also potential diagnostic supporting biomarkers. The diagnosis supporting aspect is still a little bit hypothetical, but the monitoring biomarker aspect becomes much more clearer. So this is mainly GFAP. This is a protein biomarker that can also be measured in the blood. So again, potentially good accessibility in a simple blood test. It stands for glial fibrillary acidic protein, and it's actually a key biomarker of astroglial injury and activation. And as we have discussed, NMOSD is actually a disease of the astrocytes. So this protein is a very ideal biomarker since it shows high stability, and this has actually been shown also in a mummy that has been excavated in the UK, which was 2,600 years old. And even here, the GFAP protein could be specifically tested for this in this brain. So this makes it actually a very good target as a biomarker from the blood, since it's stable, has good properties, and it has also been tested already in MS, NMOSD, and MOGAD. And it shows here that it's an emerging blood biomarker for disease activity throughout these diseases, but specifically in NMOSD. So you can see, for example, here in progressive MS, we have higher serum values of GFAP. And also you can see here that in NMOSD, this is NMOSD, and here, these values, it's higher than in MOGAD and in healthy controls. And also the values, they correlate with the disease burden. So this indicates that it is a disease activity marker or disease burden marker. So the question is, how can we apply this really to give this accessibility using a single test, not in specialized centers? And for that, it would be most interesting to actually use a test that is derived from a single drop blood just from the finger. And for that, we tested a droplet-based dried plasma spot assay. So a single blood droplet is taken from the finger and applied to a sheet of paper. And then using a specialized testing system which can detect really low abundant proteins, we tested for this biomarker. So we posed the question, can we actually diagnose NMOSD or disease-related disease activity in a droplet of blood using this biomarker? And so we tested MOGAD, NMOSD, and MS patients against healthy blood donors. And here you can again see how it works. So you just take a single blood drop that patients can also do in principle themselves, applied to a filter paper. And this filter paper is then sent to the laboratory and measured. And this is what our results showed. So we compared the values that we have for the DPS, the dry plasma spot, against plasma, and we can see that it's actually nicely reflecting the same distribution, but also in a smaller scale, of course. And also the same is true that if you do a correlation analysis, you see that the values show perfect concordance between plasma and dry plasma. So it's technical feasible. And then also we looked at disease specificity, and this showed, you can see here in blue are the NMOSD patients, and you see that in plasma you have higher values, and the same applies for dry plasma. So you have in the mean higher values of GFAP and NMOSD than in the other diseases, which shows that it's strongly elevated in NMOSD using this droplet-based test. So looking at the diagnostic performance, it revealed that it actually has also a good diagnostic performance for NMOSD, this kind of test method. And additionally, it also reflects the disease burden measured by EDSS in patients, shown here. So we think this is a very promising test that can also be used in minimally invasive and also in structural poorer areas where you don't have access to MRI machines or specialized laboratories, because you only need to measure this dried blood test at the site and then send the dried blood cards to the laboratory. And additionally, the blood is quite stable on those cards at ambient temperature, at room temperature, and it doesn't have to be stored at, for example, -80 degrees or similar. So this is also another advantage of this test method. So, but how can we actually transfer the same principle to autoantibody testing, which are the most established diagnostic markers? And this is again a project collaboration with Patrick Waters that you see down here of University of Oxford. And they apply actually the same principle where you use a single drop blood blood droplet, sorry, and apply it to a filter card. And then this is stained using a specific test called the IDOT diagnostic test for autoantibody presence. And you see here it's compared to this cell-based assay. This is the cell-based assay and showing the fluorescence for the autoantibody identification, and it actually shows the same result on the filter paper. So this is an additional test which is also showing the same properties of good availability and a strong diagnostic impact potentially for patients. So to sum up, MS, NMOSD, MOGAD are very common, taken together, very common neurological diseases, whereas NMOSD and MOGAD are more rare. But all of them are probably strongly underdiagnosed in certain African countries. Especially for NMOSD, we know from epidemiological data that patients from African ancestry in other countries show double to 3 times higher prevalence of NMOSD. We have promising new home-based sampling tests in development via dry blood spots, and this is a promising avenue for diagnosis and also monitoring of these diseases. And as I stated, a possible alternative to expensive MRI machines based measurements. We have this for autoantibodies, aquaporin 4 and MOGAD, but also for monitoring markers as the GFAP, which is an osteocytopathy biomarker. And we I'm very interested in multicentric projects across Europe and Africa and collaborative opportunities. So if you're interested to take part in this kind of research and also the improving the diagnosis for patients, it would be very interesting to connect, and please keep in touch. Thank you very much for your attention. And here's my email address. So if you're interested, you can reach out by email and we can further discuss. So
Thank you
very much again, and have a great conference. Thank you.
Thank you very much, Dr. Felix, and thank you very much, Professor Friedman, for these very nice talks. So I think we can maybe take very few questions. I have two small questions for Professor Friedman, one, and second for you. So for Professor Friedman, I think he's still with us. So he mentioned that MOGAD, it has very extensive lesion on the optic nerve till the chiasma. Just want to understand why the prognosis is much better in MOGAD than in NMO and MS. Meanwhile, the lesion is more extensive in NMO regarding compared to NMO and MS. Professor Friedman.
Very good question. Yes, thank you. There is no very clear answer to date, but what the neuropathologists believe is that the remyelination capacity is a lot better in MOGAD. So there is data showing that the MOG autoantibody only targets the mature oligodendrocytes, but not the oligodendrocyte precursors. So the oligodendrocyte precursors can give rise to maturation of these precursors to fully ripe, fully mature oligodendrocytes. And there is no recovery capacity in NMOSD with regards to the astrocytes, the vast majority. That's in a nutshell what we currently believe. Thank you.
Thank you very much. And for Dr. Felix, one question before I have another question. For the essays, I think you talked about these dried blood spots. I think they are very practical because I remember in the last meeting of NMO MOGAD, we thought that we have a lot of very easy tools to be used, for example, in developing countries like in Africa. And as you know, we already published one paper about 620 cases of NMO in Africa. That was prevalence hospital-based study. And we have estimation of 54,000 cases of NMO in Africa. Meanwhile, 99% of them are underdiagnosed and undertreated, and patients are having blindness, paralysis, and so on, because not diagnosed and not treated. How could we implement? I think you talked about the project. That's very useful. We can discuss about this, how to use it in our African countries and in our future collaboration.
Yes, thank you so much. So exactly, given this background, this would be an ideal opportunity to collaborate across Europe and Africa to improve diagnostics for NMOSD patients. And we have currently this test in development. It shows great results in smaller sample size. And as we are making great progress in improving the stability and performance of this test, it would be very great to prospectively also collect dried blood spot samples from patients with the suspicion of NMOSD or MS spectrum to use these tests in African countries. So it would be a great opportunity to concretely collaborate on this project.
Thank you very much, Professor Felix. We are taking the last question before lunch. Professor Tahir.
To Professor Friedman, I would like to ask, is there any place for stem cell transplant in this condition? Because we know that in MS, there are some cases which responded to a stem cell transplant.
Thank you very much for that question. So there is one study published by a group at the Northwestern University in Chicago, United States, on stem cell transplantation NMOSD with quite good results. But the more promising avenue for the future is CAR T-cell therapy. Yeah. So there are various studies underway, and a few case reports have been published using off-the-shelf CD19 or CD20 CAR T-cells in China, a few in Europe. So this is the way to go, because in the end, it's probably less onerous, less burdensome for patients and caregivers, and probably even less risky. So I count on CAR T-cell therapy for these devastating autoimmune diseases in the future.
Thank you very much, Professor Felix, Professor Friedman, for your presentation. It's really interesting to hear about your presentation. This takes us to the first part of the day. I can see everybody is starving here. It's been a long day, but I hope you've learned something. You've learned something, and that the lesson learned today will impact your daily work. I will invite the first row, please, to come down and go to the canteen. The food is ready for lunch, and then the rest will follow. Thank you.
Thank you. Bye-bye. Enjoy the rest of the conference.
Thank you very much.
Bye.
Lunch.
Last night, everybody go to breakfast. Nothing to discuss, cause I did bring by fault. I'm doubt, only doubt. I'm a me, I be a doubt. I know go feed the girl, I know go feed the girl. It's out, mind that's with the talk. I put my life.
such a rush, my baby, slow down, come find your love. I'm hoping you see me, come serve it up. Love it when you stir it up. That body belong on TV. Oh, this feeling I can't hide. You're feeling up my mind, and I just don't know why.
couple more.
I've got a couple more years on you, babe, and that's all.
Saw your picture on a poster in a cafe out in Phoenix. Guess you're still the sweetheart of the rodeo. As for me and little Casey, we still make the circuit in a one-horse trailer and motorhome. And she still asks about you all the time, and I guess we never even cross your mind. But oh, sometimes I think about you and the way you used to ride down in your rhinestones and your sequins, with the sunlight on your hair. And oh, the crowd will always love you. As for me, I've come to know everything that glitters is not gold. Old Red, he's getting older, and last Saturday he stumbled. But you know I just can't bear to let him go. Little Casey, she's still growing, and she started asking questions, and there's certain things a man just does not know. Her birthday came and you never even called. I guess we never crossed your mind at all. But then sometimes I think about you and the way you used to ride down in your rhinestones and your sequins, with the sunlight on your hair. And oh, the crowd will always love you. But as for me, I've come to know everything that glitters is not gold. Everybody said you'd make it big someday, and I guess that we were only in your way. But someday I'm sure you're gonna know the cost. 'Cause for everything you win, there's something lost. But oh, sometimes I think about you and the way you used to ride down in diamonds and your sequins, with the sunlight on your hair, and oh, the crowd will always love you. As for me, I've come to know everything that glitters is not gold. Everything that glitters is not gold.
And the other one is the parents will create autism in the child. Sybil is smiling, but I'm telling you, this is very important. I'll tell you why. So coming to the neurodevelopmental disorder, and it affects three things mainly: communication, behavior, and social interaction. The child will not be social, he will not be playing with other kids. There will be failure of communication. The most difficult children to treat are the non-verbal ones, children who cannot talk. And so the ASD has a wide spectrum. You can have a non-verbal autism, you can have a verbal autism, and you can have an ASD, which is the most difficult thing to treat. One ASD child in the family can disrupt the whole furniture. So coming to the inheritance, it has a strong genetic contribution. We know there's little doubt that this is an inherited disorder. Genes are strongly or majorly affecting this disorder, because you know that when you have, for example, there's one child in the family, there are 20% more chances of having this disorder. So coming to the genetics of autism, so there is little doubt that it is inherited. So the heritability is 70 to 90%. It is the most, in fact, it is the most inherited disorder amongst the neurodevelopmental disorders. If you have an identical, if you have children in the family, for example, I've told you 20% chances will be there. And the important thing is that when you have an identical twin, the chances are 70 to 90%. You know the difference between an identical twin and a parental twin? Can anyone tell me? So the identical twin is when the egg splits into two. The same egg splits into two. So the chances are definitely much more, 70 to 90%. But when you have a parental thing where the eggs are different, the chances are much less. So this is about the inheritance of autism. So it is polygenic. So there are hundreds, thousands of genes that are affected. You cannot point out. It's not a monogenetic. It's polygenetic. And the types of inheritance are variants. And it can also be de novo mutation. You know what de novo mutation is? That the gene does not come from the parents. Gene environment interaction, this is very important. Why does it happen? We still do not know. We know that there is a definite genetic component to the neurodevelopmental disorder called autism, but we still do not know why it happens in certain children. So the thing is, if the child is predisposed to autism neurogenetically, and then the environmental toxins come in, there is a very high chance of him developing the disorder. Siblings, I've just talked about them. Parents may carry silent risk genes, just talked about them. Autism may occur without family history, the ones I've just talked about. So how do you diagnose? It is not really difficult to diagnose. Now let me tell you something. It is so important to diagnose a child with autism as early as possible. But do you think it's possible? But do you know you can even diagnose a smart mother who has already had children, not the first child, does know the milestones, and he or she will always know when the child is growing up. the response of the child at 6 months, even that can click. So if you have a smart mother who can diagnose that little infant, neonate actually, at 6 months, who's not responding, it is early and the best time to do it, because you do that, you will have definitely a brighter chance of intervening and treating. So there are different types of genetic predispositions: ADOS and ADIR, developmental history, genetic testing in selected area cases. So the core principles of management. How do you manage? It is one of the most difficult things to manage in childhood onset disorders. There is no cure, but effective support is important and is effective. Like I said, early intervention is the key to everything. Individual care is very important. You know what happens? I've been talking about it yesterday and day before, that the mother is a working mother. The father is working too. Who looks after the child? The mobile phones. And that is called virtual autism. So you are inducing a virtual autism in a child. This is called, you escape. Professor Najib is the luckier of the lot. We have it in Pakistan. It is not legal, but we have it. It is now legal in the United States. It's legal in Spain. It's legal in France. I don't know if it is. It's not. But CBD, I must tell you, CBD oil, good quality CBD oils are very effective in the hyperactive disorders in children. Thank you. Question or comment? When someone questions me on autism.
Hello. Thank you, Prof, for this nice talk. My question is about, because in our practice, we see a lot of patients with diagnosis of spectrum versus autism disease. And as you said, a lot of patients who's been in front of the TV using mobile phones with all those symptoms, but it's not autism. It's a problem of lack of training of their brain for speech and so on.
It is not that straightforward. The thing is, there are almost every child is fond of the mobile phone now. You know, a 4-month-old can also look at the mobile phone. It doesn't mean that that child is going to develop virtual autism. For some reason, some children get very close to the mobile phone and it is very addictive. That is where he loses touch with his parents. He's so fond of that mobile phone that the mother calls him and says, no. So for him, that mobile phone is the mother. But you're not home. The only thing that is at home is the mobile phone. So it is not a great practice, but people do it. So this type of induced autism is called the virtual autism. And because there is no neurodevelopmental trauma, there are much better chances of treating them. You have a question?
When you talk about the genetic aspects, is there...
Yes, it's working, it's working, it's working.
Is there a chromosome that you have identified, or genes? Like for Angelman syndrome, it's on a chromosome 15. We know it's on the long arm, the maternal long arm, that the UB3A enzyme ubiquitin is missing, and that's why I'm gonna have the
disease.
The disease, yes.
Yeah.
we talk a lot about the chromosome 15 for also autism. When we say it's the opposite, the UB3 is overactive.
Yeah, what I was trying to say was it's not monogenetic. That's the problem. That's why the experts on genes are struggling, because it's polygenetic. There are thousands of genes that seem to be involved. It's just not one chromosome or one gene. This is the problem with this. If you have more, then this is what I know. But I think this is because it's polygenic, it is more difficult to analyze.
Thank you very much,
Thank you.
Dr. Arif. I'm trying to work out what we call autism in Kinyarwanda. So, autism baita gute mu Kinyarwanda?
Do you know the prevalence of autism in Rwanda? Can anyone tell me?
No, there's not.
Can anyone tell me the?
There's no word.
Yes,
There's
I'll
no
tell
word.
you. I'll tell you. The prevalence of autism in Rwanda is 400 children to 100,000. 400 children to 100,000 children. That is what they found in Rwanda. So you can go and check up. This is what I've read. But you can always.
One more question.
One more question? Yes.
Hi, good evening. Okay, I have a question about autism, because for us we have
Take your mic closer.
For us we have a parent group. So sometimes you find out when we talk about what might be triggering the parent or what triggered the autism. Some of them tell us like they think that they took a lot of alcohol because when they were pregnant they were taking a lot of alcohol. And recently in 2024, I was diagnosed with ADHD, of which I'm still wondering what triggered it, because I was like, at this age, why should I have ADHD? It's still...
Yeah, I think what you're trying to say is that mothers with alcoholism are more prone to give life to children with autism. Is that what you're trying to say?
Yeah, that's what they were saying.
Are you trying to say that the child's brain is traumatized when an alcoholic mother gives birth to that child? I don't think there are very many studies, because there's so many mothers who are alcoholic and they give birth to normal children. Yeah, exactly. So it is polygenic and multifactorial. So we still do not know. We know there is a strong chance of inheriting the disease, but again, there's still a mystery, right? Thank you.
And again, why do we have adults? Like, why do adults like you just find yourself with ADHD when you're at your age, like from 30 to 40 something?
You mean adult onset autism?
Yeah, on ADHD, sorry.
That's a very good question. I personally believe that I'm sure there is some gene somewhere which is not as intense or strong, and that's why it's coming later. Yeah.
Thank you very much. Can I please thank Dr. Arif? Thank you very much. I think I've read about, like I said, my background is education, and we do have students who come presenting with other symptoms which are not ADHD, or students who are not on a spectrum. And when we ask the parents, when we've done investigation, it's alcohol fetal syndrome, when the parents have been drinking a lot. So alcohol fetal syndrome, they present with that, which is completely different to ADHD. I'm going to invite Dr. Where's my program? All right. So this is a case study from Burkina Faso, and the managing of neuromyelitis optica spectrum disorder. And this is going to be by Dr. Dabilgu. Please make him feel welcome. Bienvenue, monsieur. anglais? Anglais. Et puis vous allez faire un petit résumé à la fin.
Ok.
En français.
Hello everybody.
PowerPoint. Ah, ça c'est avancé et puis aller en arrière. Ça va mettre. Attendez un instant.
Où est-ce que ça passe?
Ça va venir, ça va venir.
Ah, ok, d'accord.
Introduisez-vous, ça va venir.
Okay, it is a pleasure for me to talk about neuromyelitis optica disorders in sub-Saharan Africa. Alors, in introduction, neuromyelitis optica spectrum disorders is a immune disorders of cerebral nervous system, typically characterized by recurrent episode of optica neuritis, longitudinal extensive transverse myelitis, and IRA post-senile syndrome. The 2015 revised international consensus criteria, the diagnostic of neuromyelitis spectrum disorder on the presence of core clinical characteristic and serum accompanying CAT autoantibodies. Previous studies on the incidence and prevalence of NMO septum disorders have demonstrated ethnic difference in NMO with higher rate in no Caucasian population than in Caucasian population. In 1971, in Nigeria, a single study in hospital of Ibadan reported 95 cases of NMO over 12 years of hospitalization admission. The earliest documented case in Africa was reported in South Africa by If and Mondley in 1973. The majority of cases reported in Africa come from North Africa. Few cases from Sub-Saharan Africa with case report and systematic review. And this is a systematic review with the study. In other studies, and for the current state of diagnosis of neuroimmunological disorders in Africa, and another study, 4 studies in epidemiologic studies in Africa. The prevalence of NMO in Sub-Saharan Africa, we see that the high prevalence was in Nigeria, and the little prevalence in Ethiopia. And numbers of cases were reported by Professor Kisani in 2022. And the case of South Africa represent 33%. All the studies was, the majority of studies were retrospective and hospitalized by studies. The number of cases, in Nigeria we have 95 cases, and in Uganda 1 cases. You can say that 60 countries have 1 cases. In the studies of Muzubire, this is a review of 19 records between 1971 to 2020 with 410 cases. West Africa, the cases from Senegal, Niger, and Nigeria with 120 cases. South Africa with 5 studies with 59 cases, and East Africa with 2 studies from Southern and Ethiopia with 35 cases. And if you see the region of Africa, West Africa is the first to have most of cases, and followed by South Africa and East Africa. Central Africa are less cases. I don't know, perhaps there are no epidemiological studies in Central Africa. And the number of new cases I was reported, I saw that in Ghana between 2022 and 2024, we have 7 cases. And in the studies of Kisani, we have 1 cases. In Mali, between 2014 and 2019, 20 cases. And the most cases was reported in South Africa with 39 cases. In Nigeria, since 1971, we are not epidemiological studies here. We are reported 3 studies in Nigeria after 1971. And the number of new cases reported was 103 cases. According to gender distribution, you can see that we have a predominance of female gender. It is really in everywhere in South Africa. Women was most affected with NMO with 82%. According to of gender distribution, you see that everywhere in Ivory Coast, always case is women, and Nigeria 78. According to the age distribution, the mean age of patient at diagnosis was 23 years. East Africa 28, West Africa 34, and South Africa 28. Burkina Faso, we have a case in children, 1 case with 6 years in Senegal, case with 7 female patients with mean age of 35 years. Latest onset after 50 years is frequent in Niger, in Côte d'Ivoire, Ivory Coast. And the current state of a diagnostic, it is a report of studies in Africa who include most nurses, neurologists, gastroenterologists, nurse, and plenty of general practitioners. You see that we have the diagnostic suspected NMO is between 1 and 5 cases in the past year of the studies, and most of confirmed NMO disorder is not enough. This is the clinical characteristics of NMO. In sub-Saharan Africa, we see optic neuritis is the first, and transverse myelitis. We have area porcina syndrome, symptomatic cerebral syndrome with typical brain lesion, and symptomatic narcolepsy or acute dyscephalic clinical syndrome. Area porcina, we have a few cases. 3 cases adults in Côte d'Ivoire, Nigeria, and Togo. 4 cases in Senegal. Cognitive disorders, we have depression and confusional syndrome. Access to MRI diagnosis, you see that in Burkina Faso, we have 6 MRI, and the cost in dollar is $80 for MRI cerebral and MRI spin cost. And the high cost is in South Africa. For the availability of immunoglobulin, aquaporin cat antibodies, autoantibodies, most of the country, in the 11 countries, the serum autoantibodies were available. and not available in 10 countries and not applicable in 10 countries. And so in some cases, the diagnostic you can do the diagnostic outside the country, outside. And the number of positive cases in Mali, we have 16 cases with 80%, Senegal 30%, Togo 83%, Sudan 74%, and Ethiopia 100%. Other investigation in animal disorder, we have a visual evoked potential is most due in Africa. It is most severe visual impairment than in multiple sclerosis. We have a cerebral spinal fluid analysis. The comorbidities, the first is HIV positive patient, and the second is TB, tuberculosis, and neurosyphilis, and myasthenia. The treatment of animal disorder, we have high dose corticosteroid, methylprednisolone, and plasmapheresis and immunoglobulin. You see that in Africa, the most treatment is high dose of corticosteroid. The long-term immunosuppression, we have oral prednisolone, not availability of preventive immunotherapy in Africa. Clinical outcome in most cases was not reported. No isolates of cases with relapse. In Sudan, who diagnosed 31 cases, complete improvement in 2 patients, and no improvement in 7 cases. In Senegal, we have the mortality is in 2 patients. After this review, you can say that all regions of Africa were concerned. Publication date varied between the 1971 to 22. Clinical syndrome was reported in most studies. Most studies published after 2024, okay, with aquaporin antibodies. Availability of MRI in most sub-African countries. Limitation, not population-based studies in South Africa. Few cases reported. Not availability of aquaporin cat and autoantibodies in most countries, and lack of financial resource. After the suggestion, increased availability of MRI. Second, training more neurologists who can diagnose neuroimmunological condition, and subdividing cost for serum antibodies testing, and increased availability of serum antibodies testing. Creating educational training for non-neurologist healthcare provider to improve timely referrals, developing national guidelines for diagnosis, and creating educational material for public, and creating African collaborating research group for animal disorders. In conclusion, NMO are present in sub-African Africa since 1971, but are likely to be underdiagnosed or misdiagnosed with improper management. The best approach is to continue education, awareness, and collaboration to close the wide gap in NMO spectrum disorders cases. is the birthplace in Ouagadougou, in Burkina Faso, the capital city. Thank you. By working together.
Thank you very much, Dr. Dabilgou. Est-ce que vous pouvez faire juste un tout petit résumé pour les francophones, juste
pour les francophones.
in.
Ok, c'est une étude, c'est le point sur les études qui ont été réalisées en Afrique subsaharienne sur la neuromyélite optique, qui est une maladie rare, qui est une maladie immunologique rare, qui est caractérisée par la neuropathie optique, l'atteinte, une myélite, également le syndrome de l'aréna posterior avec des vomissements incoercibles. Sur le plan de l'épidémiologie, on voit que les cas les plus, la prévalence la plus importante a été retrouvée au Nigeria, tandis que la plus faible prévalence a été retrouvée en Éthiopie. Parmi les signes les plus importants, on a la myélite optique, et la neuropathie optique et la myélite. Il existe un gap au niveau du diagnostic positif de la neuromyélite optique, notamment au niveau de l'imagerie médicale, notamment l'IRM qui n'est pas disponible dans tous les pays, et également au niveau du diagnostic biologique avec l'aquaporine 4 qui n'est pas disponible. Et quand on regarde, on voit que l'aquaporine 4 est disponible dans quelques pays. Et dans certains cas, cet examen peut être fait à l'extérieur, surtout dans certains pays où eux-mêmes ils peuvent disponibiliser, comme au niveau de l'Afrique du Sud. Il y a bien sûr des forces à travers ces études et des faiblesses. On voit qu'au Nigeria, depuis 1971, il semble qu'il n'y a pas d'études sur le plan épidémiologique, alors que beaucoup de cas ont été retrouvés en Afrique de l'Ouest, notamment dans presque tous les pays de l'Afrique de l'Ouest, il y a au moins un cas, tandis qu'en Afrique centrale, il n'y a pas beaucoup de cas. Donc ça, c'est les forces et les faiblesses. Maintenant, au niveau des recommandations ou suggestions, c'est selon, on peut dire que la première chose, c'est de subventionner le prix des examens complémentaires, notamment l'IRM cérébral et l'IRM médulaire, et favoriser la réalisation biologique de l'aquaporine 4 dans tous les pays africains. Également, il faut qu'il y ait une collaboration entre les différents pays, entre les différents neurologues, pour qu'on puisse faire des études épidémiologiques. Parce que quand on regarde les cas, c'est des cas cliniques, des séries de cas qu'on observe. Souvent même, on ne voit même pas les dates, la période de l'examen. Donc, il faut qu'on mette en place un groupe de recherche sur la neuromyélite optique. Merci beaucoup.
Merci. Mon fashion tumshimire Dr. Dibogu. Merci. You have a question? Docteur, attendez s'il vous plaît. Il y a juste une question. And Dr. Mark is going to make it quick.
Hello, doctor. Thanks a lot. Wonderful. Quick question. Sometimes I get referred transverse myelitis, and just for my own knowledge, these two conditions, optic neuritis and transverse myelitis, can they exist independently, or they always go together? And the second question is, if someone has already lost their vision, I don't know how worse, or already the vision is gone, and they found out that they have the transverse myelitis, is there any chance at all that the vision comes back, or that's it, it's gone once you've lost your vision? And then the same goes for the transverse myelitis, which causes the paralysis of the limbs. If you start the steroids and everything, is there a chance for recovery, or once it's gone, it's gone?
Alors, for the first question, the two clinical characteristics we've developed each other, differently. One clinical is if you have one clinical case for neuritis, you can say that you have NMO disorder with the presence of autoantibodies aquaporin cat. For the treatment of transverse myelitis, most cases you can use, the best treatment is immunoglobulin. Immunoglobulin, 1 gram per immunoglobulin G. But sometimes, if there are not money, you can use corticosteroid. Yeah. According to visual loss, for patients with transverse myelitis, I don't understand. S'il a perdu la vue, ça c'est définitif. Ouais.
Oh, good. Thank you very much. What's your presentation on? So take your time. To end this, let me see you. Touch session, end this. Just a quick question. Has anyone got coins? I don't want to be chitty. Coins. You have one coin? Can I have another coin? Anyone with another coin? Because we've been sitting for a bit. I just want to do a quick brain break. Quick brain break whilst my speaker gets ready. Now on the sticky chitty. Anyone with a coin? Any coin?
Yes.
Oh, there's a coin there. I promise I'll return this. I'm not gonna keep the coins. Oh, there's coins. I'm gonna give me one. All right. Can I please get the audience to be upstanding? Please stand up. We need to have a quick break. Please stand up, and we're gonna play a quick game. Standing up. All right, so this is the game. This game is called Heads and Tail. Can you touch your head? Show me your head, please. Touch your head. There you go. Touch your head. There you go. But because I have 2 coins, you have to touch your head with 2 hands. Okay? So these coins have got a head and a tail. Okay? So this is a guessing game. You have to guess. Okay? When I throw the coins in the air, is it going to be head and head, or is it gonna be head and tail? This is your tail. Okay, is it gonna be head and tail? Is it gonna be tail and tail? 2 tails, 2 heads, or head and tail? Are you ready? Okay, let's go. So make your prediction, make your choices now. You can choose now. Yes, yeah. So you have to be honest. When you don't get it right, you need to sit down. Okay. Okay. Yes, yes. No, you have to be correct on both. Okay, are you ready? So make your choices, whether you're choosing 2 heads, whether you're choosing 2 tails, or whether you're choosing a head and a tail. Are you ready? Okay. I need to decide which one is head and which one is tail. So, okay, here we go. Oops. So this one is a tail. This one here is a head. So if you choose a head and a tail, then you can stand up. Okay? Well, a few people still abstaining. Okay, another one. Are you ready? Make your choices. Is it head and head, or tail and tail, or head and tail? Ladies and gentlemen, please make a choice. Some people are undecisive. All right, ready? This one is, do not change last minute. I'm watching. So this one is tail, and this one is tail. So, so tail, you still, you're in it. Okay. How many? There are the young ladies still upstanding. The two ladies. All right. I can declare you winners. So let's see the winner between the two ladies. All right, make your choices, ladies. Are you ready? Oh. All right, I'll take that. I'll accept that. This one is a head. And the second coin is a head. Hey, we've got a winner. Thank you very much. So without any further ado, I would like to invite Dr. Rukundo, who is going to talk to us about ADHD, I believe, and part of it. So please make Dr. Rukundo feel welcome. Karibu. Yeah. Diego.
Nagiraga ngo mbaze about the presentation. There is he said that the pathology affected men affected females than male. Why? I see in the presentation the male is high, have high number. I want your answer or your clarification. Thank you.
Can I get him to answer after? It's due to hormones. Hormone
imisemburo
imisemburo
iterwa n'imisemburo
imisemburo y'abadamu n'iy'abagabo. Yeah. Over to you, Dr. Rukundo.
Okay, good afternoon again. So I'm back. So now I'm going to share with you about autism. And with autism, I go rapidly because Professor has mentioned about autism. So I will go direct with ADHD and PTSD. Yeah, please, can you give me the slide, please? So I see now we are very few than in the morning. Why? Yes, my name is there, and my contact, as we say in the morning, communication is very important. We are in a digital century. Better to stay in touch. For example, this presentation I can share with everyone who wants it after. Yes. So yeah. So autism in Africa. Professor has said a lot about particularly the genetic aspect, the inheritance. So we have award day, an international day for autism. It's 2nd April. So the exact prevalence of autism, ASD, is not accurately documented in Africa. So there is a need of research, but it is believed to be widespread and steadily increasing. More concerning is that there is poor knowledge about the condition in Africa. So for example, we can ask ourselves how many psychiatrists for children and adolescents we have in Africa. Very few. Here in Rwanda, even we don't have one. We had one, but he's not, okay, we had two, and one is still available in Rwanda. Yeah, autism spectrum disorder, or autism in common language, is a term used to describe a group of complex neurodevelopmental conditions that affect how the brain develops and works. It is marked by difficult social and behavioral interaction. So there are levels. So I said that I will not explain a lot about autism because Professor has explained it. So we have levels. There is level 1, level 2, which is mild, and we have the level 2, which is moderate. So the patient can do some activities, and we have the level which is severe. Here, the patient or the child cannot perform many activities. Yeah, so there are signs and symptoms. I remember the first time I met a child in Ndera hospital. I couldn't directly realize that it's a child who has autism. I remember he was kicking his head on the floor, but I said, okay, what is wrong with him? But this is a sign of some children who has autism. I used to see their front. I used to see their hands, because when they are angry, they do this, or they kick their front to the floor. So we can see delayed speech or lack of languages. Professor told us that if a parent is educated, she can observe and say, okay, my child is different. There is something. There is not the contact. The eye contact is not there. Because imagine when you are giving birth to your child and the child doesn't see you in the eyes. You have to be, to ask, why every time when I'm with my child, he or she can't see me in my eyes? So ASD is caused by a complex mix of factors. It is plurifactorial. So there is environment factors. There are also factors when a child is born, for example, in prematurity. I remember when I was working in Muhima Hospital, I met many children who were premature, and some of them are now autistic children. So in Africa, many strong cultural beliefs. So the beliefs is very important too. And misinformation are widespread about the cause of autism, leading to circumstances that pose a threat to autistic individuals and their families. It is important to know that the development of ASD is complex and involves both genetic and environmental factors. Yeah, so genetics here, genes are the tiny biological component that structure our bodies and are responsible for particular characteristics that make us unique from each other. You must know that even if your child has the diagnosis of autism, he or she is unique. You have to live with him or with her as a unique person. So when there is a problem, for example, a mutation in one or many of these genes, a lot of issues arise. Different types of genes mutation, like SUV420, you see it is written there, have been found to cause ASD. So here in Rwanda, we have a genetician, Professor Leon Mutesa. So clinicians who are here, you can send patients to Professor Mutesa for this analysis or these exams. So environment is there also. My colleagues mentions here about air pollution. So we have also to put effort in climate change and see how the atmosphere is. Because if the air is polluted, we can have problem. Women who are pregnant can have children who are not well. So risk factors are there for autism. So advanced parental age, you see on the point there. So it has been shown that parents having children are above 40 years of age in women and above 50 years in men increase the risk of bearing children with ASD. I don't know if Professor is agreeing with the age and autism, age of parents. So the mom is 45, for example, 45 years old, and his husband is 60. So there is a risk. Yes. So tuzajya tubyara hakiri kare. Siko bimeze, doctor. Nukubyara hakiri kare. Yeah. So exposure to steroids. So steroids also can be a cause of having a child with autism. So there is other, and this is very important. There is also other factors. Madame, je pense uri gukurikira. Pregnancy complications. Abadamu bafite diabete, for example. Uratwite ufite diabete. Uratwite ufite high blood pressure, ufite hypertension. Urumva diabete cyangwa hypertension ni maladie chronique, ni indwara y'igihe kirekire. Ubwayo itera stress. Means stress ufite ishobora kujya hehe? Ishobora kujya mu mwana. So we have other condition, early birth. I've said about prematurity. Prematurity is also a factor. Sex, tugeze kuri sex, also male children are said to have a higher risk of developing ASD. Abahungu bayigira benshi kuruta abakobwa. So numvise ngo uri muri groupe y'ababyeyi bafite autisme, sinzi niba murebye abana banyu musanga abahungu aribo benshi kuruta abakobwa. Siko bimeze? Oh yes, sorry. Oh, I was asking if you are in a group, you say that you are in a group WhatsApp of parents who have children who have autism. Have you observed that, male is higher than female? It's true? Okay. Yeah, so the diagnosis is possible to do the diagnosis. When you're a clinician, there are, some symptoms, and we have a classification called DSM-5 and ISD. There are symptoms we can find there and do the examination. So also, these are symptoms. I think I will go up because Professor has explained about all about deficits. Yeah, so screening, how to screen? I don't know if you see the image. What is that image? This is very important. Because a child, when he has this condition, this neurodevelopmental disorder, you as a doctor or a clinician, you have to ask for exams. What is this exam? What is this result? So this is a tool we don't have now in many countries in Africa. This is a PET scan. You know CT scan. You know MRI. But who knows PT scan here? Who? So very soon, and this is good for our country, we will have very soon a PET scan here in Rwanda. So it will be good because this is a tool that can help in the diagnosis of neurodevelopmental disorders. It helps, yes. Murabizi ko n'abanyarwanda baba bashaka ko umuntu aca mu cyuma, siko bimeze. Iyo umuntu aciye mu cyuma uburwayi bukaboneka birafasha. Hari ukuntu bifasha ku muntu ufite umurwayi. So treatment, also Professor told about it. There is ABA, there is CBT, there is educative training, and some technology, some devices that can help a child. Yeah, so it is important to start helping a child with autism as early as possible. Professor said about it, because their young brain is very ready to learn and grow during this time. Research has shown that when children around 1 year, 0.5 and 2 years, 0.5 years old begin therapy early, they can make big improvement in things like learning, adapting to daily life, and even in the way autism is affect them. Yeah, also support from parent and caregiver. That is me and my son. He's not an autistic, but here I want to tell you that we have to be close to our children. Professor talked about vulture autism. So better to, if you have a child who is an early age, under 5 years, please parent, be with your children. Be with them, show them love, show them examples. So autism is different, but not less. So there are some medication that can be given for some of them, like risperidone, aripiprazole, if the child are aggressive and in a severe situation. And of course, because they have some symptoms of depression, we can give them antidepressant. Yeah, so this is the PET scan. This is the PET scan. I was in India. That is where I saw for the first time a PET scan. So this is a machine that must be available in all Africa, in all of African countries, because it is very important. So challenge of AIDS in Africa, we need awareness and education. Diagnosis and assessment must be done by doctors. Evidence-based intervention, financial support is needed. And of course, stigma reduction, social inclusion, and family support. It is not easy to live with a child who have, autism, I know. So if it is even a child that you cannot live with a telephone or another person to take care of. Yeah, in conclusion, autism is a complex developmental disorder that presents significant challenges for affected individuals, families, and communities, especially where services are limited in African countries. So allow me to go directly on ADHD. There is someone who asked a question about ADHD. It is also a neurodevelopmental disorder. And we have patients here in Rwanda who have ADHD. So it means attention deficit hyperactivity disorder. That is ADHD. Yeah, so ADHD is a brain function developmental disorder that affects persons' ability to control attention, impulsivity, and activity levels. More people are now receiving an ADHD diagnosis. This is because previously it was only diagnosed in children. But now, more adults are seeking help for ADHD symptoms. Yes. And there is also more awareness and less stigma around this disorder. So some research suggests that increased screen time can cause symptoms similar to those in this disorder, but more research is needed to confirm this claim. Yeah, it doesn't work, the pointer. Can you help me with the pointer? Yes, so these are symptoms. We can have symptoms of inattentive presentation. So there is difficulty sustaining attention in task or play activities, frequent careless mistakes in work or other activities, forgetfulness in daily activities. So there is also hyperactivity or impulsive presentation. So there is fingering or tapping hands or feet, inability to stay seated in situation where it is expected, so the child is moving around. Even if you put him in a class, he cannot stay on a seat. So there is also impulsive actions without consideration of consequences. So we can also have a combination of presentation. Means the child is hyperactive and is inattentive. So causes here we have family history, genetic history, as Professor said. So we have neurobiology. That is why also we have to encourage young doctors to learn neurobiology. It is very important. So we also have environmental factors, exposure to prenatal, tobacco, smoke, premature birth, low birth weight, and exposure to lead. So there is also, this is also very important, childhood trauma. So the treatment is can be available. So here we must have a holistic approach. So we can have psychotherapy, We can have some medications. We can have parental training, very, very important, psycho-education of parents. So parental training on managing a child with an ADHD diagnosis, school support also. So we have also to teach, teachers, to be near teachers and say, okay, even if you have a child who is like this, know that you can help him. There is a way you can help him according to his situation. So in African context now, although at a very slow pace, ADHD is gradually becoming more understood as a condition rather than bad behavior in Africa. Most people with this disorder struggle in school and at work because they or those around them believe that these symptoms are poor character traits. It is important to share this information with family and a friend because there are ways to help a person either resolve or cope with ADHD to live a fulfilled and productive life. So if you or someone you know may be struggling with ADHD, please reach out to a professional for help. So now it's PTSD. So we are in Rwanda, 30 years after the genocide, we have many people who have had PTSD. And let me tell you that today, they don't have the PTSD as diagnosis. Today, many of them, they have bipolar disorder because with the past, the history they have had, and after that, they have a stressful life. Today, many of them are on bipolar disorder. So PTSD in Africa, not only in Rwanda, PTSD is a mental health condition triggered by experiencing or witnessing a traumatic event. This is very important. It can affect anyone, regardless of age, gender, or background, and has a significant impact on daily life and functioning. So here we have symptoms like flashback, disturbing dreams, avoidance if you saw someone who resembles people who were with you in a trauma event, or if it is a car, you met the same car, it becomes a problem. So there are also negative changes in thinking and mood. So I said that their mood is also affected. There is also changes in physical and emotional reactions. So causes are there. While PTSD can result from any traumatic experience, certain factors can increase vulnerability. Direct exposure to trauma, ongoing stress. I talk about stress. You have faced PTSD and now you are stressed. So historical and systemic trauma, occupational related risk, like first responders, military personnel, and healthcare workers. You saw war there on the picture. Here on the picture. So in how many countries today in Africa we have wars? So in those countries, there are many people who are facing traumatic event. Yeah, the treatment option also is available. So I remember when we started to help in 1995, 1996 and 7, people who were, who had this diagnosis. It was not easy. Even in the period of commemoration, it was not easy to manage these people who have, PTSD. But today it's different. Today it's different. There is resilience, and we say thanks to our government and our policy makers in Rwanda who have been there to help survivors of genocide. And today they can have work, they live, they can have children. Yeah, so psychotherapy is needed. We can use what we call CBT and what we call EMDR. So some practitioners, some psychologists are trained to do EMDR. And EMDR is helpful for people who have a PTSD. So there are also medication. As I said, many of them today, they are on a mood stabilizer. But if they are not in a condition that is bipolar disorder, if it's depression, you can give an antidepressant and something for anxiety. I used to give also a medication used in high blood pressure called propranolol. So 40 milligrams per day, it is helpful for people who had PTSD. Yeah, so support group and peer group is very important. Yeah, engaging with others who have experienced similar trauma can help. So I still have 7 second cases of PTSD are increasing and there is a need of research. So no health without mental health. Yoga or vodka, it's up to you to choose, please. And murakoze cyane.
Thank you very much. Thank you, thank you.
It was a speed, huh?
Yeah.
You can understand.
It's a race.
It's
You're
a race.
racing, yeah. Thank you so much.
But
for
I
your
think I was clear and explained well what I have to share with you. Thank you.
Absolutely, absolutely. Thank you very much. First question in terms of ADHD, is there a diagnostic tool for adults in Rwanda? Because we know adults can be diagnosed with ADHD.
Yes, we have for children, but if it's an adult, not yet. On my side, I have never met here in Rwanda a person who have the diagnosis.
Yeah.
It's most likely children.
Yeah.
Yes.
And on PTSD, I think like you alluded to the history of our country, the sad history of our country.
Yeah.
So I think when we're talking about the traumatic events that people might have witnessed,
yeah.
We just put trauma in one big umbrella.
Yes.
Right. But then under that big umbrella, then there's things,
Yeah,
conditions like
it's a lot.
PTSD
Yes.
and stuff like
Yes.
that. Just to finish as well, the peer support,
Group, yeah.
peer
Peer group
groups.
is very important.
Yeah.
Because when you are in a group and you realize that in the group people have faced the same situation as yours, it's easy to share how they manage their situation. And if you are not alone in that situation, somehow in the mind it helps you.
Yeah.
It helps you to say, okay, I'm with someone, another person also have faced this, and we don't have to think about the past. We have to see the future.
Yeah.
And that is what the government of Rwanda did.
Yeah.
To give work, to give occupation for people, tell them how they have to consult psychologists every day or once or twice per week.
Yeah.
And the way we also commemorate today is very different with the way we commemorated in the 90s.
Yes.
Or 2000. So this is a combination of knowledge, because Rwanda is not the first country that faced traumatic events.
Yeah.
We have, for example, in US,
Yes.
people who are veteran of America. They are the one who have experienced trauma event in wars. So here in Rwanda also we have learned about those countries, and today I think we're doing a great job for people who have faced trauma.
Thank you very much. Tumushimire Dr.
Welcome.
Rukundo. Thank you. Abantu mufite ibibazo mumbabarire. Mumbabarire tugiye gukomeza. Our last, but certainly not least speaker is Dr. Dawn, and she's going to talk to us about management of febrile convulsions. Thank you very much. Welcome.
Hi.
Going forward, and let's go backward.
Right. Right.
And we'll give you 20 minutes.
No problems. So first of all, I'd like to. Okay. Thanks for all that are staying here late and to hear the talk. Although I'm going to talk mainly not so much about the management of febrile seizures, because I'm really wanted to convey some things about certain syndromes that I think are important to recognize, and knowing that these can be implemented in the educational curriculum for neurology residents, and also to give certain perspectives. And I just want to make sure that this goes forward. So I think that one of the things I've learned is that there is a certain gap, which we will hopefully narrow in the next few years, as far as what is the burden of epilepsy in sub-Saharan Africa. And we do know that we do have in sub-Saharan Africa a lot of patients with epilepsy We have infections, perinatal insults, traumatic brain injury. And I think that I'm very happy that with a lot of your colleagues, and especially want to thank Professor Kisani, who's advocating for epilepsy surgery in Africa, because a lot of patients have a perinatal hypoxia, asphyxia, prolonged labor, and then they develop even many years later. The lucky ones develop hippocampal sclerosis, can be cured with epilepsy surgery. And I'm going to talk about some of the patients that are not as lucky. I came around this article, which was just published recently from South Africa, and basically stating that we do have strategies that we can look at and diagnose things. So how does febrile seizures go into this talk? One of the things that you can recognize is patients that have prolonged febrile seizures, and some of those patients actually have genetic abnormalities, and one of them is Dravet syndrome. And you can look and see, and Dravet syndrome and Lennox-Gastaut syndrome, and Lennox-Gastaut syndrome, just to tell you, is like a syndrome where it's a basket full of many etiologies. So think about all the perinatal hypoxias you have. You'll have a lot of patients with Dravet and a lot of patients with Lennox-Gastaut syndrome. We'll start talking about Dravet syndrome, and I know that genetic diagnosis may not be extremely common or easy to find here, but if you look at certain clinical syndromes, and you can see that there are many patients with Dravet that have here. I was given not a lot of time, but basically I think it's important to recognize that a lot of the first seizures are febrile seizures. And a lot of the patients initially have normal development. So a lot of them have a variety of development. But anytime you have a patient with prolonged febrile seizures, think about also Dravet. And Dravet is important. And it's important to recognize those syndromes before we have developmental slowing, because time is brain, time is development, and the earlier you institute treatment it's more important. Now we do know that there are adults with Dravet syndrome, just in case, for those of you that are adult neurologists and epileptologists, and sometimes you may have cognitive impairments, Parkinsonian features. I'm going to skip some of those slides. If you have access to genetic testing, but it's important to recognize you have limited resources. Which patients should I send for diagnosis? I'm not going to go too much into the NAV 1.1 and the GABA-ergic things, but you can look at what are the interrectal findings, and whether you look at EEG, because a lot of places do have access to EEG. So it's important to recognize that what are the high yield patterns, the febrile convulsions, which may be hemiclonic. So anytime you have a patient with hemiconvulsions, think about Dravet syndrome. And then I think I brought some examples of EEGs that you can see, and these are some of our patients. And then and this is like I looked for an ictal pattern, and this was like referenced here, and I can give the reference later, and you can see that there's a focal onset and then later followed by it. But if you have a normal EEG, that does not preclude Dravet syndrome, and the EEG is a tool and it shouldn't replace. And one thing I've learned coming to some and following some physicians here in Africa and certain other countries is that all of you have great clinical skills, great history taking, great physical diagnosis. And sometimes, I think that in the States, a lot of people are spoiled, and they forget about the importance of the history, physical, and all that. MRI is normal. So if you have hemiconvulsions and MRI, Due to lack of time, I'm going to skip, but I'm just giving you just classic vignettes. 9-month-old, prolonged febrile hemiclonic seizures, EG normal, MRI normal. Think about what things. Another key point is that I know that there's very limited anti-seizure medications and I'm so happy that due to the efforts of a lot of you, they've added to the necessary medication list levetiracetam from the WHO. But I think it's important to know most of the medications that are available in Africa are sodium channel blockers, and sodium channel blockers are going to make it worse. So if you see the seizures are getting worse with treatment, think about Dravet and think about what you can do. Again, other things are clobazam, which is frisium known, and I think that cannabidiol, whatever form you can have, we use like Epidiolex. And then in the US, we use a lot of fenfluramine, which is fen-phen, which used to be used for weight loss, but that requires monitoring with echo and looking at cardiac echo because there's pulmonary hypertension. I've only seen one case reported in the literature post-marketing, so the risk is very low. It's only because you use like 10% of the doses. Yesterday we had an excellent presentation about ketogenic diet, and there's some studies that report even 15 to 30% seizure freedom with ketogenic diet. If you can't do the regular ketogenic diet, which is a 4x1, you can also try modified Atkins diet, so don't despair. I love carbs too much. I don't think I'll be a very good candidate for a ketogenic diet. So I realize the importance. And this was like, there was like a symposium, so they put what is the management of in Dravet. But those patients have a lot of status epilepticus. I'm not going to go too much into stiripentol, which if you go to meetings. So this is an algorithm, but in some patients don't respond, and I don't exclude doing vagal nerve stimulation. I can't underestimate the importance of doing multidisciplinary care and having protocols and preventing all that. I think what's important with treatment is to know the patients develop, really pay attention. If you control the seizures, you may arrest the developmental delay, which I think is very, very important. And all of us have SUDEP patients, especially those that treat with epilepsy. So the risk of SUDEP is quite high in patients with Dravet. And that's something that like that. There are people who are companies, looking into antisense gene therapy, antisense oligonucleotides, and there's some trials looking in that direction. So if we go into Lennox-Gastaut, which is another type, and there are many patients with LGS, and those patients may start with infantile spasms and then progress. What's important is sometimes you may see in clinic a 10-year-old, 12-year-old, and you don't see the typical EG findings. What you see in those patients is just diffuse slowing, and that's something that is very important. So just because somebody stopped having infantile spasms does not mean that they don't have Lennox-Gastaut syndrome. Some patients have Dravet, some patients have metabolic reasons, so there's a big spectrum of those patients. And those patients may have tonic seizures, atonic seizures, atypical absence, generalized tonic-clonic, and they may also have a lot of times EG, which is not that clear. I just showed here the classical EG pictures for patients for LGS, which shows like a classical slow spike and wave of 2.5 hertz. You may see some paroxysmal fast activity during sleep. And that's like sometimes you can see. And then even in adults or in teenagers, you may still see sometimes during the seizures what you see here, a slow EG, high amplitude wave, and then an sort of what looks like an electrodecremental response or generalized paroxysmal fast activity. Again, clinical EG is important, and think about Dravet and think about what you can do. You don't have access to all the medications. And before I had access to a lot of the new medications, I used valproic acid and lamotrigine for a lot of the patients with Lennox-Gastaut. Now, we can also use cannabinoids, CBD, fenfluramine. It's also approved for it. And people are looking into other medications like cenobamate and other things. And the main marker of those clinical trials are drop attacks. Ketogenic diet is also effective in those patients, and especially with drop attacks. A lot of patients respond to vagus nerve stimulation. We do corpus callosotomy in some of those patients. For those of you who have access, you can either do it either with open resection or in some centers I know and advanced centers in Morocco, Egypt, South Africa. They also may have access to LIT, and you can do like non-invasively, because a lot of people, and especially people are afraid of doing surgery. There's the problem of cultural barriers and fear from surgery. So those are things to consider. We are doing in a lot of patients with LGS or LGS plus. We are targeting the central median nucleus of the thalamus and doing either deep brain stimulation or responsive neurostimulation with those patients. And we have data on like something 40, 50 patients, which is one of the largest groups available. And again, because initially I was talking to some students, just looking, drop attacks and cognitive, that's when, and a slow spike and wave, that's when you can do. And again, time is brain, early recognition, and even if you don't have access to anything, you have all the clinical skills better than a lot of the residents that I see back home, and you can not easily, but you can diagnose. But I think that what's important is SUDEP and developmental delay. So those are things that I think I'm going to go skip over this due to lack of time. And I just wanted to briefly, another syndrome that I think is clinically recognized. A lot of you see a lot of patients, and there's a big patient load with patients. So I did want you to recognize a syndrome that is maybe treated by steroids or other stuff or surgery and recognizing it, and you can recognize it clinically. It's not going to be, it says that TV will turn in 60 seconds, so I don't know if there is that because of the time or all that. So those patients have, what's unique about Rasmussen's encephalitis is that it is a chronic inflammatory focal encephalitis. So a lot of the patients will have focal status, but if you see a patient that comes to you with twitching, focal status, and you see hemiatrophy on one side, think about Rasmussen's. I'm not going to go too much into the immunopathogenesis, and we're talking about, cytotoxic CD8 and T cell. And there's a subset of patients that have glutamate receptor antibodies. But you may have either rare or more frequent things like that. So I just wanted to bring you some MRI examples from the patients that we've had at UCLA. And you can see here, what I want you to look is that you can start seeing, and this is an actual patient, a patient of mine, that you can actually start seeing atrophy, and the atrophy increases over the years. And look at this patient, and you can see that there is more unilateral involvement. So anytime you see a patient with focal features, focal seizures, even epilepsy partialis continua, and you see MRI that shows hemiatrophy, think about Rasmussen's. And this is an example of a patient that we treated, and you can see how this is a progressive disease. So I think recognizing it is very important. We have access to PET scans, so you can also see hypometabolism on the PET scan, which is unilateral, and this is like that. There is a differential diagnosis. You may have patients with perinatal strokes and that continue having seizures, focal cortical dysplasia, and encephalitis. I think, how much time do I have left? 0? I was given 20 minutes. Okay.
No, not that 20 minutes. Maybe another 5 or 10, 5 or 7 minutes.
Yeah, I was asking. I thought my time was up, so that's why I was running. So those patients, those patients, you have to consider, and why is early recognition important? Because some of those patients may respond surgically too. So you may do like a hemispherectomy on those patients, and the earlier you do the surgery, the better the outcome is. So if you do a hemispherectomy, obviously it depends on whether function moved to the other side or whether you will have some residual weakness. A lot of the patients that had surgery don't, some of them have some hemiparesis, but they're still able to walk. So it really depends. So don't exclude surgery for these particular patients. And then we reserve surgery of doing steroids. I don't know how much access there is to IVIG or to other immunotherapies, but thinking outside of the box when patients don't respond to medical management and considering immunotherapy is something that I think is important to consider. I did want to, if I have 5 minutes, I'd rather end it now to allow people to have questions, if there are any questions from the audience. I know it's late.
Thank you very much, Dr. Dawn. Just a couple of questions.
Yes.
Bear with me, bear with me. I'm bringing the mic.
I know that it is the second time I follow your treatment for autism, your specialties. But regard some cases we have here in Rwanda, we have frequent cases of Dravet syndrome and Lennox-Gastaut. And if you can give us at least something like a guideline on prescription based with the weight of the children, on combination of the drug, maybe if you can summarize to us some of the symptomatic, because sometimes they don't know exactly if it's it. Even they start treatment, they start as a general seizures. But normally, I know with Lennox, we can know exactly if it's it. I know some symptomatic. But for me, I think for the students or even people who are coming here, it's basically to teach them which particular drug can work for those children. Because majority of I have a case of a child born with a Dravet syndrome. I cannot speak the name for the data, but now she is 15. But we could not control it from 0 to 10, always hospitalized. So how can your association create a cloud, like a telehealth for those cases? We train intensively
like 5 students, but came with an answer that from even you don't have time, I know you are tired, we can have them take control of
Yeah, I'll be
national
happy to send either to give me who to send. I'll happy to send.
Excuse me, later come please.
I'll be happy to send.
Stand up, they are in the research. This question is for you. Come, pay attention.
I'll be happy to send.
Because they are
give
the
me
one,
a contact, and
yeah,
I'll be happy to send
give your
you.
contact, take the contact. It's about the lectures, how to train on Dravet syndrome, the symptomatic and how to treat it.
So, and obviously you have to remember not to give carbamazepine and not to give.
Yeah, not to give carbamazepine.
and
So
not to
the
give
guideline you'll
phenytoin
give nationally
and
will be
all
the
that.
one they're gonna follow because more children are dying for wrong prescription. Yes. Thank
I'll
you
give
so
you
much.
my email and send me, and I will give you guidelines. So what happens is that one of the reasons
Of course, they are not here to chat. They are
I'm
here
happy that you got levetiracetam and you
Please
have more
create a guideline, and that guideline try to insert it in the district hospital, every place, by explaining, because even this presentation, she can send it to you. You can review it. I know you're tired, sorry, but you can review it, and this can save thousands of patients. Thank you.
I'll be happy, but I think the take-home point for Dravet, no sodium channel blockers.
Thank you so much.
And you can start giving levetiracetam. And the other thing is like, certain things like Fintepla, you may not have access. Those have more strict upper limits of medications, like, you can 0.1 milligrams per kilograms twice a day, or 0.2 milligrams per kilogram twice a day, and a maximum up to 26 milligrams if you don't have serpentol. If you have serpentol, you have to give less. But you can give doses of levetiracetam. It has a very wide toxic therapeutic threshold, so I'm not afraid of giving high doses of levetiracetam in patients with Dravet. But I'll send, and clobazam, if you have access. I know I was surprised that Egypt is a very advanced in epilepsy, and I want them to have clobazam too, which, by the way, in India Frisium was like one of the first line medications for many years, even before the United States. But those are like common medications that I use in patients with Dravet syndrome, and I'm sure you have experience. I don't know, in Pakistan, which is also has very advanced. I don't know what.
Yeah, we have quite a few patients. I have quite a few patients with Lennox-Gastaut, and I must tell you, I've been struggling with them. And you know, and I know that there's no real treatment. Fenfluramine has come out, but it's still in the experimental stage. And the best thing that I'm doing is the CBD oil. I get a lot of CBD oil from the US, and okay, that's the only thing you can do.
I mean, the Dravet specific ones approved are Epidiolex, which is CBD, clobazam, which is Frisium. Those are officially reported, and Fintepla, which is fenfluramine, is also officially. I can give you a list of others that are on the list, with phase 3s.
Can you?
And and ketogenic diet is extremely important.
I think
extremely important, very important. Right, and I looked up ketogenic diet. Even though for those of you who don't like meat a lot or don't have access to meat, there are even vegan ketogenic diets. So if you enjoy steaks, meat, like some of my brothers or children, that's different.
Can you stress on rescue medicine, which are very important in these cases?
So rescue medication is very, very important. We use a lot of intranasal, and I know that may not have access in many countries, but we use either Valtoco, which is diazepam. We don't use as much Diastat, which was used before, and we also use midazolam, which is nasolam, which is manufactured by UCB still. I think it's still under patent from UCB. But you can use Bucolam, but I think it's very important to have rescue medications for those patients, especially Dravet, because they have a high incidence of status epilepticus. So I think having readily available rescue agents, you know, if you have Diastat, you know, just, you know, weight-based, that's fine. We don't use Diastat now as much because of our availability of intranasal, but I realize other places may not have it available. Yeah, the data on ketogenic diet is very impressive. I had one slide showing it. So some people claim 50%, 30%, you know, seizure freedom. And I'd like to thank, at ending, to thank you all for this wonderful opportunity to meet all of you. And I really believe that a lot of the young medical students and residents will have very successful careers and lead neurology in Africa.
Thank you very much, Dr. Dawn, for your insights. It's getting on. The day is getting a bit longer, and we have. It's already long. So thank you very much for your patience. We are going to have. Thank you. Just bear with me a minute. Mube muganira hagati yanyu ndaje mu minota ibi ngibi. Speak amongst yourselves, talk to the person next to you, and I'll be back in 2 minutes. Just a few, just need to sort out. Eric, screen hano yazimye. Reka mvuge ku bintu. One of the things that has come through the conference is making a distinction between the patient and the disease. Two separate things. The patient, and it's the same philosophy we use in education. There's the student and there's the behavior. When we're dealing with the students, we need to respect their dignity and their humanity. And so most of the time we have to actually make sure that we're discerning between the two. Eric, are you ready? All right. So we've got quick. Mugihe tugitegereje ko bari abantu bari barutegurira icyo kurya bitungana. tari utu presentation dutoya tugiye gukora turi recorded hanyuma tubone icyo kurya tunafunge ceremony zacu. So just two small presentation and Dr. Najib is going to introduce them. Thank you very much.
So I think to keep you very patient, we have only two remaining presentations. One from Professor Friedman, the one who presented for NMO in the morning. So he was supposed yesterday to talk about MS, if you remember when we had the electrical issue. So the presentation will be shared with you, and so it will be about clinical advances workshop in MS. I will just pass the slides. As you know, MS is a frequent disorder mainly in North Africa. NMO is in sub-Saharan Africa. So just very few background. And as you can see here, MS is affecting neurons rather than astrocytes for NMO and oligodendrocytes for MOGAD. Yeah. So to go quickly, and you see that there are some relations between MS and the Epstein-Barr virus. So a lot of patients affected with the viruses, and they developed MS later on. I think in Rwanda maybe you have few cases of MS, but in North Africa, Morocco, Tunisia, Algeria, we have many, many cases. So I think it's most predominant. So this relation has been demonstrated with viruses and MS. And also here you can see that there is a link between some even HLA gene interactions and also Epstein virus infections rather than the other infections. Here you can see the evolution of MS. So MS is a chronic disorder affecting white matter in central nervous system. So we can have a triggering period, and when we don't have any clinical signs, but if we do MRI, we can find abnormalities on white matter. After that, you can have relapses, so inflammation is starting. Then after that, you can have more relapses, and there is progressing of the disorder. And in last stage, after 15 years, you have the chronic period, and you have the secondary inflammation, and usually patients are having big handicap. Of course, it's inflammation and attacking neurons. Before we saw about NMO, which is attacking astrocytes, so it's directly interacting with neurons, and there are a lot of antibodies. And now with the research we discussed before, there are a lot of antibodies that we can look for, and that could be very helpful for diagnosis. Of course, there are a lot of antibodies, but some of them are very useful for diagnosis, and even for prognosis, where you have to check some microfilaments. And there are a lot of studies that you can see here. Of course, we will not go in detail in all these. By example, this glial CAM immunoglobulin superfamily with adhesion molecule expressed. These are highly sensitive in MS. A lot of other antibodies, glial CAM reactions. You can see that these are highly developed techniques to look for antibodies that we hope to be developed also in our continent. And there is an increase in the incidence. Of course, there are a lot of cases that we can diagnose. MS is affecting young people between 20 and 40 of age. And you can see that there is
Just hold it closer.
Okay. So there is also good relationship between obesity and MS, and also lack of vitamin D. I think we can also go quicker. This is also another study that showed an inverse association between Mediterranean diet and risk of multiple sclerosis. So that's also very interesting to know and to use this diet. Of course, to get a diet, Mediterranean diet, when you have olive oils, a lot of vegetables that we see here also in Rwanda, it's reducing the risk of MS. There is also risk with smoking and MS, so neuroinflammation, and also that's not only useless, risky for MS, but also for other disorders. Also the risk with vitamin D, so that's why we are dosing vitamin D, and whenever vitamin D is lower, we have to treat those patients. So the risk of vitamin D is mentioned on that study, and it's increasing the risk of having MS, not only having MS, but having severe form of MS. Of course, there are some prodromal signs of disease course, as you can see here. Smoldering inflammation is starting very low, as you can see on the pictures. After that, it can be chronic, and if patient is not treated in early stage, he can keep sequelae for all his life. And you see here the hypersignals in the white matter, and these are very specific of MS. They are closer to the ventricles, and in late stage you can see severe atrophy in the. So this part is about neurofilaments, so that's a very specific component that we can look in MS, neurofilament and GFAP. So these neurofilaments, now it's even easy to look for them in serum, not only in CSF. Before it was in CSF, and now it's a very, very sensitive marker, even in the blood. I think that can make easier the diagnosis of MS. And also there is the effect of immunotherapy on those neurofilaments that you can see here compared to some medications, teriflunomide and ofatumumab. You can see the big difference when you are treating and controlling with those biomarkers. The same thing, we can see the difference. So how the MRI is measuring the disease activity and progression. So that's also very interesting. You can see the lesions in white matter affecting the myelin, and you can see on the MRI, you have to inject the gadolinium to see if there is any enhancement that shows that there is inflammation. If it's the case, you have to treat with corticosteroids. Here we have the PIRA, the progression related with the disease, and you can see that the atrophy is very severe at later stage, especially in patients not treated at early time. So that's why we need early diagnosis. About strategies of treatment, we have a lot of strategies. Of course, we treat the onset of disease with corticosteroids, the relapses. After that, we treat the chronic disorder with the immunotherapy. And we have escalation of strategies. We have 3 levels. Disease-modifying therapy level 1, which is interferons. Level 2, by example, fingolimod, and level 3, it could be ocrelizumab and other medications. And there are a lot of arguments to early and be highly effective in those patients to avoid worsening and to avoid handicap in those patients. So that's what you call escalation therapy. And there are a lot of comorbidities, as you can see here, associated, of course, bad prognosis associated with high relapse rate, greater physical and cognitive impairment, and also at level of the health system and society. There is association with increase in the healthcare utilization, costs, and work impairments. You can also see here about the effect of vascular comorbidities on MRI in MS patients. So a lot of lesions in patients at chronic stage. So the future proteomics for diagnosis and monitoring MS. So that's the new era in MS. There are a lot of techniques how to better diagnose using very simple tools like blood samples, like neurofilaments in those patients, and how to monitor. So we can also see the mass spectroscopy. These are new techniques emerging, also the O-Link Explore, the SOMA scan, and a lot of other experimental studies. And also there are some emerging high throughput proteomics methods. I think that's the new evolution of new techniques in diagnosing and also looking for bad prognosis in these disorders, like this study published with liquid biopsy platform with atomic sensitivity and high multiplexing. Also a lot of studies about proteomics, blood-based biomarkers. I think biomarkers, they are really the new era You can see on the right a lot of biomarkers to measure the evolution of the disease, the bad prognosis. Proteomics also on brain health markers. You can see also with aging, a lot of biomarkers are also found, and they are also correlated in also these severe forms of MS. And of course, it's interesting neurons, you can see on the right, top right, related than astrocytes, which are not expressed. A global perspective on MS quickly, so just the differential diagnosis, suspected multiple sclerosis, global health considerations. We have lot of other disorders. I think that's very important in Africa when we have infections, when you have inflammatory disorders, we have not to confuse them with MS. You can see MS, for example, when you have lesions close to the ventricles, compared, for example, to the other disorders like infections, like abscesses, like inflammations, like systemic disorders, as you can see, for example, in the bottom pictures. So the scarcity of diagnosis equipment in low middle income countries, I think that's what we have to work on in developing countries like in Africa. So you can see here also the current state of diagnosis for neurological disorders in Africa. We have long, you see the upper middle income with green, it's only South Africa and Botswana, and the lower middle income and the lower income in blue. And you can see that we have a lot of discrepancies, and nearly only 2 countries in Africa are quite developed in diagnosing and proper management of MS. So just to go quickly, and thank you very much for this presentation, which is for Professor Friedman. And I think if we can have the second study, which is from Morocco, so that's from Germany, not my study, or just helping to, if we can have the second study quickly. So this second study that I know well, because it's done by one president of association, is how carers could help patients.
People, can you give the view? Can you give people a break? 10 minutes. 10 minutes to fix it. Sorry. Thank you very much, Dr. Najib. There is some refreshments in the room. You don't need to leave the room. Whilst you're having your refreshments, we'll have the band playing some music for us, and that will mean that we're starting the processions for the closing ceremony. So can I invite the people sitting in the front row? If you'd like a refreshment, there's a refreshment at the back. Please be upstanding if you would like a refreshment and have a refreshment. And then we start the processions for the closing ceremony. Abacuranga mucurange, twe turi tayari. First row.
Back to.
bivuga ngo mbirangize.
twaza ngo bagira ngo nibeze none twaza kuba duhiga ubukungu none twaza bakaduhiga ubutwari none twaza kuba duhiga uburanga none nk'uko twaza mwegere twaza mwajya twaza mwakwirwa ko twaza twambaye none twaza ngo twaza mwajya twaza mwakwirwa ko twaza twaheze none twaza ng'abakobwa b'abandi none twavuye ngo bagira ngo ni beza none twaza duteza amaboko none uko twaza mwegere twaza mwajya twaza mwakwirwa ko twaza twambaye none twaza ngo twaza mwajya twaza mwakwirwa ko twaza twahize none twaza n'ababyeyi b'abandi none yewe ngo bagira ngo ni beza none ko baduhiga uburanga none nk'uko twaza mwegere twaza mwajya twaza mwakwirwa ko twaza twambaye none twaza numvise ko biri imbere y'intore numve ko nderaritse ikemba n'igitwenge cy'urumenesha mama ndinda nanjye icyo ni igitaramo cy'inzovu ndende n'igisagara cy'ingabo nziza barara bibuka aho bavuka mama ndinda nanjye ndaje numvise ko biri imbere y'intore numve ko nderaritse ikemba n'igitwenge cy'urumenesha mama ndinda nanjye ngaho nimuhuze mutengere muze mutemba n'intege nkeya mutere imbabazi yego mama ikibyimba n'igitwenge cy'urumene yego mama nindana ahubwo rero izira ngo rwo byinshi nduza batanagesheje rw'amatero bategeye guhiga rwose meza twateranye n'inkubi tubamburiza ibiga ngo rwizira ngo rwo byinshi nduza batanagesheje ahubwo rero ihumura humeka kandi humura nshuti yanjye kandi humura nshuti nkunda ngaho rero muha nzajya inama nande noneho nzajya inama nziza n'abavandimwe n'inshuti nzajya inama nande nzagukura ishyanga mushyire inyuma y'ishyamba yewe mushyire mu bakwiye ngaho rero muha nzajya inama nande noneho nzajya inama nziza n'abavandimwe n'inshuti nzajya inama nande gira amata gira noneho nzajya inama nziza n'abavandimwe n'inshuti nzajya inama nande nzakwima amacunga yewe mwihera agashyushyu yewe muzimanire inturire maze nkwibutse n'utwejo ngaho rero nzajya inama nande noneho nzajya inama nziza n'abavandimwe n'inshuti nzajya inama nande uko amasaha atembera amatakika akazunguruka niko umutima ugutekereza watera intambwe inegeze kagwa ngo mama mama ndata mama shenge mama we nguwo kabawe ngwino mwihoreze nyabusa wishirira agahenda ndagukunda nawuryarya wemera yuko nkukunda pe mu mutima wanjye nturambirwa njyewe nzapfa nkwikundira mama mama ndata mama shenge mama we wokabaho we ngwino mwihoreze nyabusa wishirira agahinda ikandrogera indronge oya mama we wowaruka kumwega ndagukunda ni mamo ko nagukunze icyera oya mama we tukiri bato twembi ndagukunda ni mamo ko nagukunze rwinshi oya mama we tukiragira n'utunyana ndagukunda ni ndagukunda ishenge ndagukunda disi we ndagukunda ni mama ndagukunda ishenge ndagukunda disi we ndagukunda ni mama ahubwo rero bizira ngo rwambyinshi ntuzabatanagije nahita nje kumbwira iteye nyir'umuheta izirangwa rwo mwicuruza batenejeje na ndacacu kuko nitengera umuhero nari ndikabuye n'umusore nagira wese uzamumusha nko kuri mashaka ubwo n'ubukombe bw'inkotanyi arahira bw'amazu rw'amatere rwategeye guheka yego ugiye ujyo
tujye ku gicumbi igicaniro cyituze yewe muzaze tugaragare
nimuze
Mumamera Mashi. Can you please give them a round of applause for the entertainment? This is the last bit. We are on a home stretch now. Thank you very much to the band today for entertaining us. This is the last bit we're going to do, and we'll let you go home. We've held. It's been a very long day. I'm just waiting for the folks there to sit down. Thank you very much, everyone. It's really this gives me great pleasure to be standing up here. And in closing, I am a teacher. I need to remind people that I'm a teacher. I need complete silence. Eyes on me. Eyes on me, ladies and gentlemen. Eyes on me. No more talking. Thank you very much. I'm a principal. I'm a school principal, so I demand attention. Thank you very much. Jokes aside, it's great pleasure. Events of this magnitude, they can only happen, they can only be achieved when there's dedication, when there is passion, and when there is hard work. And I cannot, on behalf of the organizing committee, I cannot thank everyone, in the background who have made this a successful event. And we cannot thank you enough, and we cannot thank each and everyone who have dedicated themselves for this to take place, for this to happen. Otherwise, if I was to thank everyone, we'll be here until tomorrow morning, and that's the last thing you need. There are our sponsors who have made this happen, this event happen. There is the endorsement for the Ministry of Health. There is the catering staff for feeding us, sustaining us. There is the protocol services from UMST staff and students. And on behalf of the organizing committee of the 4th Africa Mena Brain Week, we say from the bottom of our hearts, thank you very much. Can you please give them a rendition? Having said that, there is a number of institutions and individuals who have gone above and beyond to make this happen, and would like to give them a token of appreciation for making this extraordinary event happen. In no particular order, I'd like to thank, on the organizing committee, would like to thank Professor and Chancellor Mamoun Humaida. Can you please come forward? And I would invite Najib to come. Thank you. I'd like to invite Professor Mamoun. Please come again. Najib. Najib has been, Professor Najib has been instrumental in this as well. So we want to show you an appreciation. So I'll ask Professor Mamoun to give it to him. Thank you very much. Shukran Jazeera. The next person on my list is Dr. Arthur Rukundo. Thank you for your contribution. Please come forward. Thank you very much. Mwakoze cyane, Dr. Rukundo. Next, we have Dr. Mark Nyanzu. Please come forward. Thank you for your contribution. Thank you, Dr. Mark. Yeah, thank you very much. Next, we have Dr. Stefan Jensen. Please come forward. Thank you for your contributions. Much appreciated. This next award, it's to someone who has worked really day and night, and we really appreciate your dedication and support over the course of these 4 days, and that's Dr. Susan Homaida. Please come forward. Next award is for the, I name him the infatigable. Is that a word? Infatigable. He never tires, and that's Professor Arif Hereka. Please come forward. Next award is for a man that I've only met him for a few days, and what strikes me is his dedication and his love for this continent, for these people, and that's Professor Abdullah Shehu. Please come forward. The next person, she's very dedicated, and if there was an award for advocacy, that will go to Chantal Kanyautembo. Thank you.
And also as local organizing committee, I think her and the next time it will be Tonga. The local organizing committee, they were the head of that organizing committee, working very hard.
And on that note, from Professor Najib, I would like to invite the CEO and Managing Director of Global South Connect, Mr. Tunga Abdul Ndame. Thank you. We would like to also invite Ndera Neuropsychiatric Teaching Hospital for their dedication and support and their drive in wanting their students, their medical students, to really have access to the best knowledge we have at the moment. And on behalf of Ndera Neuropsychiatric Teaching Hospital, I'd like to invite Dr. Rukundo to receive the award on behalf of Ndera. next award goes to Professor Dawn. Please come forward. And thank you for your contributions.
From the bottom of my heart, I want to extend my thanks and send you love. And we're all together in a common mission to have a cure for epilepsy and treat patients with epilepsy across the continent. And I see a lot of beautiful people here, excellent physicians, and I believe in the future, and I believe in the future of all of us together.
Thank you. Thank you very much for those kind words. I think that has been the trend. The Rwandan people say, "Umutwe umwe ntiwigira gutekereza, wigira gusara." And that's the common thread. You know, we can only work together. If you wanna go further, you need to work with other people. If we go alone, we're not gonna get anywhere. And that's the message there. Let's work together. And the next award is Dr. Dabilgou, s'il vous plaît, monsieur. All the way from Burkina Faso. The next award is for the man who has become my friend over the couple of days. And one thing that I see in him, he's got a lot of energy, and he's got a big heart, and that's Professor Dr. Osher. Please come forward. The next award is for Dr. Sally Shaban. Please come forward. All the way from Egypt. The next man, he's only my size, and I can say this because we're joking in the hallway. He says he can listen to me because I am as tall as he is. And that's Professor Tahir. Please come forward. The next award is, the English people say that if life gives you lemons, you make a lemonade. And there are people who have met adversities, and from those adversities, they have gone on to do things so that they can prevent or they can help other people. And that's the case of Madame Sibylle Bellamy. Please come forward. going to echo the words of Professor Dawn. We have a lot of dedicated physicians. We've come across them, and there are those physicians who are not in the limelight, but they're in the background just working hard and trying to make their patients' lives better. And that's the case of Dr. Olarinde. Please come forward. I think during the first day of the convention, the first day of the conference, we were inspired by listening to the presentation from the different students, medical students, and Professor Osher and Professor Abdullah Shehu. They selected the finalists, and the winner for that, we had 8 students who presented, and the winner is from UMST and is Miss Tamara Mukhtar. Maybe we can invite UMST staff to receive it on behalf of Tamara. Tamara is not here. Last, but certainly not least, not last yet. We have, obviously we won't hide away. There has been ups and downs during this conference, but we have people who choose to always see the glass half full, not half empty. And we thank everyone and each and every one of you to having that vision of the world. And I would like to invite Dr. Gokche to come and receive that.
And I think the last award will go to our friend, because he was very active and very dynamic, Mohammed. We thank him. And we are really impressed. Thank you very much. We are really impressed by your dynamism with from Rwanda, this UMST's faculty. So really, we are very happy to be with you this 3 days. I think the celebration will continue during the next Brain Weeks. I want just to announce that we had 4 candidates. It was Mali, Bamako for the 5th Brain Week, the 27th, 28th of February 2027, and 1st of March 2027. It was also Oman, Muscat, the capital of Oman. Professor from Oman could not be here, but Professor Suleimani is part of that committee. So they are just waiting for Ministry of Health to validate. Maybe it could be Oman, say 80%, then Bamako, but we have also Iraq. So we have between these 3 candidates. Of course, we removed Morocco because we just been in Morocco last time. Morocco maybe could come after 4 Brain Weeks. And inshallah, there will be a lot of good news for this event. We'll announce the next venue in coming weeks. And thank you very much. Shukran jazilan. See you very soon.
Yes. So this one, just one last announcement. Part of our conference, everyone is invited to Kigali Free Day, Kigali Car Free Day, and that's tomorrow at 7 o'clock at Kigali Convention Center, 7 a.m. If you would like a t-shirt, because we're going to go as a group, l'union fait la force. When we go together, we look much better. It's stronger. Together, stronger. So if you would like, if you're committing to coming tomorrow at 7 a.m. at Kigali Convention Center, there should be t-shirts. We can, yeah. Aline, find Aline. She can organize for you to have a t-shirt that you can wear tomorrow. And then we go and march strong. Also, yeah, there's also a last award. I don't think the person is here, but this is for Dr. Lucretia Long, who is here and has also contributed to this conference. So Dr. Lucretia Long. One last thing, Dr. Shehu, is an announcement you need to make about the poster. You too. Sheikh?
So there was a lot of oral presentations, posters submitted. They will be online, they will be put on the website, and Professor Sheikh and Shehu worked hard to select the best one.
Thanks very much, leaving this nice flavor to the last of this very impressive meeting and very nice venue, very courageous, generous people beyond anything. We reviewed around 14 abstracts, and we have selected the one from Morocco, which is for telemedicine and TIA. They are a group. I cannot name one person, but they are a group of them. The award will go to the Moroccan group of researchers who are young graduates, and they gave very comprehensive approach to use of telemedicine and AI for solving neurological problems in a resource limited environment. I think that deserves to be applauded by everybody if it comes from young. And we will give the award to Professor Najib. He will take it to them because they could not come to Rwanda. So you will give, where is the trophy? Okay, it's just symbolic. So the trophy goes to the Moroccan group, and Najib will take it to them. Thanks very much. Thank for everybody. Thanks for the lecture. Thank you very much.
Thank you very much. That concludes the fourth African Mena Brain Break. Before I do that, there are people who might be interested in receiving a certificate of attendance. You'll be emailed a questionnaire. You answer the questions, and then we'll email you the certificate of attendance digitally. So that's it. Thank you very much for being a great honors. Ciao. Thank you. Can we have the photographers? Can we have a group photo at the front?